All right, we have quorum, so we'll get underway. I declare open this hearing of the Senate Community Affairs References Committee's inquiry into excess mortality. I begin by acknowledging the traditional custodians of the land on which we meet and pay my respects to their elders past and present. I extend that respect to Aboriginal and Torres Strait Islander peoples who are here today. The committee will be conducting today's hearing in person and via video conference. In the room we are joined by myself, Senator Orman-Payne, Senator Babbitt, Senator Rennick, Senator Roberts, Senator Antic and Senator Canavan. Senator Pratt, Senator Kovacic, Senator Askew, Senator Hughes and Senator O'Sullivan are joining us via video conference. These are public proceedings being video streamed live via the Parliament's website, and a Hansard transcript is being made. I remind all senators that as we continue our work implementing the Set the Standard report, as Chair I will ensure that proceedings are conducted in an orderly, respectful and courteous way. I remind all witnesses that in giving evidence to the committee, they are protected by parliamentary privilege. It is unlawful for anyone to threaten or disadvantage a witness on account of evidence given to a committee, and such action may be treated by the Senate as a contempt. It is also a contempt to give false or misleading evidence. Witnesses also have a right to request to be heard in camera. If a witness objects to answering a question, they should state the ground upon which the objection is made, and the committee will determine whether it will insist on an answer having regard to the ground which is claimed. If the committee determines to insist on an answer, a witness may request that the answer be given in camera. I remind committee members and witnesses who are appearing via video conference and who are not speaking to please mute your microphones. I now welcome representatives from the Australian Bureau of Statistics. I understand that information on parliamentary privilege and the protection of witnesses giving evidence to Senate committees has been provided to you. The Senate has resolved that an officer of a department of the Commonwealth or of a state shall not be asked to give opinions on matters of policy and shall be given reasonable opportunity to refer questions asked of the officer to superior officers or a minister. This resolution does not preclude questions asking for explanations of policies or factual questions about when and how policies were adopted. Commonwealth officers appearing today are also reminded of the Senate order specifying the process by which a claim of public interest immunity should be raised. A copy of the order is available from the Secretariat. For the Hansard record, will you please state your full name and the capacity in which you appear today?
Good morning. I'm Bindi Kinderman, the General Manager of People and Place Statistics at the Australian Bureau of Statistics, and I'm joined by my colleague.
I'm Linda Fardell. I'm the Program Manager of Health and Aboriginal and Torres Strait Islander Statistics at the ABS.
And I'm Lauren Moran. I'm the Director of the Health and Vital Statistics section at the ABS.
Thank you. I now invite you to make a short opening statement, and at the conclusion of any remarks, I'll invite members of the committee to ask questions.
Thank you, Chair, and good morning, everybody. Thank you for the opportunity to make a brief opening statement. Throughout the pandemic, the ABS worked to support government and the community by providing accurate mortality data to inform health responses. When COVID-19 hit, it was clear that having frequent, timely information about people who died during the pandemic was important. We began intensifying our analysis of death registrations supplied by jurisdictional registries of births, deaths and marriages, and from June 2020 began releasing new death reports. Since 2021, the ABS has generated about 25 mortality-related outputs per year and has sought to improve the quality and the accuracy of those over time. Each product we produce serves a specific purpose. For example, the ABS provisional mortality reports released each month allow timely tracking of the number of deaths and highlight changes in patterns of mortality over time. While the 6 monthly excess mortality reports address the question whether there was more or less deaths occurring during the COVID-19 pandemic, compared to the number of deaths expected had the pandemic not occurred at all. To answer this question, we employ a model based on historical data to estimate patterns of mortality that would be expected to occur in the absence of a pandemic. Similar to health and statistical agencies internationally, the model accounts for important factors such as the growth and ageing of the population, both which would be expected to increase expected deaths, seasonality to understand in-year patterns, and longer-term trends such as improvements in healthcare that reduce expected deaths. The ABS statistics show that COVID-19 was the main cause of excess deaths in 2021, 2022 and up to August 2023, which is the latest data available. In 2020, COVID-19 ranked as the 38th leading cause of death in Australia. In 2021, it moved up to the 34th position, and by 2022, COVID-19 was the third leading cause of death, marking the first time in over 50 years that an infectious disease was in the top 5 causes of death in Australia. Before I finish, I did want to let the committee know that the statistics for the full calendar year of 2023 will be available for excess deaths on the 28th of this month, and statistics showing the relative ranking of COVID-19 and other causes of death for the calendar year 2023 will be available later this year in October. Thank you, and we're looking forward to assisting the committee with this inquiry.
Thank you very much. I'm actually going to go to Senator Louise Pratt to kick us off for questions this morning. Senator Pratt, you have the call.
Just unmute. Sorry, I've just reset up my display at home and I was having trouble finding the mute button. Can I begin by asking, in terms of public debate about excess mortality due to COVID vaccination versus COVID, when you look at the data that you've seen assessed in an Australian context, have you seen anything that would indicate elevated deaths attributable to causes such as the vaccine?
Thank you, Senator Pratt, for your question. I'll hand to Lauren Moran to respond.
Yeah, sure. So as part of the coding of causes of death, we analyse the death certificates and all of the coroner reports that come through. So any type of mention of COVID or a vaccine, that would get resolved individually by a team member. An autopsy would be looked at. So when we've had a look and done the analysis, the ABS, we've found that there were 16 deaths that were directly attributable to the vaccine. Now, we know that there's a lot of interest in vaccine-attributable injuries. So we've also had a look at deaths where perhaps the vaccine didn't directly cause death, but it may have exacerbated existing health conditions. And so there are 5 additional deaths where we have found that the doctor or the forensic pathologist has said that the vaccine did exacerbate existing health conditions. Then the other question that came up as part of this is, what else could we look for? So normally if there's a cause of death that's not reported on a death certificate, we would see strange increases in other causes of death. So things that we know to be a symptom of the vaccine, so myocarditis, pericarditis, thrombosis with thrombocytopenia syndrome, Guillain-Barré syndrome, I've just got a table that I've put together. Cerebral venous thrombosis and also anaphylaxis. So we've looked at all of those individually and there's no increases that are abnormal. we have looked at them as an underlying cause of death, but we've also had a look at them as other causes of death. So the most common causes of something like myocarditis or pericarditis are other viral pneumonias or ischemic heart disease. Cancer is also the main cause of things such as thrombosis and the thrombocytopenia. So there are legitimate causes being certified by the doctor on those certificates that do not indicate a vaccine. So while we can't measure directly what we don't have, there's no evidence of additional deaths due to the vaccine in the data set that we can see.
Is there evidence of a significant level of injury? Because we have a compensation scheme. We have a compensation scheme for vaccine injury. Many of the kinds of injuries you might acquire might also relate to injuries and side effects of having COVID itself. Is there anything in the data of interest there that you can tell us about?
So just to clarify with your question, Senator, so do you mean something such as myocarditis is also likely to be caused by COVID-19? Yes, that's correct. So when we looked at myocarditis, for example, there is an increase of myocarditis in 2022 as an associated cause of death, and that increase is generally attributed to COVID-19, so it has been certified by the doctor. We've also seen other things such as infections, secondary bacterial infections. We have seen this increase, and they have all been attributed to COVID by the doctor or the forensic pathologist if it's been referred to a coroner.
So you can see that in the data.
Yes,
Sorry,
that's
it's school
correct.
time. It's good. It's off to school time here this morning at my house. So that data is distinguishable. You can distinguish in that data the causes of the myocarditis in general terms. You might not be able to in all specific terms, but generally there'll be a doctor say, because in some cases people will have both had a vaccination and had COVID.
Yes.
In some cases they will have had a COVID and no vaccination, and in others they may even have had the vaccination and still got myocarditis. So I'm interested to know if you've seen any relevant data there.
Yep, so we haven't actually analysed deaths by vaccination status. We don't have that information on the death certificate. But I will say that the way the death certificate is set up in Australia is there's two parts in the death certificate. So people may be familiar with this, but I'll explain it just in case. So part one, we're asking the doctor to put a causal pathway to death. And part two, there are significant contributing conditions. So what we generally see is that the myocarditis has been certified as due to COVID-19 by the certifying practitioner. If the vaccine was a cause of the myocarditis, and we have had deaths where the vaccine has caused myocarditis, we would expect the medical practitioner to give their best medical opinion and to put on that death certificate that the myocarditis has been induced by the vaccine. But we haven't seen that in the overwhelming number of cases. What we have seen is that the myocarditis is generally attributed to COVID or other viral diseases. So it can be caused by a lot of different types of viral diseases, and that has been legitimately certified. So there is a legitimate pathway to death that we can see that's aside from the vaccine.
Last question, Senator Pratt.
Are there higher levels of myocarditis in the unvaccinated versus the vaccinated?
We haven't done any assessment. We don't have access to vaccination status on the death certificate data, so we haven't been able to look at that.
Thank you. And thank you, Chair. Thank you to the ABS for the excellent work that you do. That was really valuable.
Senator Kovasic.
Thank you, and thank you for your time this morning. And just to verify, just in your opening statement, you noted that the majority of excess deaths that have happened since 2021, and you noted 22-23, have actually been due to COVID. Is that correct?
Yes, that's correct, Senator.
Hello, I didn't get that. Sorry.
Sorry, yes, that's correct, Senator.
Thank you. Do you have any data that you're able to share or any insights that suggest that there have been an increase of deaths from preventable diseases?
Thank you for your question, Senator, and I'll pass again to Ms Moran.
Yes, certainly. So the definition of preventable diseases is quite broad, so maybe I'll just focus on a couple, if that's okay. That may be easier. So in particular, there's been a lot of looking at preventable diseases from trauma. So that includes road traffic accidents and suicide and also drug-induced deaths. So throughout the pandemic, there was a decrease for the first 2 years in some of those types of preventable deaths. That's certainly not to say that for something such as suicide, for example, that the pandemic didn't affect people. We know that the pandemic did have an effect on people's mental health, but overall there was a reduction in those. We did see a slight increase in 2022, but for the moment we haven't. It doesn't look like that statistically significant excess deaths. It looks like it's a return more to these usual patterns of excess mortality that we would see. There are some chronic diseases that are considered preventable in some cases as well, so some cancers are considered preventable. We haven't seen an increase in cancer at all. Of course, some screening programs, it may take a long time for somebody to die of cancer, so that's something that we would need to monitor on an ongoing basis, but that certainly hasn't been the case so far. There has been some excess mortality in deaths due to diabetes, and some deaths due to diabetes are also considered preventable. Some of these are likely still to be associated with COVID-19 itself. We know that people with diabetes can be highly immunocompromised and more susceptible to infections, but some of that may also be access to healthcare and management of healthcare during the pandemic and not accessing those services.
Thank you. And would that be sort of more concentrated again in regional areas where there is already, or does your data show that where there is already, a reduced accessibility to screening to GPs and to specialists?
So, Senator, we haven't done excess mortality per se by regional areas due to small data cells, but in general we do publish on remoteness areas in our annual publications, and in general preventable causes of death are higher in regional areas. All of those causes that I mentioned would have a higher standardised death rate in those areas, and some of that would be due to some of the healthcare access and other preventable health measures.
Thank you, and apologies, it appears there are some issues with my camera. It is on my end, so my apologies. I'll ask one more question and then pass on to the next person, Chair. How do we, or do you have any data, or have you collected any data in relation to how we compare to our international counterparts in relation to excess deaths and preventable diseases?
Again, I'll hand to Ms Moran.
Yeah, sure. So while we ourselves don't publish that information comparing to other countries, there has been a lot of work done. So the World Health Organization has taken on that role, and there's also been some work done by The Economist, who have put out some work comparing excess deaths compared to countries. So while we connect with our colleagues on methods and discussions, we don't actually publish their data.
Thank you. Thank you, Chair.
Thank you, Senator Kovacic. I'm going to go to Senator Rennick.
Yeah, hi guys, how are you going?
Oh, thank you.
So have you got medical qualifications, or are you just got statistical qualifications?
So statistical and psychology.
Psychology, okay, thank you. And I just want to confirm that the ABS hasn't run the deaths, compared it to any vaccination status whatsoever. So you can't say definitively whether or not people died from the vaccine or not, based on using statistics as opposed to... another?
Senator Rennick, so the ABS's role is to bring deep expertise to the coding of information that's supplied on the death registration certificates.
Sure.
So we have very deep expertise in doing that work. We apply a methodological, systematic approach that is objective, and then we compile the statistics, quality assure them, and publish them in detail on the ABS website.
Okay.
We don't have, to your question about the vaccine status,
Yep.
as Ms Moran's explained, the vaccine status is not available on the death certificate. However, the ABS also has the ability to link the Australian Immunisation Register, which has vaccine status, with death records, and that information has not been analysed by the ABS team, which was also part of your question, but is available for other researchers.
Is that something you'd consider doing, linking vaccination status to death data?
Our colleagues at AIHW who are appearing directly after us...
I'll take that up with them. Okay, that's fine. So then, have you got access to the primers that were used in the PCR tests to determine whether or not someone had COVID versus another form of a virus?
No, Senator.
So you're not sure of the accuracy when someone tested positive to COVID, how accurate that test was?
I'll just hand to Ms Moran to make sure that we're providing the most accurate information.
So we are asking doctors, though, Senator, for their best medical opinion, and for forensic pathologists for their best medical opinion. So we would expect that to be listed on the death certificate.
So I guess then, because normally if you want to find out if you've got a disease, you get a pathology test, you get a serology test where you go and get a blood test. And in COVID, we actually used a PCR test that had a very high cycle threshold of 40. And Anthony Fauci himself has said above 32, 33, the PCR test is very unreliable. And it's been found in a court in Europe that above 35, it's down to 3% reliability. So I guess I note here that you said you're interested in the quality and accuracy over time. Are you prepared to go... And I've asked the TGA and estimates for this PCR test for the primer so that I know the sequence and the length of the sequence used to determine whether or not someone had COVID or not. So is that something you're interested in looking at in order to get better quality control over whether or not someone had COVID versus other viruses?
So that would be out of the scope for the death certificate data.
Okay, so in regards to the doctor's certificate, when they ruled that COVID was the cause of death, had those doctors gone and performed pathology tests on those patients to determine whether or not there were the presence of the spike protein from the virus or there was a spike protein from the vaccine? Noting that the vaccine has a different spike protein to the actual virus. So I'm not sure if any of you have read the actual TGA non-clinical report on the vaccine, but it was codon optimised, so the mRNA in the vaccine was codon optimised to increase the presence, to output the expression of the actual spike protein. It also had replaced the normal natural pseudo-nucleotide, uridine, with a synthetic nucleotide called methyl pseudouridine. Now, that was designed to make the mRNA last longer, okay, which meant that it would produce more spike. As well as that, it also had an extension poly A tail at the end to make it last longer. So,
Rennie, I'm just conscious of time, and you only have about a minute left. So, just wondering if you
I'll keep. I've got this question. So there were no pathology tests performed by doctors to determine which spike protein was in the body at the time of death?
So that happens before we receive the death certificate data, so we're not aware of the testing.
Okay, so that's... okay, so I'll leave it at that. And then the last question, Chair. In your opening submission, you say ABS statistics show that COVID-19 was the main cause of excess deaths in 2021. Now, you've modelled excess deaths to be at 169,000, which was up from 5,000. It was actually up from 7,000 in 2020 on an actual basis and 5,000 from 2019, which was in excess population growth. But I'm interested in all-cause mortality, which anyone that looks at drug trials, they look at all-cause mortality because when originally they started drug trials back in the middle of the 20th century, they'd go, oh, this drug lowers, this particular symptom, but if the overall all-cause mortality increased, Right, that was an issue. So what we saw in 2021 was we had a jump of almost 10,000 deaths in the last 8 months, okay, and yet there are only 1,300 deaths from COVID in 2021. So while you may be correct with your model figure that COVID was the major increase in excess deaths, do you accept that it wasn't the major reason for the increase in actual all-cause mortality in 2021, given that there was a jump of almost 10,000 deaths?
Yeah, sure. There are a few reasons that we see that deaths increased in 2021. So some of that we believe is due to mortality displacement. So because deaths were so low in the winter period in 2020 and really so low to the end of the year, we feel that there was some catch-up. And
so that's 2,000. So deaths dropped by 2,000 in 2020 from 2019. So it's not 10,000, it was 2,000.
Yeah, that's right. And with the population increase, we still do expect some people to die. So I know that you just said that even though there looks to be flat or negative increase, the reason that the population dropped so much in 2021 because we had such a low migration rate, and so that affects the younger age groups where we really didn't expect people to die. So when we look at ages 65 and over and really get to those 85 and over groups, those population growths are still going up by 6% and even more because deaths were so low in 2020. So there is still some concept of that ageing population there. So we think that also attributed to some deaths. COVID also being some, and we would expect that there would be some issues with accessing healthcare, although our data can't measure that.
Yeah, and that's a fair point. I accept that, except that didn't show in the figures until May 2021. Cheers. Thanks, Chair.
Thanks, Senator Rennick. Senator Roberts.
Thank you, Chair. Thank you for appearing today. Many citizens, and now increasingly politicians, healthcare professionals, economists and journalists, are saying COVID measures were hugely expensive, at times needlessly cruel, callous and damaging of personal and societal health. Now, the ABS is the only agency that had the opportunity to provide near real-time data on those measures, yet chose instead to use long lag times and problematic baselines to rob decision-makers of the data governments needed to make informed and timely decisions. Why is that?
Senator Roberts, at every step of the way, the ABS has sought to be transparent and meet the needs of governments in the community. As I said in my opening statement, we immediately turned to intensifying our analysis of deaths data and moved from annual reporting that we'd done previously to a monthly cadence. We've always been motivated by the desire to produce the most accurate estimates possible, and we've published the data every month, allowing others to do their own analysis, including building their own models of excess mortality. Indeed, the Actuaries Institute is amongst a number of others who produce their own estimates of excess mortality.
Thank you. Before moving to mortality, I'll briefly raise birth rates because there's no reason why birth data can't be done in near real time. There's no excuse for the ABS's delays on birth data. There are no autopsies to hold up birth data, as there are in deaths. There's a reduction in births happening that's significant, and it's probably related to the increase in deaths, so it's relevant to this inquiry. The West Australian Government has just released its latest birth data that shows a continuing decline in live births of around 11%. This data is to March 31st, 2024, less than 3 months ago. New South Wales data showing a 12% decline in live births is now available to December 2023. Your latest Births in Australia report is to December 2022. Victoria released their latest death data in April for the period to the end of March 2024. They turn out that report in about 3 weeks from period end. Your provisional mortality data is now 4 months behind, and your cause of death data is 18 months behind. Why can't the ABS perform at the same level as the states when you simply repackage state data?
Senator, I'll hand to Ms Vardell.
Thanks, Senator Roberts, for your question. So our births data is based on the registration of births from the jurisdictional registries of births, deaths and marriages. So in the different states and territories, parents do have time to register the births after the birth. Obviously, The day of the birth isn't going to be the day that you rush out necessarily and do the paperwork. So there are lags associated with that. In terms of the timeliness of the data, we have quarterly information on birth numbers. That's published in our national, state and territory population publication each quarter. So we do have quarterly information.
Okay, thank you.
There's no evidence of any decline in births either associated with COVID.
Let's turn to mortality then. You have a data set that would cast light on where excess deaths are coming from. It's titled Causes of Death Australia Doctor Certified Death. This data was last updated in 2019. Is there another data set that has this same information in it?
Ms. Moran?
Yes, so Senator, we've replaced the doctor certified publication with the provisional mortality statistics. So the doctor certified used to come out annually, but the provisional mortality statistics comes out monthly.
What period does that latest causes of death data set cover?
The full annual data set?
Yes.
The full annual data set covers till the end of 2022.
2022, okay.
Yes.
It's now 2024, so you can see the problem. How can the Senate make decisions about the COVID response with data that's so out of date? And also, delays take significant bumps in the data that hide correlation out of view from the public.
Senator, I'm not sure that that we would take the same view of that. We've been producing, as I said, we moved quickly to producing monthly estimates. We have, I think, the latest estimates are for February, and we'll be releasing the estimates for March on the 28th of this month. In relation to the excess mortality estimates, while we publish them 6 monthly, they include data by week, by month, so that analysts can look at those detailed time periods. This is a significant investment in this area of statistics, which we haven't produced, this frequently in the past, and we've done that to, given the strong public interest and the importance of this issue.
Thank you. Could I turn to this graph? I can't remember which graph that number is, but I can table it if you like. It's in your submission.
Are you able to just refer everyone to the page number, Senator Roberts, in the submission?
I can't remember the page number in the submission. I've just got the graph separate, Chair. Yeah, there they are. It's graph 1 of your submission, sorry.
Yeah.
Got it?
Yes.
It uses a different way of showing the comparison between expected and actual deaths. In particular, you've changed the baseline and removed the range of death, replacing that with a simple 95% confidence interval, which is the blue area in the graph. In effect, this graph is saying excess deaths minus COVID deaths are almost entirely within the 95% confidence interval. So there's nothing to see here. Move on. The validity of your analysis, though, comes down to one thing, the validity of the baseline calculation. Have you brought along a clear and transparent explanation of that calculation for the committee, please, in writing? I'd like to see it step through. Can we get that on notice if you haven't got it?
Yeah, we can take that on.
This will be your last question, Senator Roberts.
Could you provide, on notice, thank you for that, Ms Moran, could you provide a detailed step-by-step explanation of the change of baseline and the calculation, along with reasons and justification, please?
Sure.
Thank you.
We can do that.
Senator Babbitt. Senator Canavan, do you have questions?
Yeah, I do have questions.
Oh,
I
okay.
was happy just to go.
Yeah.
Do you want me to? Oh, I'm happy to go at the end.
Yeah.
Ralph, go.
Thank you, Chair. Now, this question is to Ms Moran. Ms Moran, the ABS produced a cause of death certification paper to guide medical practitioners when completing cause of death certificates. For example, a patient receives a vaccination 28 days prior to death. Does this medical procedure have to be recorded on the death certificate?
The vaccination? So the vaccination, that would be up to hospital policies, whether that goes on a certificate or not. I would imagine that it wouldn't go on. So normally a health procedure should be certified if it's contributed to death.
Okay. So the ABS, you've reported 16 deaths with COVID vaccination as the underlying cause of death on the certificate. In the same way that you gave guidance material to medical practitioners on how to complete a death certificate in relation to COVID-19, did you give any guidance on how a vaccine-related death should be recorded? Any clear guidance?
No, Senator. So when we publish that certification guide, the vaccines weren't yet in use, so we didn't have any guidance. We are updating our certification guide this year, and that will have a lot more information in it around medical procedures.
Okay. What is the ICD-10 or ICD-11 code for vaccine-related deaths? That would be the International Classification of Disease.
Yep, so we use the 10th revision, so that's U12.9.
Yeah, U12.9. Okay. Next question would be, in your submission, you said that COVID-associated deaths were the main contributor to excess mortality. Now, we know that the ABS applies the international coding standards to produce cause of death statistics, and according to your submission, a COVID-19 associated death is defined as someone who has died either directly due to the virus or has died with the virus, end quote. Now, ABS data up to the 31st of Jan 2024 shows that over the past 4 years of the 17,276 deaths listed, just 702 or 4.06% of COVID-19's deaths had COVID-19 reported alone on their certificates. So 95.94% of all COVID deaths reported over the past 4 years had pre-existing chronic conditions and or listed COVID-19 as a causal sequence of events. Now, do you believe that COVID-19 deaths have been defined in an accurate manner, and is it fair that deaths with COVID-19 are lumped in with deaths from COVID-19?
Yeah, it's a good question, Senator. So the coding of COVID-19, well, the coding of deaths, to be quite honest, is really complex. So in Australia, we tend to have lots of diseases. On the medical certificate, we have an ageing population, and it's around sorting through what do we think has caused the death and led to death, and what are these contributing conditions. And in a lot of cases, it is multifactorial. So the reason that we decided to present both together is because it is complex, it's multifactorial. So the coding of COVID-19 is actually the same as how we would code influenza. So what we're looking for...
So it's treated the same way?
They're treated the same way. So what we're looking for is, did COVID cause a pathway leading to death? And so did it cause viral pneumonia? Did it cause acute respiratory distress syndrome? So the advice from the WHO, what they're saying to us is that, yes, people who have pre-existing health conditions are at higher risk of contracting COVID, but dementia, for example, can't actually cause COVID. It just puts you at higher risk. And because it is of such high public health interest, and this is the same with influenza, it is generally coded as the underlying cause of death.
All right, so on page 10 of your submission to the inquiry, you state that the median age of death for people recorded to have died from COVID or with COVID is 87.3 years. Is this correct?
Yes, that's correct.
What is the current average life expectancy in our country?
It's just, actually, I would have to take that on notice. I feel
I've got it here.
Oh, you've got it there?
So the average life expectancy at birth for a male is 81.2 years, and for a female, 85.3. Do you find it strange that somebody with COVID lives longer on average than someone that doesn't have COVID?
So, Senator, that's the life expectancy of birth. So when looking at the life tables, we normally would take the age that you're alive at that time, and every single age has some life expectancy attached to it. And so that the median age is a little bit different to life expectancy at birth.
Next question. Now, I just find it very strange, obviously, that, if someone has COVID-19, they're living on average roughly about the same time as someone that doesn't have COVID-19. So why have we seen, materially higher excess mortality in, all age groups? Can you tell me that?
So most excess...
So it's killing the elderly, but it's also killing kids.
So most excess mortality is in people aged over 65. So when we have a look at those excess mortality figures by age that we've put in our submission, the numbers of death are really, really small. And so there would be some natural variation in that figure as well. The assumptions around people dying at younger ages are also a little bit different, because that's where we're seeing more injuries and external causes of death. And the other point I'll just make is that there are still younger people with cancer, with disability, who are really prone to contracting COVID, and we have seen that they've had some severe comorbidities even in the younger age groups.
Okay, last question. A spokesperson for the Actuaries Institute COVID Mortality Working Group once said that mortality doesn't usually vary by more than 1 or 2%. The Actuaries Institute, who are notably, unfortunately, absent today and rely on your data for their analysis, reported that excess mortality was at least 5% in all the age groups in 2022, with the excess for females being higher than for males. Recently, the Actuaries Institute has released analysis which shows that young women are dying at an exceptionally high rate. 0 to 44-year-old females are dying at a rate 8% above expected in 2023 and 10% above expected in 2022. For men in the same age category, the variance was -2% and 2%. Are you aware of this alarming spike? Why are young women dying?
I haven't seen the actuaries' report, so I would want to have a look at that. When looking at our own data set, as I mentioned, we're still seeing COVID-19 in younger age groups. They're much smaller numbers as well, so when we're saying 10%, that may be 50 compared to thousands in an older group. And there may also be some issues with injury, because we've seen some changes over that pandemic period where we saw really low injury and then some return to some of those pre-pandemic periods. But I would need to look much closer at that as well.
Thank you.
Senator Canavan.
Thank you. I wanted to also go to the Actuaries Institute submission to this inquiry, and I'm hoping that a page from that can be tabled, although we're just having to get that printed. I just wanted to check, though, the ABS hasn't calculated excess mortality rates at a cause of death level?
Not yet, no.
Okay. Are you planning to do that?
Yes, we are planning to do that.
And so I think I heard you mention earlier that on your, I suppose, look at the statistics, there's not an abnormal increase in heart condition mortality?
There is higher than expected deaths due to ischemic heart disease.
Right. Okay, so I might have misinterpreted that. I mean, so the Actuaries Institute, they have done that. They've done the using their own methodology in excess mortality at cause of death, and their stats show that how do you pronounce it? Ischemic.
Yep, ischemic heart disease.
Ischemic heart disease. It was 14% higher in 2022 than expected.
Yes.
Other cardiac conditions were 11% higher than expected, and there was also excess of deaths in other years. I mean, that to me, admittedly, the Actuaries Institute goes on to say, well, look, that they don't think that's due to vaccines, but that is one of the potential side effects of vaccines, and we are seeing an excess mortality in those very conditions. Am I wrong about that then?
It is ischemic heart disease isn't a side effect of the vaccine. So where we would see the side effects is in that other cardiac conditions.
Okay, well,
so
they're 11% higher.
Yeah, so they are a little bit higher as well. So we have had a quick look at that, and so the reason that we haven't published yet, I'll just mention first, is because we still don't have the coroner data, and so the younger cohorts are more likely to be certified by a coroner. So we would really like that complete data set. But the actuaries have put out some great analysis just using the doctor-certified deaths. What we do find for all of those diseases is that COVID is a really common comorbidity. In seasons where we have high influenza, we often have excess mortality due to ischemic heart disease and also due to some of these other cardiac conditions, because viral illnesses in general can have some effect on circulatory health. So we still think that COVID and probably effects of long COVID, we would have expected probably to see a little bit more long COVID certified on a death certificate, and we haven't seen that yet. So we still do think that COVID is probably a key contributor to some of that heart disease excess mortality.
I mean, I wish I could share your confidence, but I mean, it just strikes me we're not really approaching this in a very scientific way. We're wanting to prove that the vaccines are okay, and we're grabbing on anything that we can when there's at least some correlation here. There might be an issue, and I find it hard to believe that you could dismiss vaccine at this stage as a potential cause. Now, that doesn't mean it might be. I just wanted to go. I mean, you do mention in your submission the vaccination status is available through the Australian Immunisation Register, and you have a link between the register and ABS datasets?
Yes, I might pass over. Do you mind if could I just mention, Senator, we're certainly not dismissing vaccines and their effect in the cause of death data set. We've taken it very,
so it's
very
still an
seriously.
open question whether vaccines
it's something that we will continue, and we'll keep looking at it.
Well, can I just clarify that? Is it an open question that vaccines could be playing a role to cause the significant excess mortality we're seeing?
So it's been put up, and what we've been looking at is that our statement is we've found no evidence that vaccine have caused excess mortality.
So it's still an open question, though, then?
It's something that we've monitored.
All right. Just on my question about the linkage
Last
between
question, Senator.
Yes.
I have one more. I've only got two questions here.
Yes, so our colleagues at the AIHW are expecting to look at that very question.
Okay.
The primary research question that the ABS has been trying to answer is, has there been fewer or more deaths during the pandemic than there would have been if the pandemic hadn't occurred? I think the question that AIHW will be able to do with the linked data is is there more or less deaths from people that received the vaccine during the pandemic?
That's the question.
Versus, yes,
okay,
which is
so
the
that
question.
can happen. Fantastic, thank you. Just my last question. I suppose the other way to put this is we were told in the last few years that we had to lock down and take vaccines to improve our health, and whatever way you cut it, more people are dying now than before that advice and before those things were put into place. So while you're saying there's no evidence that the COVID vaccine has caused the excess mortality, is there any evidence that the COVID vaccine has actually reduced mortality? Because that was the intent of the vaccine. The vaccine was intended to reduce mortality than it otherwise would have been. Has there evidence of that?
Senator, I think that question probably goes beyond our expertise and is best directed to the Department of Health and could potentially be answered by this research that the AIHW are looking at doing that would tell us was there more or less people who received the vaccine during the pandemic who died compared to those who didn't receive the vaccine.
Chair, excuse me, I have more questions. I'm happy to put them on notice, including one question about the timely correlation between a large increase in deaths in Queensland before they got COVID in Queensland, but immediately after the vaccine injury. So I'd like to ask that question, but I'll put that and several others on notice to you.
Thank you, Chair. All right, thanks everyone. Thank you very much for your evidence today. The committee will report to the Senate on the 31st of August 2024 and request that answers to questions taken on notice are provided to the committee secretariat by close of business on Friday 21 June 2024. Thank you very much.
Thank you.
Now going to call the Australian Institute of Health and Welfare. I now welcome representatives from the Australian Institute of Health and Welfare. Thank you very much for appearing before the committee today. The Senate has resolved that an officer of a department of the Commonwealth or of a state shall not be asked to give opinions on matters of policy and shall be given reasonable opportunity to refer questions asked of the officer to superior officers or to a minister. This resolution does not preclude questions asking for explanations of policies or factual questions about when and how policies were adopted. If a witness objects to answering a question, they should state the ground upon which the objection is made, and the committee will determine whether it will insist on an answer having regard to the ground on which it is claimed. If the committee determines to insist on an answer, a witness may request that the answer be given in camera. Commonwealth officers appearing today are also reminded of the Senate order specifying the process by which a claim of public interest immunity should be raised, and a copy of the order is available from the Secretariat. For the Hansard record, would you please state your full names and the capacity in which you're appearing today?
Yes, my name is Louise Gates. I'm the Group Head of the Population Health Group at the Australian Institute of Health and Welfare.
Hi, I'm Michelle Gawley and I head the Burden of Disease and Mortality Unit at the Australian Institute of Health and Welfare.
Thank you. I now invite you to make a short opening statement, and at the conclusion of any remarks I'll invite members of the committee to ask questions.
Thank you, Chair, and good morning, everyone. Thank you for the opportunity to make a brief opening statement. So the Australian Institute of Health and Welfare is the leading health and welfare statistics agency in Australia. The AIHW produces a number of reports each year using mortality data from the National Mortality Database, which includes records of all deaths registered in Australia, both doctor and coroner certified, from 1964. The cause of death data is sourced from the Registrar of Births, Deaths and Marriages in each state and territory, the National Coronial Information System, and compiled and coded by the ABS, who we just heard from. The latest year of mortality data currently included is 2022. In addition to mortality, the AIHW routinely monitors health service use, such as hospitalisations, emergency department presentations by particular conditions, as well as cancer screening rate. AIHW also publishes regular data on suicide and self-harm in Australia from a range of sources, including death registrations, suicide registers established in most states and territories, ambulance attendances, and intentional self-harm hospitalisations. The ABS also produces annual burden of disease estimates for Australia as part of the Australian Burden of Disease Study. This includes trends in years of life lost due to premature mortality, also referred to as fatal burden, which is another measure that can be used to look at mortality outcomes in the population. Age-standardised rates of years of life lost have typically been declining in Australia. The AIHW has also recently developed the COVID Register, a linked data asset that can be used to develop a deeper level of understanding of the health and mortality outcomes and health service use of COVID cases and the population generally. There are a number of projects underway by the AIHW and external researchers which will provide further information on the extent to which deaths are associated with a prior COVID-19 diagnosis and how this may differ by population groups and vaccination status, and to look at other research questions such as the occurrence of post-acute outcomes such as cardiovascular disease following COVID-19. We're happy to take any questions and look forward to assisting the committee with this inquiry.
Thank you very much. I'm going to go to Senator Pratt.
Thank you very much, Chair. You indicated that there's further work in relation to vaccination status and COVID death. I can see very clearly in information that you've presented and from the ABS, the peak in deaths from the Omicron wave, which was statistically significant. How might vaccination status, what are you looking for it to tell us in the context of looking at excess mortality?
Thank you, Senator. Sorry, just confirming you had finished. Yeah, so I guess we're looking generally at what are the health outcomes for people following a COVID diagnosis by population groups and vaccination status. So it won't be just deaths, we'll be looking at severity of outcomes as measured by hospitalisations, ICU and other things like that, and what is the increased risk of severe outcomes depending on different factors, which might include hospitalisation, which might include things such as vaccination status, it might include access to services, it might include other comorbidities.
And will that data also look at the vaccinated who didn't have COVID at the time of death?
Yeah, so all of those factors will be incorporated in the models that we'll be looking at.
Okay, and so how are you putting those models together? What kind of things will underpin that? Will it depend on what kind of vaccination they had, I'm presuming you'll factor in age, ethnicity, socioeconomic status, other comorbidities, etc.?
That's right, yes. So the project's in its early stages and we're working with expert advisors in this space to determine exactly what variables we have, what variables we can use that are consistent across the different data sets from the different jurisdictions to determine what we will look at in the model.
That's good. In the context, for example, some people were told not to get vaccinated because of underlying conditions. How do we assess whether that was helpful or meaningful in the context of overall health outcomes for those people, for example?
So we won't have any information in our data set to understand what advice people were given or at what stage necessarily they had underlying conditions.
Okay, and you'll be doing this using all of the national data, or will you dig down into little pockets of it, or create a model and look at it and then expand it out to national data?
So the data set that we have has data from the majority of states and territories, and we will be using that entire data set.
Okay, so and how far progressed? Have you actually started crunching any of the numbers inside that yet?
I think the analysis is very preliminary at this stage.
Okay, so there's nothing that you would be confident to put on record at this stage about that preliminary analysis. When might we expect?
So we're expecting things from early analysis in December 2024.
Okay, so we will know those. And will that be a final analysis, or will it be just trends, or will there be further areas to look at based on what you might find?
Yeah, so I'm imagining that there will be a lot of possible analysis that could be done at this stage, and so rather than waiting until we've done all of it, we thought we'd release something in December 2024, but we expect more analysis to continue into next year.
Excellent. Thank you, Chair.
Thank you. Senator Kovacic.
Thank you, and thank you for your evidence. Are you able to tell the committee a little bit about the COVID-19 register project and the anticipated outcomes of integrating this data with the existing national health data assets?
Yep. So the COVID-19 register includes a range of data sets, including the Australian Immunisation Register, admitted patients' data from the states and territories. The deaths data that we've been talking about includes COVID notifications up until the end of 2022. And a few other data sets that we have, as you mentioned, as part of our National Health Data Hub, which include, for example, residential aged care.
Thank you. In your submission, you talk about the years of life lost estimates based on actual deaths registered for each of the COVID years. To assess whether there's been an excess fatal burden as a result of the pandemic and how this compares to excess deaths in Australia, can you explain what you anticipate that this work will provide in terms of value and additional information that we don't currently have?
Thank you, Senator. I'll pass that to Ms Gourley.
Yep, sure. So just to explain a little bit about what years of life lost are and the measure. So it looks at the age at which people are dying and it compares that against a standard life expectancy. And it gives a really good overall summary measure in the population in terms of at what ages people are dying and overall how many years of life are being lost. And what we have done so far in our burden of disease study in 2022 and 2023, we've moved to a model where we've been now casting our burden of disease estimates to the year of publication to make them more timely and policy relevant. However, we acknowledge that COVID-19 having happened in that time span, it'd be really important to actually use the actual number of recorded deaths in those years to fully account for the actual estimate of years of life lost in those years. So what we can do now at the Institute, we now have 2022 deaths data. We don't yet have a full set of 2023 data. So we can calculate years of life lost to look at how that compares to the excess burden. What we would expect is that because years of life lost, you gain more years of life lost at younger ages because you're comparing that to what your expected life expectancy would be, and less years of life lost at the older ages. We think that because a lot of the excess burden is shown to happen in those older age groups, there probably won't be as much excess in terms of fatal burden, years of life lost, as we've seen in excess mortality. But until we do that analysis, we won't be able to fully quantify that. But we think it is another alternate measure to excess deaths because it does bring in that age factor.
Thank you. Yeah, that makes sense. Could you also tell me, based on the information that you have at hand or the research that you're doing, has there been an increase in deaths from preventable diseases, particularly since 2021?
So we've had a look at some of the leading causes of death in Australia, and we've found that coronary heart disease, or also known as ischemic heart disease, which we've talked a little bit about already, did show some increases in the age standardised rate of mortality in 21 and again in 2022. Similarly for diabetes, so that's also shown an increase in 21 and 22. And I think we've talked already, ABS has talked a lot about potential drivers of that, so one being the comorbidities with COVID, so we know there is some association with COVID-19 and those particular diseases, but also another factor is potentially delays and disruptions in terms of health services during the early part of the pandemic. And my colleague Louise here has some data on that if that's of interest. That might be relevant.
Yes, it is actually. I'd be very keen to hear that. Thank you.
Thank you, Senator. So, yeah, we have some evidence, particularly around cardiovascular disease and some of the procedures and the differences that we saw in 2020 compared to 2019. So for coronary angiographies fell by around 27% from 11,600 in March 2020 to 8,400 in April 2020, and percutaneous coronary interventions also fell during that period, but by a lesser amount. It is worth pointing out that most of that was just in that very narrow period of time in 2020, and there was no difference during the rest of the pandemic.
Thank you. And just very quickly, my final question. Do you guys have any data or information, and I asked the ABS this as well, about how we compare to our international counterparts in relation to deaths from preventable diseases?
Yes, so we've looked at what's been released internationally, so we haven't obviously produced the estimates ourselves, but we've looked at Our World in Data, which is one of the key global sources of excess mortality, and we've published some of that data in some of our flagship reports, such as Australia's Health, Australia's Welfare, and in some of our health expenditure reports. So I don't have the exact figures at hand, but I think the key message from that is that compared to other high-income countries, Australia has very low excess mortality compared to places like the USA, many of the European countries.
Thank you. Thank you, Chair.
Senator Rennick.
Cheers. Thanks, Chair. Hi, guys. Look, I just want to follow up my colleague Senator Canavan's remarks on not approaching this in a very scientific way. A lot of the data we've been given so far is basically numbers on a spreadsheet where it's been crunched in various methods, and being an accountant myself, I know that you get garbage in, you get garbage out. I come back to this report, the COVID-19 register, that is actually looking at people diagnosed with COVID-19. Are you testing the quality of the diagnostic tool that was used to diagnose people with COVID-19. So both the PCR test and the actual rat tests, noting that 9,970,000 people were diagnosed with COVID from January 22 through to September 22. So most of these people that caught COVID were already vaccinated. So can these diagnostic tools distinguish whether or not someone had a condition because of the vaccine or because of the virus?
So just to clarify, I think I'm understanding your question correctly. What we have is the information that comes from the notifiable disease system, which comes from the different information systems in each of the states and territories as to whether people were diagnosed with COVID or not. That will be one source of information we'll be looking at. We will also be looking at information as to whether they were hospitalised for COVID or in intensive care for COVID.
Okay, so you're just taking it at face value that if they're diagnosed with COVID, that's it. So when you say you're going to engage other external researchers, will these people be performing pathology tests and histology tests to actually look at the tissue sample of the people that passed away to look for the presence of either vaccine spike protein, vaccine lipids, and whether or not their condition was caused by the codon optimisation or the transfection that the lipids caused?
No, there will be no research like that.
Okay, because that's what I mean by the scientific research, is that we actually got someone, with a biochemistry background, or a pathologist or histologist, who are actually looking at tissue samples.
No, so we'll be looking at the information that's already been provided.
So that'll be provided via a spreadsheet or, a database, numbers on a database, rather than the actual content or the actual pathology tests or anything like that.
That's correct.
Will you be getting autopsy reports to validate the numbers that you've been given on the spreadsheets?
No.
Okay, thank you. That's all. Thank you, Chair.
Thank you, Senator Rennick. Senator O'Sullivan. I might go to Senator Canavan and we'll come back to Senator O'Sullivan if he is online.
I suppose I might just quickly, you mentioned the Our World in Data database. I'm just wondering, have you had a chance to look at the British Medical Journal Public Health article published, I think, only in the last month or so? It's titled Excess Mortality Across Countries in the Western World Since the COVID-19 Pandemic, and it used Our World in Data information for its study. Have you seen that paper?
I have briefly looked at it.
Right,
yeah.
okay. I mean, well, it does note that there's no consensus about the concerns that mRNA might have caused more harm than initially forecast. They show that there's something like 2 million excess deaths across the world at the moment for 2021 and 2022. I don't think they analysed 23 in this publication yet. And so, I mean, I suppose the problem I'm still getting to here is we don't seem to have good answers about why so many people are dying. I mean, 2 million extra people dying, it's not that dissimilar to COVID itself. It's up there with some of the biggest pandemics in the world. And I suppose, do you have any particular insights for us about why we're seeing so many excess deaths in Australia and around the world?
Not in addition to what we've already mentioned.
I might just, turning away from the vaccines, I know it's going to take a lot of attention, but I'm interested in this diabetes issue. And it comes back to the point that I and Senator Rennick have made here, that we seem to default back into, OK, the diabetes is possibly because of COVID. But I would have thought it is a shocking increase in diabetes in your submission. But why aren't we looking or potentially saying that perhaps diabetes could be a function of the lockdown rules we had in place and the closing of gyms? And, I mean, there's a lot of things that happened during the pandemic which seem strange to me from a health perspective. Is that something you think could be a cause of increased diabetes, that people haven't perhaps been living as healthy as they could have because they were told to by governments to stay inside? And
so we haven't looked at any associations with increases in diabetes at this stage?
Yes, but you did say earlier that you think possibly the diabetes increases because of COVID-19 comorbidities.
But we haven't got any evidence to look at whether particular people.
But how could you conclude to us, to our Senate committee, that possibly this increase was due to COVID-19 status or
Yeah, I think
infection.
what we're saying
But
is
you
it's
can't
possibly
make a
one of the
supposition on the
factors.
lockdown rules. It seems that you're applying an unequal test to the impacts of COVID-19 relative to the impacts of government policy.
Yes, I think what we're saying is it's quite multifaceted. So the comorbidities is just one potential driver, but there's many others. So there's people not potentially going and seeking health services because of issues around the lockdowns and scared of getting COVID
I just
itself.
didn't hear lockdowns earlier, but I reckon...
As well as the risk factors. AIHW does have a lot of data on changes over time in health risk factors, so physical activity levels, overweight and obesity, etc. And we know that those risk factors are strongly linked to diabetes. So we could look at it from that perspective in terms of whether there's been any changes over time.
And then dementia's another one here. I'm no expert on this issue, but I'm happy to take advice. I would have thought being separated from loved ones, being isolated and alone is probably not the best health outcomes for dementia patients. Would that be a reasonable supposition?
So I guess that's a supposition. We haven't done anything in relation to that.
Yeah, still waiting a proper inquiry into all of this. I was also taken by there's a different topic, but the rates of suicide, a terrible thing that happens. And I remember at the start of the pandemic there was a lot of concern that due to the pandemic and the isolation, it would cause potentially an increase in suicide. But that hasn't happened, has it? Seemingly, we didn't see an increase in
no,
suicide.
that's correct. We did not see that.
Right. Okay. I couldn't see, and admittedly, I only get time to flick through submissions of these things. But have you got statistics? Oh, you do have. Sorry, cardiovascular disease. I see. That's what I wanted to come back to. This that. It seems like we've had a very, very big decrease in cardiovascular disease, like consistent decrease over many decades. Have you ever looked into the reasons behind that? I mean, why have we improved so well? But this is pre-pandemic on cardiovascular disease.
Not specifically, but I guess there's been a range of things that cover both reduction in risk factors, such as tobacco smoking, as well as improvement of services and clinical approaches.
Okay. But this decline just stopped in the pandemic then, and has slightly increased. Is that right in terms of cardiovascular deaths? Okay. And look, finally, just going back to I think some other questions before, this study you're going to be able to do. I just want to be clear. You're going to be able to link someone's immunisation status with the mortality figures.
Correct.
Are you going to be able to look at the number of vaccines they took, or just this?
We have the number of vaccines, the date the vaccine was taken.
Okay, great. And I suppose one issue I'm thinking, just before I looked at this in detail, is most people in Australia got the vaccine. So how are you going to, if you like, separate out a placebo group, a group of people who haven't got the vaccine, if you like? There's only a very, very small number of Australians, a small percentage that didn't get the vaccine. So how are you going to be able to assess the impact of the vaccine in that environment where most people got it?
So this work's being done in conjunction with the National Centre for Immunisation Research, and so they'll be looking at things like date at which the vaccine was taken and time after that and that sort of thing.
It's going to have to be a lot of assumptions. Okay, thank you. Cheers.
Senator Babbitt.
Thank you, Chair. Now, this question is for either of you. I'll refer as well to the BMJ Public Health peer-reviewed study that was released recently. Obviously, it goes through the potential links between COVID-19 vaccination and higher than expected mortality. Now, you guys have the data set. You have the immunisation register data in your hands. Surely there'd be no greater priority than to investigate the potential links to excess mortality. Are you, or perhaps do you plan to investigate this issue with the data that you have?
Yeah, so as I said before, that we are looking at a range of things that impact both mortality and severe health outcomes, including vaccination status, different population groups, presence of other comorbidities, etc.
Okay. Now, we know that the novel vaccinations which were rolled out en masse were not as safe as the messaging potentially suggested. According to the West Australian government data, these products resulted in an adverse reporting rate that is 23.79 times greater per 100,000 doses than all other vaccines combined. Now, this inquiry, we received dozens of submissions, many of which have come from independent academics, researchers who are unable to access sufficient data to be fully informed and draw conclusions. Is the Australian Institute of Health and Welfare able to work with independent experts or potentially release de-identified data to assist them with their work?
Yeah, so the COVID register has a governance process that allows a range of people to access, including researchers, if they put in project proposals.
And how do they get access to this data if they wanted to conduct their own modelling?
Yeah, so they put in a project proposal that gets approved by the committee, and usually it will involve an ethics approval as well, and then that will enable them to have access to the data in a secure environment.
So is the data that they receive de-identified?
So the data they will access will be through a secure environment, which will have no identification in there.
Okay, great. Now, the AIHW submission quotes the Australian Bureau of Statistics statement that 2/3 of excess mortality in 2022 was COVID-related. As data experts, you must be aware that, including deaths with COVID is directly against a World Health Organization principle established in 1948 that primary tabulation should be done by underlying cause of death. There is an inherent assumption made that every COVID death is automatically an excess death. So, in other words, a death that would not be expected in that year. Does the AIHW have any view on the validity of the assumption, given that the median age of death from COVID in 2022 was 85.8 years? And have you emphasised that people dying from COVID often have comorbidities and thus amongst the frailest in our population?
So I think we would agree with the reply that the ABS gave to that question.
Okay. So in your submission, you state that in 2022, 729 deaths from circulatory disease, 121 deaths from diabetes and 550 deaths from dementia had COVID as an associated cause of death. Could you put these numbers into perspective by telling us what proportions of these deaths with COVID were of the total deaths for these categories? Our preliminary calculations suggest that they were quite small proportions.
Yes, so we do have those proportions at hand. So for coronary heart disease and circulatory diseases as a whole, the proportion was about 1.6% of deaths. For diabetes, it was 2%, and dementia, 3%.
That's it from me, Chair.
Senator Roberts.
Thank you, Chair. And thank you for appearing this morning. It's still morning. Your submission references your Australian Health Performance Framework. This is a set of data about the health of the nation, including mortality data. This information is further referenced across several dozen socio-economic, behavioural and medical factors, one of which is vaccination status. Can you provide the committee, please, a report on notice showing death by COVID vaccination status by age?
Yes.
Thank you. So that's the number of people who died with no shots, 1 shot, 2 shots, etc. by age. Can you just take that on notice? Can you provide the same data by vaccination status for all vaccinations in the Australian vaccination schedule, which is showing on your website, please? What's the health of the vaccinated and unvaccinated population from age 0 upwards?
So I think I'd need some clarification on exactly what you're asking there.
I'd like to know what the impact of vaccines are on people by age. So I want to compare the vaccinated versus the unvaccinated.
When you say impact, do you mean how many people have died by age?
By age, yes.
Okay. How many people have died from the vaccination by age?
By all vaccinations in the Australian vaccination schedule.
By all vaccinations, yes. Not just the COVID vaccine?
Correct. Now, you should be able to do it because the ABS said so in Senate estimates just a couple of weeks ago, last week.
So I think we would have to look into that and see what's available in terms of vaccines on the register and for particular time periods. The immunisation register has various vaccines that have only been on for a short period of time.
Sure, but then you've still got deaths among infants.
Yeah, so I'll have to look into that and see exactly what can be done.
Okay, thank you. And where you can't provide something for a particular vaccine, if you could just explain why, or just list why, the reason why. But you should have mortality data, age data, health data, like hospitalisations and vaccine status, so you should be able to do the comparison. As I said, the ABS said so last week in Senate estimates.
Yeah, so we have the Australian Immunisation Register linked to deaths. We'll have to look at what information the Australian Immunisation Register has on it for different vaccines.
Thank you. Vaccination rates are falling as a result of mistrust in government, state and federal, after the COVID response that we're investigating today. Your own data says that. Why wouldn't you run that data and prove vaccination is safe and effective, if indeed that's the truth, and reassure the public? Because there's a graph showing that vaccinations in infants are now falling.
Yeah, so as an independent agency, we publish information on vaccination rates.
So why wouldn't you do an analysis of the vaccines to see whether or not there's any reality in people now switching off vaccines?
So one of the things that we would be publishing regularly is the rate of vaccination over time, and so then you would be able to see whether it's going up or down.
Yes, I think we've got a graph from you. It is by Australian Institute of Health and Welfare data, showing that there's been a decline in vaccination in the last 2 years. You could run multiple health outcomes by age, by vaccination status, deaths, hospitalisations, suicide attempts. You have the data, don't you?
Pardon? Sorry.
Well, you could run multiple health outcomes by age, by vaccination status, deaths, hospitalisations, suicide attempts, because you've got the data to link it all up. But you haven't done so, because it would prove, it would reassure people or scare people.
Yeah, so though that information is linked up, in order to be able to do that, we would have to, I guess, go through the same process that I described before, which is put together a project proposal, get it approved by data custodians.
New South Wales published the data during COVID until it became embarrassing for the vaccines, and then they stopped publishing it, or they covered it up more accurately. They have the data for your registry. They have the data from your registry, so I imagine that you would too, so it should be okay.
Sorry, can you say that again, please?
They published the data of deaths by COVID vaccine status, New South Wales, until it became embarrassing for the vaccines, and then they stopped. They covered it up. So surely they got their registry information from you, so you should be able to publish the same data.
So I can't speak to what New South Wales has.
No, but you should be able to publish vaccination status for COVID and the other injections.
So we just discussed that before, yes?
That's right. So I'm just showing you that New South Wales has actually done it, using your data.
Last question, Senator Roberts.
In Senate estimates, the Australian Bureau of Statistics made the comment that this data cross-matching access was given to selected parties. Are you restricting access to this data to people who you know will not use it to find and expose the truth behind government's COVID policy?
No.
Thank you, Chair. Can I ask the last question?
Yes.
Thank you. Can you allow the Medical Professionals Association, AMPS, Australian Medical Professionals Society, access to that data? I know that you have a medical and technical panel that matches anything the government or any university has. I know that they have a medical and technical panel that matches anything the government or any university has. So can you release it to AMPS?
So we have a governance process, as I said, which has various criteria around the project proposal that people put forward, and it would have to go through the normal process in terms of going through ethics and getting approved by the different
Is that governance process available anywhere publicly, or could we get it on notice from you?
We'll take that on notice.
Thank you. Thank you, Chair.
Thank you very much for your evidence today. The committee will report to the Senate on the 31st of August 2024 and request that answers to questions taken on notice are provided to the committee secretariat by close of business Friday 21 June 2024. The committee will now suspend for a break and will recommence 5 minutes later than scheduled at 11:50. The committee will now resume. I now welcome representatives from the National Rural Health Alliance. I understand that information on parliamentary privilege and the protection of witnesses giving evidence to Senate committees has been provided to you. For the benefit of the committee, could you please state your names and the capacity in which you appear today?
Susie Tegan, I'm the Chief Executive of the National Rural Health Alliance. And online, Carmen?
Carmen Ellis, Policy and Research Officer for the National Rural Health Alliance.
Thank you. Do you have an opening statement?
Yes, I do. Thank you. First of all, I'd like to thank the Senate Standing Committee on Community Affairs for the opportunity to give evidence today to the parliamentary inquiry into excess mortality. As mentioned, my name is Susie Tegan. I'm the Chief Executive of the National Rural Health Alliance, and I represent 52 national organisations committed to improving the health and well-being to over 7 million people in rural, remote and regional Australia. They make up 30% of the Australian population. The group that I represent follow patients across the patient journey from birth to death, but also researchers that research in rural, remote and regional Australia, and those clinicians in their journey from the day that they decide that they want to study a health career all the way to the end of their career. People living in rural areas are more likely to die younger and preventable causes, have a higher burden of disease and limited access to health services. Currently, 44,930 people in remote Australia have no access to primary health care services within an hour drive from their home. Now, 44,000. To put it in context, it's like whole of Lismore, more than Lane Cove Council, more than Strathfield Council, more than the Adelaide Hills, or Livingston or Somerset in Queensland, for those people not to have a healthcare service. During the course of this inquiry, the Alliance's most compelling finding was the lack of available data demonstrating the impacts of excess mortality by remoteness. In the absence of these data sets, we are unable to fully determine the impact of public health events such as COVID-19 and subsequent events, and what they may or have had on rural and remote Australians. Examining the implications of COVID-19 pandemic through the lens of rural healthcare provides a unique and nuanced insight into impacts of pandemics on at-risk populations. These at-risk populations are those that live in those regions that have a $6.55 billion underspend in healthcare currently, which means $844 per person per annum less expenditure on healthcare. Substantial investment in healthcare and infrastructure is needed to support future outcomes for rural and remote Australians. This must include a targeted national rural health strategy, which includes a compact between federal and state and local government, to ensure that a health strategy with tailored models to bolster the rural healthcare workforce and take measures to address the historical inequities faced by rural Australia. Rural Australia is not a third world country. They are fellow Australians. These interventions must be grounded in community knowledge, co-design and supported with a robust data set to provide insight into community need. I'd like to thank the Senate Standing Committee and Community Affairs and Committee Chair Senator Marielle Smith for this opportunity to provide evidence to the inquiry for excess mortality, and look forward to answering your questions.
Thank you. I'll go to Senator Pratt. Are you back online, Senator Pratt? I might go to Senator Kovacic and I'll come back to Senator Pratt.
Thank you, and thank you for your evidence. It's been established that a majority of the excess deaths are due to COVID. However, in regional areas, there are also other factors like distance of care, which you've just noted around, the time to a practitioner, more than an hour, and, that's some quite alarming data around access to services. Are you able to take the committee through some ways in which excess deaths, especially from preventable diseases in regional Australia, could be reduced with improved health services and access to those services?
Well, the first thing is that you could plan for periods of increased admissions to rural healthcare services. Senator Kovacic, for example, seasonal respiratory viruses, designed interventions to bolster the healthcare workforce. Now, during COVID, one of the difficulties was that people couldn't move around, and there was already a shortage in workforce. Those people are still stretched currently. They were stretched then, and they're even more stretched now. And, there need to be some changes in the way we fund healthcare services in rural communities. They need to be more flexible, and the funding needs to be very much community-led. The fact that 44,000, almost 45,000 people living in remote Australia have no access to primary health care services within an hour's drive of their home is just appalling. Small rural towns have almost 60% less health professionals than in major cities, and they pay the same taxes, the same Medicare levy. In fact, they bring in 2/3 of Australia's export income comes from those communities. We have 50% of tourism income coming in from rural, remote and regional communities, and yet we provide them with less money and inflexibility in funding. We also say, oh, sorry, you don't fit into the way we are going to fund this particular grant and application. No wonder we don't have the workforce on the ground. In addition to that, potentially preventable hospitalisations are 2 to 3 times higher in remote and very remote regions. And the study of the peak influenza periods in rural New South Wales, for example, between 2016 and 19, noted high admission and bed transfer, which led to 245 extra hours of nursing and cleaning staff, and yet we weren't able to support them with more workforce or flexible delivery. I hope that answers your question, but there is a broad spectrum of initiatives that could be put in place, and data could be made available when actually the data collection has been funded by populations. It should be available.
Thank you. And sort of leading on to that, and the different things that we can and should do, what do you think that Australia should do to improve preparedness for future health emergencies, with a particular view on improving care for our rural cohorts? Because, the data again that you talk about is quite alarming.
It is alarming, yes. Thank you for recognising that. So one of the models that the National Rural Health Alliance has put together with communities, with local government, with input from our 52 members, but also some state-based or local entities, has been the PRIM-HS model. And it's been referred to in quite a few different government reports and reviews. This is about having a grassroots-led approach where you have all the local health entities, including individual services. You have local consumers, you've got local government, you have the federal government-funded workforce agencies and PHNs, and state-funded agencies sitting together around the table looking at the population health for that region. So the funding currently exists on historic funding for that region, which is already underfunded. It isn't population health based. But with the PRIM-HS model, you have population health data, you have information about what services exist currently and then you look at what is missing. And you should be able to have those regions cashing out some of that underspend and saying, our approach will be X to deal with these needs that we currently have. It might be in diabetes, it might be in aged care delivery, it might be in funding for disability sector, indeed in Aboriginal health services. And then the approach will be very much locally based. However, because the PRIM-HS model expects everyone to sit around the table with an independent chair, it then is identified and allocated to the needs that are, and prioritised to the needs of that community. And we have some communities around Australia in rural, remote and regional Australia that are willing to start with this now. And unfortunately, the funding isn't there.
Thank you, Senator Kovacic.
Thank you for the evidence. Sorry, apologies, Chair.
Thank you. I'm now going to move on to Senator Pratt.
Thank you, Chair, and my apologies for my problems with technology earlier. The terms of reference for this inquiry look at the years where the effects of COVID and the pandemic were particularly felt. Can you give us an overview of how the experience of rural and regional people were different from Australians in metropolitan or larger centres?
So the excess mortality increased from 3.1% below the expected annual mortality in 2020 to 1.6% above expected and 11.7% above the expected rate for 2022. There were 13,544 deaths in February 24, and that was 4% above the 23 figures, but 3.9% below the 22.
Sorry, can I ask, is that compared to the metropolitan data or is that compared to what was expected?
That is what is expected. So in 20...
And how did those gaps vary if you took that data and compared it to metropolitan areas? So, for example, was the excess mortality higher or lower?
It was higher.
In regional areas.
Yes.
And what can you tell us about, have you got any data yet on vaccination rates in regional areas versus metropolitan areas?
I don't currently have that, but we can come back to you, take it on notice and come back to you with the latest data. Okay. And in terms of excess deaths, we know that COVID varied a whole range of for example, the road toll went down because there was less traffic on the roads in some parts of Australia. Have you got any data on what excess mortality is attributable to, and how did the health trends vary overall statistically? What is excess deaths just attributable to COVID, or can you see other variations? So, for example, we know the flu was down because of isolation, and so there was less deaths overall nationally from things like the flu. What can you tell us about how those trends varied in more regional areas where you might have different different trajectories for the carriage of disease? Sure. So I'll just start with Indigenous populations, and just to get back to your initial question, because there is a lot of data around, but it can be confusing. So the mortality rate from COVID-related deaths for Aboriginal and Torres Strait Islanders was 1.6 times higher than for non-Indigenous people in Australian populations at large.
Yeah.
Don't forget, 2/3 of Indigenous people live in rural, remote and regional Australia. The deaths from COVID or with COVID for Torres Strait Islander people occurred at a similar rate in major cities and inner outer regional areas, but were 1.3 times more likely to occur in remote and very remote areas. In terms
that
of...
doesn't surprise me when you look at overcrowding and...
in housing, yes.
Yeah.
Correct.
And if you're in a small community, once a disease has come in, it's going to be socialised internally rather than like in more disparate ways. Yeah. Correct.
And that is why it's so important to have social housing for Indigenous people and social purchasing of housing for Indigenous people. The other thing is the death rate was higher for Aboriginal and Torres Strait Islander people than non-Indigenous people in all geographic regions, increasing with remoteness, and 7 times higher in remote and very remote areas. COVID deaths have disproportionately affected Indigenous populations in all geographic regions. And the biggest thing that always makes me open my eyes is, don't forget, there are Indigenous and non-Indigenous communities around rural and remote Australia where people are living between 13 and 16 years less of a life than those people that live in the city.
Well, I think that would probably align with, if you look at Australia's Medicare expenditure, the closer you live to GPs and specialists, the more likely you are to draw down at the taxpayer's expense for access to those services. Can I ask, in that context, are there any trends in other disease? So, for example, specialists and other clinicians may not have been travelling as much. Can you see anything yet in further delayed diagnosis? We know that people living in regional and rural and remote areas can have delayed diagnosis because of that lack of access. I imagine that was exacerbated during COVID, as many specialists aren't local and travel.
Cancer, people having their surgeries delayed, cancer diagnosis. I can't give you the figures yet because the data isn't out yet, but we've heard anecdotally. There's definitely, I mean, on an everyday basis without COVID, this is already a big issue because those populations have had to put up with not having the services. And there is almost an expectation that they don't have the service. And there is also a suck it up and just deal with it. Sorry, you just won't have the service and we'll just have to put up with it. And because of the commitment to go to an appointment in the city being so big, it's not only costly for people, it is also time away from their job or their families. Often those people do not have families around them to look after children. With Indigenous communities, you would have to have, quite a few family members go with them. And so, and because of the cultural issue about if you go to a hospital setting, you often don't come out of it, those populations are often not getting to the services that they need. In addition to that, at a local level, you often have a revolving door of clinicians coming in and out, and that includes nurses, allied health professionals and doctors and specialists. And so it really reflects on, we need to re-look at the training of the future workforce, and we need to look at the way we collect data locally. Federal, state, local government and local health services need to have a compact through a national rural health strategy to collect data, to research rurally, to fund rural research, and to make that data accessible and openly accessible by communities and by researchers.
So this inquiry is looking at excess mortality. Just last question. We're looking at the motivation behind this inquiry was really based on an assertion from some senators that the government's suppressing data on excess mortality related to COVID. Would you be concerned if that becomes a dominant paradigm? We know there's excess mortality in rural and regional Australia. We don't want to skew ourselves away from what the real causes of that excess mortality are, when there's so much that we can do to address that for rural and regional Australians.
Absolutely. In the end, the data is collected with taxpayers' funds, so it's data that everyone should be able to access. And the National Rural Health Alliance, Friends of the Alliance, are grassroots individuals that provide us feedback. They would like to be healthcare savvy. They would like healthcare literacy and healthcare system literacy. And if we keep data and we don't explain data, you will continue to keep people in the dark about what is actually occurring in their population. And we must give people access to information and make them more accountable to their own health, but also be part of the solution. Because without it, we will continue to have people, having less access and less positive healthcare outcomes.
Thank you, Chair. If you could take on notice for me, just quickly, excess mortality, which is what this inquiry is about, whether there have as yet been any trends around excess mortality in relation to all of the other contributors to excess mortality in rural and regional Australia versus
we'll definitely be able to send you that. We'll definitely be able to send you that because they're comorbidity issues and yes, we'll be able to send you that. Thank you.
Thank you. That's terrific.
Thank you. Senator Rennick.
Thanks, Chair. Hi, how are you going? And thanks for your submission. It's a very good one. I just note you made a pertinent point here that COVID-19 accounted for less than 1% of all deaths in 2020 and 2021. I'm not sure if you're aware, but $18 billion has been spent on COVID vaccines, and that's just vaccines and the tablets. That's not counting the PCR tests, etc. I note that the Sunshine Coast Hospital was the last big hospital built in Queensland for $1.8 billion, and that had 450 beds. Do you think one of the ways to improve regional health would be to actually, rather than waste money on treatments that don't work, is that this money was actually spent on building hospitals out in the regions in order to get more frontline services?
Thank you for that question. The first thing is we would like to be preventable rather than getting to the tertiary setting in the first place. And so we believe that investment in the primary care setting in the first place is a fantastic and proactive option. Building of hospitals is when you're at the stage where things are already bad. And yes, we actually need to support hospitals and we need to make sure that they're up to date. But building the primary care workforce, which is multidisciplinary, nursing, allied health, podiatry, dentistry, those sectors are so underserviced in rural, remote and regional Australia. And we need to make sure that we can support the people that are already on the ground. Since COVID, we've had more people burn out. We've had more people saying that they haven't had the support.
Let me rephrase the question then. Rather than spending $18 billion on hospitals, if you assume a doctor is $1 million each, okay, you can get 1,000 doctors for $1 billion or 18,000 doctors for 18 billion, right? So my point is that preventative or treatment, I don't care what, you need to get hands-on, effective treatment and that better value for money. Do you not agree with that? I mean, my background, just so you know, is I grew up in a small town where we've lost our maternity ward despite the town being twice as big. So I'm familiar with the problem with regional health and I'm totally on your side.
I'm aware of that.
But the point is that the money isn't getting to where it's needed. It's often ending up in the pockets of big pharma or bureaucrats or experts punching spreadsheets rather than actually frontline services.
There's a $6.55 billion underspend in rural, remote and regional Australia. So every person living in the country should be getting another $844 per year. That needs to be going to those communities rather than getting to the city. And it has been historically underfunded and it is still underfunded. And when I mentioned earlier that rural Australia is not a third world country, why are we treating it like that? If this was occurring in the city, I can tell you those people would be on the doors of Parliament House. The people in rural Australia are continuing to put up with getting second best, and there are clinicians on the ground that are working their butts off, and we are allowing that to occur, and we're saying it's okay by not doing anything.
So thank you for that. So why is it that we have to import doctors from third world countries instead of being able to train more doctors here in Australia? Because that's something that really grinds my gears.
Well, I've been working in this...
Third world countries need their doctors and we're basically stealing them because our education system isn't educating enough doctors and nurses, it seems to me.
So I've been working in this industry for more than 30 years and we have been telling successive governments that we cannot continue to ethically continue to take people from developing countries that we've provided aid to bring them to Australia after we've supported the training in their own countries. That being said, there have been some excellent international medical graduates. The problem is that not all international medical graduates stay in rural communities, even though we have a moratorium where they have to work there for X number of years. They often leave early under all sorts of guises, and the populations in those rural communities are getting tired of the revolving doors. They no longer trust that the system is working for them. They often don't trust governments when they say we're giving you services, but they leave within a year or two, including trials and programs. We are changing the way we train doctors by recruiting, and that includes allied health professionals and nurses. We need to recruit rural students. There are many cases where we've done the research. 7 times more likely to stay or return to rural if they are rural from primary school and secondary school and then train in rural. 7 times more likely.
Okay, thanks. I just know that short time, so cheers, thank you.
Yeah, thank you. I'm going to go to Senator Roberts.
Thank you, Chair. Thank you, Mr Teagan, for being here. Your submission's third paragraph includes this statement, quote, "The absence of geographical data makes it impossible to fully understand the impacts of excess mortality on rural and remote consumers. National Rural Health Alliance strongly advocates for the creation of data sets demonstrating excess mortality in relation to remoteness." End of quote. We need to ensure the committee notes this, Ms Teagan. Is this something perhaps that must be in this inquiry's report?
Absolutely.
What about preparedness? You should have been aware that there was a preparedness plan for rural areas for a flu epidemic. Were people in the rural areas aware of such a plan, and was it followed?
I'm not sure if they were all included in such a plan, and I think if there is a federal plan, it needs to be taken to those rural communities. A classic example, again, is through the pre-MHS model, where at a local level they start looking at how do we manage a risk like this if it comes to our region. It's no different from a fire plan that rural communities have or a flood plan that rural communities have. And, you know, it's really interesting. Why is it that the Defence Force, the Police Force, they are all funded to do this, to support their workforce to do this well? We need to do it in health, and it needs to be done under a national rural health strategy, and it needs to be a compact between federal, state and local government with the community.
Thank you. I must commend the witness chair for clear and concise and very strong advocacy. It's refreshing. What discussions, meetings, planning occurred in the early stages of responding to COVID to guide your response in rural areas to COVID? Once we were told there was a supposedly major virus on the loose.
The National Rural Health Alliance started a series of teleconferences and updates with its members, but also its friends of the Alliance, which are the grassroots people. In addition to that, we held meetings with the government to provide real-time feedback to those communities, also the clinicians. But again, I think clinicians on the ground were really stretched in rural areas because they already had workforce shortages, and it needs to be revisited with the learnings of the populations and also the response on the ground.
Thank you. Your submission raises the topic of a shortage of health professionals in rural areas. You repeatedly did that, and you've said it again today repeatedly. How did the shortage of health professionals in the bush make the impact of COVID worse, and what can be done about it?
It burned out a lot of workforce. It made people feel that they weren't supported, because as soon as we felt that COVID was finished and it's business as usual, they are still trying to recover from what happened over the last 4 or 5 years. They still feel not supported. You know, we're now focusing on the future workforce, and yet we're not able to support or, you know, provide more bolstering for the current workforce. The communities are back to normal in terms of living their life. They're working in an environment where you've got a higher inflation rate. So, you know,
it's tough.
It's tough. And these communities are the most underfunded, the most, I mean, if you're looking at agriculture and primary industries, they are the only community around the world that are not subsidised. Yeah. And here we are expecting them to deal with health issues, with global markets, with weather patterns. You know, it's... Why we don't expect that from the city? Why do we expect it from the country? Because it's out of sight, out of mind.
So one of the things I'm picking up between the lines is that you don't see the imposing of systems and processes from the city to rural as being effective. You're calling for a national rural health strategy. You've also made the point that people need to be accountable for their own individual health.
Yes.
Isn't that something that can be said about the whole country's health?
Absolutely. Absolutely. And by increasing the amount of data that's available, by increasing an understanding of health care, the healthcare system, but also your own health, you are more likely to be able to deal with your own health issues because you've got an increased health literacy level. And I just make a comment about the death of recently of a person that was really raising the awareness in the population, and that was Michael Mosley. Australians loved watching him, their increase of understanding of healthcare. You've got Norman Swan increasing the understanding of healthcare. His Corona cast was listened to by millions of people around Australia, rural Australia, which still has a very high readership and listening to the ABC. Those sort of initiatives were really important to rural people. You know, we just need to make sure that they are not forgotten and that we have a social contract to do something about this rather than having reforms and inquiries and nothing happening with it.
I see your message, so I yield my call.
Thank you very much, Senator Roberts. Senator Canavan.
Thank you, Chair. I just wanted to ask, well, first of all, clarify, the ABS does not have excess mortality data for geographic areas?
No.
All right. And I mean, even in the broader mortality statistics, I don't see them in geographic areas. Do they have that? Also, not excess, just mortality figures for geographic areas. Is that available?
Some is available. See, there is some data available, but it's not as per geographic area.
Right.
And often we would like to talk with local government about it. We'd like to speak with local politicians about it so that they're more aware. And we'd also like to speak to the Regional Health Service because in the end the health system is federal and state funded, and I think it needs to be looked at. For the average Australian in rural Australia, they don't go, oh, this is state government, this is federal government and this is local.
Yeah.
They just want a health system, and the data needs to be available for their region.
I mean, I often do hear stats, though, that the life expectancy of people in the bush is much lower than in the cities. Where do we get that data from if it's not collected?
We get it from the AIHW, and we also get it through the ABS. We get it through the Best for the Bush report from the RFDS. So, you know,
so the data's there.
And our data. Well,
Right.
we have to draw it all together. So it's
Right.
quite costly to bring all that data together. There is nobody being funded. Like, we ended up funding ourselves, funding a report so we could draw all that funding together.
Right.
It actually should be funded so that it can be provided to those regions so that they can plan.
I mean, we heard earlier, I'm not sure if you were here or heard it, but we heard earlier from the AIHW that they're doing some work at the moment linking mortality rates with an individual's vaccination status. I would have thought they must have then the ability to do the same for people's geographic
they should
location.
be able to.
Why can't they do that?
But for anybody to access it, you actually have to pay for it.
Right. But why can't they? Why shouldn't they be funded to do that? It seems
Well,
very
they are
important.
funded to do it. Like, they can do that. They prioritise which areas
right.
that they should look at.
Right.
If there is a mandate that they must look at that,
Yeah.
it's a different matter. So maybe that's one of the things that
Yep. Well, I
you
think
could
it's a
ask
very-
for, and it definitely should be at a local level. But the thing is, most communities don't have the money to pay for it.
No, of course not. It's a very sensible recommendation. Do you have a particular view on then how disaggregated that should be? Like a particular statistical area,
It could
on a
be
regional basis, local government area? What
well,
do you think?
MMMs for one.
Right.
Modified Monash model areas, because at the moment we have 1 to 7. Rural is really 3 to 7.
Although that would potentially be across the country then,
It is across.
not necessarily. So you report a figure for, say, in a regional rather than for,
but then
say
you could
Townsville. But do you think you want it on a
Local government level.
Yep, right.
Because local government is often taking up when market fails and all of a sudden a community has no medical or allied health or nursing staff. They often pick up the pieces. And I'd just like to say, after the taxpayers paid taxation, they've paid the Medicare levy and they're paying local government fees, the local government rates are then used to support that community. So the local community is paying 3 times, sometimes 4 times, because they're also fundraising. Again, I don't see an urban centre doing that.
Yeah. Just on a different topic, I mean, obviously there are challenges in the bush, as you've outlined, but I sometimes try not, as someone who lives in a regional area, sometimes try not to be too negative. I felt that the best place to live during the pandemic was outside the cities. And I came here and saw what it was like, and it was bliss out in the regions, in the bush, in comparison. So maybe, I mean, is there any evidence so far about the different impacts of COVID? And as I say, it's not always negative living in rural and regional areas. Yes, you have fewer services, but sometimes quality of life is better. And and certainly in these times we didn't face the same stresses.
In the happy index, apparently people living in rural and remote Australia are happier, right. And that's partly because they have much more of a community pulling together. So during times of COVID, we had all sorts of people going out and cooking meals, taking them to the older population that aren't in aged care because there aren't aged care facilities. They worked out different ways of looking after people. That occurred much more in rural communities. But really, the data on COVID-19 related deaths in Australia, while it wasn't presented as an overall figure for all people by geography, being broken down, it did show a major difference, and it just highlights that we need to do something about ensuring we have local data so that planning can occur, risk management can occur.
I mean, the only other negative thing I suppose I'd raise about this is that sometimes the rules around lockdowns and what have you seem quite inflexible in rural and regional areas. So rules were sort of designed for a Sydney environment. You can only drive 5Ks or something. Did you have any feedback on that then through the pandemic, that they weren't really well designed for a rural location where distances were much greater?
Yeah, definitely. I mean, how can you support somebody that's in your family that might be old, it might be on a property, and you can't actually go there? And so there were local initiatives which were not purely because of the need, because it's just so inflexible in the city where you have too many people in a close environment. And so that is why the data needs to be available. That is why a local health strategy needs to take place. And while it might be under National Rural Health Strategy and a national COVID or whatever the initiative is, strategy, there needs to be some local planning that can inform federal planning, because you cannot. I mean, there were people that couldn't go across the border that were clinicians. It's just like, it just doesn't make sense. The borders are man-made.
Yeah. Do you have, just on that then finally from me, do you have a view on whether we need a Royal Commission into the pandemic, given those concerns you've just raised?
What worries me is that if you have another Royal Commission, it's another report sitting on a shelf. I think there is enough feedback out there, and a review such as the one here, such as this inquiry, needs to make some really serious recommendations. And for the National Rural Health Alliance and its members and communities, we would like a National Rural Health Strategy under which an emergency health strategy is informed by local feedback in how risk can be managed.
Okay, thank you. Thank you, Chair.
Senator Babbitt.
Thank you, Chair. Your submission makes a clear point around the lack of quality data that demonstrates the impacts and frequency of excess mortality in rural and remote areas. I think you make a pretty valid point, but sadly we're finding that the data that is publicly available in many areas is lacking. How are we supposed to demonstrate the impact of excess mortality on rural and remote Australians if we don't have suitable data in the first place? What do you think?
Oh, exactly. How are we supposed to impact that? And how can we ask for anything or make a recommendation of a better strategy if we don't have the data? How do we expect consumers or / patients to know more about their healthcare or the healthcare system if they don't even know what the status is? How can people be informed about whether vaccination is valuable or not if we're not informing them? We're a Western country, we're a democratic country, and the data is funded by the population.
Yep. You also mentioned in your submission that rural workforce shortages significantly impacted healthcare provision during COVID-19 during the pandemic and continue to impact healthcare access today. Now, your alliance represents 52 national organisations who represent thousands of healthcare providers. Now, there is no doubt at all that some of those who you represent would have been mandated. What is the National Rural Health Alliance's position on the COVID-19 vaccine mandate? Should they exist today? Should they have ever existed in the first place? If another pandemic were to occur, would you support them again?
Oh, Well, there are some individual views, and also organisational views. From an organisational perspective, and those organisations which we represent, the vaccination and the approach taken after not having had such a case like COVID for more than 100 years, the strategy to have vaccinations out there and to make sure that all allied health, all nurses, all doctors are vaccinated and communities are vaccinated was an important decision to stop the deaths in the first place, because there was no predecessor to this case. I guess the research wasn't there, and I think once the data is available, this whole thing needs to be re-looked at. First of all, do we mandate vaccination? What are the findings from the vaccinations? What can we inform the consumer about? How can we inform the clinicians? How do we support the clinicians better? And then how do we do that at a local level in rural, remote and regional Australia? I don't think without data you can't make a concerted recommendation. And you will always have a population. Again, we're a Western country. We're a country where everyone can have a view. There will be an institutional recommendation, and there will be people's views on the ground. And in the end, Australia has a remit to keep the population safe and secure and make sure that the mandate is for the major part of the population to continue to be able to live a healthy life.
Now, do you believe that losing staff members because of the vaccine mandate could have increased the effect on staffing shortages and therefore potentially risk the lives of patients?
I haven't seen the data.
Okay. Next question is in regards, in your submission, all right, you said that the National Rural Health Strategy was it funded, I should say, was it funded or partly funded in the federal budget, the National Rural Health Strategy?
It's not funded.
It's not funded?
No, it's not acknowledged nor funded.
What's the cost going to be over the life of the strategy, do you think?
A National Rural Health Strategy has several parts of it. The first part is that federal and state governments have a compact and sign up together to have a National Rural Health Strategy because of the poorer health outcomes and because of the underspend. So that's the first thing. The second one is, so that would be, and to develop a National Rural Health Strategy would probably be a commitment by federal and state government to work together with the National Rural Health Alliance and other stakeholders to develop it. Underneath that would be a definition of the minimum level of care that every Australian should be able to access. So that means it is determined by health outcomes, by geographic region, by distance to services, by minimal access to a clinician. The third thing would be that the primary rural integrated multidisciplinary care model is funded, which means that every community that currently doesn't have that sort of ability to plan for their health population and has had an underfund is able to work out what services they might need for that community.
Do you feel let down by the federal government?
I feel rural communities are let down. Absolutely. Those people in those communities, those 7 million people making up 30% of the population, bringing in 2/3 of Australia's export income that has kept Australia out of 2 financial crises and the downturn of COVID, and bring in 50% of the tourism income and provide 90% of Australia's food, are let down because they don't receive the health funding like the rest of Australia's population does.
Final question. What's your personal view on vaccine mandates? Should an individual's right to choose be priority or not?
My personal view, I haven't seen the data and I'm not here in my personal perspective.
What's your professional view?
My professional view is that you need to see the data and you then go back to speak with the community and those grassroots individuals. But I am fully vaccinated.
All right, thank you.
I'm just going to go to Senator Pratt very quickly for a question on notice.
Thank you. Can you please give us some advice on notice about the extent to which there's any evidence to show that disinformation campaigns are likely to have more traction in communities where there's less access to healthcare because people don't have the same level of health literacy because of that historical lack of access to services? Thank you.
Thank you for the question. We will definitely come back to you.
I want to thank the National Rural Health Alliance for your evidence today, and as someone who also lives in a regional area, thank you for your advocacy. There are many good things about living in regional and rural Australia, and access to healthcare is not one of them. The committee will report to the Senate on the 31st of August 2024 and request that answers to questions taken on notice are provided to the committee secretariat by close of business on Friday 21 June 2024. Thank you very much.
Wonderful. Thank you very much for having us. We really appreciate it.
I'm now going to call representatives from Asthma Australia and the Stroke Foundation, who I believe are attending online. Thank you very much for appearing before the committee today. I understand that information on parliamentary privilege and the protection of witnesses giving evidence to Senate committees has been provided to you. For the Hansard record, could you please each state your full name and the capacity in which you appear today?
My name is Doris Whitmore and I appear for Asthma Australia and I'm the Interim Chief Executive Officer.
I'm Anthony Flynn. I'm the Director for Knowledge Translation and Knowledge Management and Translation with Asthma Australia also.
I'm Angela Cartwright, Policy Manager with Asthma Australia.
Hi, I'm Dr Lisa Murphy, CEO of Stroke Foundation.
Thank you very much. I now invite you to make a short opening statement, and at the conclusion of any remarks that you may have, I'll invite members of the committee to ask questions. So I might go first to Asthma Australia if you have any opening remarks.
Thank you. Thank you, Chair. On behalf of Asthma Australia, I want to thank the Community Affairs Reference Committee for the opportunity to address this inquiry into excess mortality in Australia. 1 in 9 or 2.8 million people have asthma in Australia. In 2023, asthma was the 8th leading contributor to the overall burden of disease in Australia, having risen from 9th in 2018. For children aged between 1 and 9, asthma is the leading cause of total burden of disease. With regard to this inquiry, we recognise that there is a significant opportunity to learn from the COVID-19 pandemic in terms of the impact of the public health measures that were implemented to protect people in Australia from COVID-19. In Australia, fewer people with asthma died from their condition when these measures were in place than in previous or subsequent years. While many of these public health measures are not practical today, the continued promotion of good hygiene, staying at home when unwell, and having regular influenza and COVID-19 vaccinations accessible to everyone in the community remains important to helping people with asthma manage and maintain control of their condition and to stay out of hospital. Lessons from the pandemic also highlight the importance of air quality in keeping people with asthma safe. Reducing air pollution from avoidable sources will reduce the burden of asthma and prevent a range of other adverse health impacts. Ensuring that buildings and homes are equipped with appropriate ventilation and air filtration not only reduces airborne virus transmission, but it also promotes healthy indoor air quality, reducing indoor asthma triggers like mould and pollutants produced by biking. Here today with me, we're happy to answer the questions of the committee if they relate to our submission.
Thank you. Your connection was really great until about the last 30 seconds, so hopefully that will improve as we go through the morning. I might check whether Dr Murphy, you had any opening remarks from the Stroke Foundation.
I do, thank you. So thank you, Senators, for the opportunity to appear before you today and to talk about stroke prevention, treatment and enhanced recovery in the context of the COVID-19 pandemic. Everything we do at Stroke Foundation is guided by our community, the estimated 450,000 survivors of stroke living around Australia, their families, their carers, clinicians, researchers, everybody who's been impacted by stroke. Tragically, 23 Australians die of a stroke every single day, and according to the AIHW, that's more than 8,500 people every year. Stroke doesn't happen to individuals, it happens to families and it happens to communities. So today I would like to acknowledge those who have lost loved ones to stroke and those living with the ongoing disabilities from stroke. I send my condolences and I offer Stroke Foundation support to anybody who might be listening today. We know that for many Australians, stroke strikes completely out of the blue. Many have no warning signs or don't even know their risk factors and haven't been assessed and managed by a GP or allied health practitioner to prevent it. Senators, we made a submission to the committee of our analysis and insights into the excess mortality in Australia from 2021 to 2023, and I hope you've had an opportunity to read our submission. I would like to highlight a few key points. Whilst we didn't see an excess of deaths into the stroke data, we do know that disruption of stroke prevention and treatment services will have long-term impacts, which we just haven't seen yet, and there's two reasons for this. First, Australians missed out on preventative health checks to test risk factors, putting them at high risk of stroking in the coming years. And second, survivors of stroke were unable to access timely acute stroke treatment as well as rehabilitation in their ongoing treatment and support. We know in stroke prevention is better than cure, and we and the stroke and chronic disease community have called for greater allocation in the Commonwealth Department of Health budget towards preventative health initiatives to tackle chronic disease with a particular focus on risk factors for stroke. And for those of you who don't know, high blood pressure, atrial fibrillation or an irregular heartbeat, diabetes, high cholesterol, overweight and obesity, as well as excess alcohol consumption, smoking and vaping, poor diet and a lack of physical activity are all risk factors for stroke. 80% of strokes are preventable. So if we can just better address these underlying risk factors, we can prevent so many more strokes in the first place. And this is especially true for high blood pressure, which accounts for over 40% of strokes. But to do this, we need to have targeted screening and regular health checks so people work with their primary healthcare providers, so they know if they're at risk and they know what to do if they are at risk. Australia's primary care system and Medicare is critical to addressing this. Time is brain when it comes to stroke. This means that as soon as the signs of stroke appear, you need to get urgent medical attention. That's calling an ambulance. So that's why Stroke Foundation always advocates for funding for national campaigns to raise awareness about the signs of fast stroke: face, arms, speech and time. We work alongside national stroke experts and clinicians, and we're calling for the implementation of 30, 60, 90 targets to make sure Australians receive vital clot-busting treatment and stroke quickly. We need to give treatment in the window of 4.5 hours after stroke appearing. We also want to see Australian hospitals have certified and dedicated stroke units, a proven evidence-based model that achieves best treatment and recovery outcomes for stroke. Quality of stroke care depends on clinicians having access to world-leading and up-to-date treatment data and evidence. And Stroke Foundation established and delivered the world's first living guidelines for stroke treatment, whose methodology was actually used for the COVID-19 living guidelines that saw research evidence implemented into clinical practice in absolute record time, and that no doubt saved lives. We're on the cusp of losing funding for this critical programme after we were unsuccessful in the recent federal budget. And lastly, once you've had a stroke, you are at risk of having a secondary stroke, 30 to 40% more likely. We have a stroke line, which is our major support line, and it's free and staffed by health professionals. We are busier than ever since COVID, with increasing complexity and increasing number of calls. We're getting calls around mental health, about social distress, about navigating the NDIS. Stroke Line is currently funded purely through donations, but we are asking for government funding to get that funded through government support. It takes enormous courage to be the voice for your loved ones and to support an organisation like ours post-stroke. We cannot continue to deliver critical services without support of government. Senators, with your help, we can prevent over 80% of strokes and reduce the risk of disability and death if people are more aware of strokes, receive appropriate treatment quickly and in a timely manner, and are fully supported in their recovery. I implore you to take the information we've provided and help us secure greater investment into critical programs and prevention activities that help organisations like ourselves deliver. Together we can prevent stroke, save lives and enhance recovery survivors, their families and their carers. Thank you for your time.
Thank you very much. I'm going to go first to Senator Pratt.
Thank you. I've got two questions for both organisations. The first is in relation to COVID vaccination and the experience of COVID. For your populations, there'll be different kinds of vulnerabilities associated with that. One of, clearly if you're asthmatic, you might be, and you get COVID, that might exacerbate your condition and your likelihood of a really adverse event. Or if you've got a stroke, you might need higher levels of care, more intimate care. You might have more vulnerable organs as well that can also make you more susceptible. What was the significance of vaccination during the COVID pandemic in terms of protecting your vulnerable populations? And now on an ongoing basis in terms of immunisation overall, for a rate, whether it be for influenza or a range of other preventable disease that can be prevented with vaccination.
Might go to the Asthma Foundation first and then we'll go to the Stroke Foundation.
Thank you. I think that's a question probably best answered by you, Anthony.
Yeah, thank you. Thanks for the question, Senator. The first thing to clarify is that people with asthma indeed felt very vulnerable when COVID, swept over the world and swept into Australia. But we quickly did some work to understand their vulnerability, and we're pleased to note that they weren't more vulnerable. Most people with asthma were not more vulnerable to COVID infection compared to people without asthma, but they were still vulnerable like people without asthma. So the significance of the COVID vaccination was huge for them. It provided them the reassurance because of the strong evidence of the protective efficacy of the vaccination against contracting COVID in the first place, and the efficacy of it to prevent severe disease once with COVID. So it was very reassuring and a very important measure that was when it was available to people with asthma across Australia.
Oh, and yes, it still is available. And what about other vaccinations, particularly connected to respiratory disease? You would, for example, encourage people with asthma to get a flu jab every year?
Yeah, very much so. So people with asthma. So this was the interesting finding about the finding that people with asthma are not more vulnerable to contracting COVID but they are more vulnerable once they have a respiratory virus on board. So in particular, the influenza virus, respiratory syncytial virus, the RSV viruses, they're two very big problems. They're big hazards for people with asthma, and that we do encourage all measures that are available in terms of public health measures as well, including accessing vaccines to people with asthma to follow public health measures, reduce their risk of being exposed to these circulating viruses, but indeed avail themselves of the vaccine that's available to protect them and prevent severe disease if they do contract these.
So severe disease from a flu virus that affects the lungs could exacerbate your asthma and make you more vulnerable?
That's right. Exactly, yes. So a vaccination will significantly reduce the risk of a person with asthma having a severe asthma exacerbation in response to an influenza infection, for example.
And the same with COVID?
Yeah, indeed. The COVID vaccination will significantly reduce a person with asthma's risk of having a severe COVID infection or severe asthma exacerbation in the setting of a COVID infection.
Thank you.
Dr. Murphy?
Thank you. So if a person who had a stroke, they are more likely to get, they are and were more likely to get severe COVID symptoms, more likely to get complications, and also 5 times more likely to die. So I think that comes out in the statistics around people with comorbidity. The other thing that we know is that if you have COVID, you're also more likely to have a stroke. So we absolutely encourage our community to get vaccinated. There was, like asthma community, there was a lot of concern. You know, people who have had a stroke are on blood thinners, so they're worried about bleeding or clots, but the risks outweigh the benefits. So we absolutely encourage people to get vaccinations because of those impacts on survivors of stroke with COVID.
I had just one more question, which is, if we're looking at excess mortality and we've got to take a rational approach to make sure we're not looking for excess mortality in the wrong place. So while it's legitimate to say, look, we've got to understand vaccination and whether that's had a good or a bad impact on excess mortality, I would contend that it's had a good impact and it's reduced it, but there are some conspiracy theories that might suggest that are suggesting otherwise. What happens to, I guess, the sense that comes from the community when we're not looking to the right place, if you like, about how we protect ourselves from excess mortality, which is going back to things like preventing stroke and preventing asthma and all the broader public health questions that are evidence-based.
So the Stroke Foundation is an evidence-based organisation, so we always direct people to the Stroke Foundation website where we have the evidence base and simple messaging that people can read, but then if they need further questions, reach out to our stroke line. Because as you say, there is so much misinformation out there that people latch onto, so it's always guiding us back to the source of truth, leaning on the Department of Health website, making sure that we link into really credible sources.
Thank you.
Senator.
And for the asthma, Senator. Yes, Asthma Australia also. We saw our role being very important. Indeed, we have up to 500,000 visitors to our website. So it was very clear the importance, critical importance of us being a source of truth and a source of evidence for people with asthma, because they did rely on us for that. Indeed, we task ourselves, oblige ourselves to reproduce information that's of the highest evidence standard, and also refer to the Department of Health guidance around those communications also.
Senator Askew.
Thank you, and thank you everyone for your time and for your evidence this morning. I just wanted to start with Asthma Australia and in your submission, and you've also made comments earlier about it, about in 2021 the number of deaths in asthma-related deaths was much lower, and it was relating, you think, to the steps that have been put in place to prevent COVID spread. Can you just elaborate on that, and then comparatively why we ended up with so many more the year after, like in 2022? How that impacted?
Yes, thank you, Senator. I might take that question and then perhaps hand over to Anthony if he has anything to add. So asthma deaths indeed reduced in 2021 by 30%, and when we look at that, the evidence, it suggests that it was due to the implementation of public health measures which reduced the prevalence of the asthma triggers in the community. And they were, if you look at the data, the reported case of influenza and the reported cases of the respiratory syncytial virus, RSV, were also dramatically reduced at the same time, and also a reduction in pollution. So they were all asthma triggers that, and so the data strongly suggests that it's linked to the reduced asthma deaths. In the subsequent year, the COVID restrictions were removed or relaxed, and so there were higher rates of influenza and RSV, etc., which were the triggers for asthma. So those people with asthma were exposed to those increased cases of influenza. Anthony, is there anything else you want to add to that?
Just to reinforce, Doris, that for a person without asthma, a virus might mean a few days off and a box of tissues, but for a person with asthma, it can be fatal, and that's it's a leading cause of a life-threatening flare-up.
So just following on from that, we haven't got 2023's figures. What sort of reflection is there in that? Has it reduced back to more similar numbers to previous years?
I think
I don't have this.
Yeah, the forecastings, we haven't done any forecasting, but we can imagine that there will be a proportionate level of mortality proportionate to the number of influenza cases, RSV cases and other circulating airborne respiratory infectious diseases.
Okay. Thank you. Just while I'm staying with Asthma Australia, just any thoughts on how we should be preparing for future health emergencies then? Because obviously we found with that case, through the COVID era when everybody had all those extra preventative measures in place, there was that reduction. What should we be doing as a nation to try and prevent them for the future?
Yeah, so in our submission we did talk about continuing the promotion of some of those public health measures, acknowledging that some are not practical in a non-pandemic situation, but the promotion of good hygiene, staying at home when unwell, regular influenza and COVID vaccinations being accessible to everyone in the community, reduction of air pollution from avoidable sources, and ensuring buildings and homes have appropriate ventilation. I might ask Angela to give more information on that, because that's actually quite important point as well in terms of promoting the public health measures. Angela?
Thanks, Doris. I think in terms of preparing for inevitable future respiratory pandemics, of course, the lessons we learned around hygiene and good health practices of staying home were really important. But one of the really critical things we should be doing generally to improve health outcomes across a range of different areas, including asthma, is reducing avoidable sources of air pollution. And I think one aspect of that is there was quite a lot of research going on during and since the pandemic around air pollution compounding COVID disease in people, so the two working together. And we also know that during the pandemic, anyone who lives in a populated area would have seen the streets kind of emptying out, and we can't require people to stay at home permanently. But what we can do is reduce sources of air pollution for example, encouraging people to move towards active and public transport, having stronger policies to support that, transitioning to electric vehicles, for example, and of course reducing reliance on coal-fired power stations. So this is a critical area for improving asthma outcomes generally, and in terms of pandemic preparation, we have new Australian research that has actually explored the kind of health benefits we could expect from a similar reduction in air pollution to what occurred at the beginning of the COVID pandemic. And they've demonstrated a 27% decrease in excess mortality, which is quite significant.
Definitely. Thank you for that. And air pollution is obviously an issue, and I know even here in Tasmania we've had reductions of smoke, removal of smoke, fire burners, wood burners and so on, so that they could do that, just because of, especially where I live in the valley. So that's great. Thank you. I'll just quickly, I know I'm really conscious we're tight on time, go to the Stroke Foundation. And just in regard to you mentioned in your submission about how many less heart health checks were conducted during the period of the pandemic. Have those numbers returned to normal? Reflection?
Yes, they've definitely improved. I'll have to take that on notice to exactly what numbers we're up to now, but there was a significant dip, and I think the contrast between those areas that didn't have such a severe pandemic as in WA and Queensland compared to Victoria and New South Wales, that's quite telling. The smaller numbers in WA and Queensland, the larger numbers in WA and Queensland, people are still interacting with their primary care, whereas in Victoria and New South Wales, etc., people were just not getting health checks, and that's all in the numbers. But they have returned, but I don't know exactly what numbers they're at now.
Okay, and so as a result of that, so obviously the number of deaths that were recorded because of people with COVID sounded pretty extreme, but obviously now if we are back on track, things will start to return. But the numbers of stroke deaths since COVID, has that levelled out to more to pre-COVID numbers, or is it still elevated?
Yes, so the age standardised rates, mortality rates for stroke actually trend downwards. So in 2021 they were 23 per 100,000, and now 24, and now they're 23 per 100,000. And that's because the treatments for stroke are improving. But what we are worried about is the disability after stroke. So during the pandemic, treatment wouldn't have been as quick, and as you know, time is brain, so people are left with more significant disability. And the other thing we saw during the pandemic, and that it's still having a hangover effect, is the disbandment of acute stroke and acute stroke units and rehabilitation units, and those things are the single most thing that have an impact on patient outcomes in terms of lives lost, disability, and independent living. And it was that disbandment of the acute and rehabilitation stroke units that was the real struggle for the stroke community during the pandemic, and is ongoing now.
Okay, I'm conscious of time, so thank you for that. I'll hand back to the chair. Thank you.
Thank you. I'm going to go to Senator Rennick.
Yeah, hi guys, how you going? My questions are mainly for the Stroke Foundation, if that's okay. I note that in your submission you note that basically the risk of stroke is increased in people who contract COVID-19 or experience long COVID. Is there any reason why you ignored the risk of vaccine injury in your submission there?
I think mainly because vaccinations actually protect survivors of stroke. So once again, it's that risk balance. The mRNA vaccines, there's no evidence to show that they cause an increase in stroke, so it's absolutely strong evidence there that survivors of stroke should get vaccinated. And there are a very few number of cases that have had a stroke subsequent to the AstraZeneca vaccine, and that's with a rare clotting disorder.
Okay, thank you. Have you read the product assessment report for the Pfizer COVID-19 vaccine?
No, I haven't.
Just for the record, it's been released by the TGA and it's not a conspiracy theory, just so that Senator Pratt's aware of that. On page 27, it talks about the results of the testing on the Pfizer trial, and it shows that people who received the COVID vaccine had a 250% greater risk of a nervous system disorder than someone that got the placebo. And I'll also note that there was actually missing information on the use of the vaccine in frail patients with COVID comorbidities, for example, including chronic neurological disease and cardiovascular disorder. Given the lack of evidence in the trials around the COVID-19 vaccine, are you still convinced that there's no risk at all from vaccine injury in regards to people getting strokes?
I would like to read that report and also delve deeper into the neurological disorder, because that's a huge spectrum of diseases, and we can get back to you on that one.
Well, can I ask why you didn't read it before you appeared today? Because obviously a product assessment report goes with every medical product that's released by the TGA, and it just strikes me as incredible that the number of people that will come and appear before an inquiry that hasn't actually read the product assessment report regarding that particular medication.
We take our advice on vaccinations from the Department of Health as the source of credibility. As I said, I will read that report and get back to you.
Okay, so then that leads to my next question. Have you read the non-clinical evaluation report released by the TGA in regards to the biochemistry of the vaccine? And in particular, have you noted the fact that on page 19 that the vaccine uses mRNA that has been optimised to increase the expression of the spike protein, and that spike protein has been found to last up to 60 days, the vaccine spike protein has been found to last up to at least 60 days in the blood of people who've received a vaccination, COVID vaccination?
No, I haven't read that report.
You haven't read that report either? Okay.
No.
Are you aware that the natural nucleotide uridine was replaced with methyl pseudouridine for the purpose of ensuring that the mRNA lasts longer in the body than the normal synthetic natural mRNA?
No, I'm not aware of that.
Okay. Are you aware that a normal dose or a standard dose, 30 micron dose of the COVID vaccine had 13 trillion mRNA strands in it that are capable of producing at least up to 100 spike proteins in the actual, for each mRNA strand, which is a much greater dose than a natural virus the body would receive from a natural virus?
No, I'm not aware of those reports. What I can do is we can get back to you. My expertise is more in stroke rather than vaccination, so we do take our guidance from the Department of Health.
Okay, because the reason why I asked that is that the spike protein has been shown to damage the heart and cardiac and also the veins and the arteries. I would have thought that this is something that the Stroke Foundation would be interested in, is the impact of the long-lasting spike protein from the vaccine and that impact on the cardiovascular system and clotting and then strokes.
Yes, I appreciate that, and we will read the report and we will get back to you.
Okay, and just one last question. Is it true, are clots capable of causing strokes?
Sorry, can you repeat that question?
Are clots a leading indicator for strokes? Not that I know strokes can be caused by numerous factors, but is clotting one of them?
It is, yes.
Okay, thank you very much.
Thank you. I'm going to go to Senator Roberts.
Thank you, Chair, and thank you all for appearing here today. Could I table a newspaper article written by an economist in Australia, please? I'd like to put the first questions to Dr. Murphy from the Stroke Foundation. Your submission is clear. I won't go into that in detail. You mentioned in your statement that you're busier than ever since COVID. What I'm aware with my statistical training is that statistics and data analysis are not just a matter of looking at numbers, they're also listening to people. Now, my understanding is that strokes, and I'm ignorant of this topic, strokes are caused by potentially many factors, neurological, blood supply. You've just confirmed with Senator Rennick on blood clotting. Is that correct?
That's correct. So there's two main types of strokes. There's strokes called ischemic strokes, which are due to blood clots, and then the second main type is hemorrhagic strokes that are due to bleeds.
Due to?
Bleed, so a blood clot, a blood vessel bursting and causing a bleed.
And also interaction with the neurological system?
Yes, so once a blood clot or a bleed has happened, then blood supply to the brain is cut off, so you get death of brain cells at the rate of 1 million per minute. And then, depending on where that bleed is, will depend on the ongoing symptoms of the stroke.
Thank you. I had a talk with a funeral director recently. She's been in the business 30 years. She's noticed that in the last 3 years, since the introduction of the COVID injections, there have been many more reports of deaths due to cancer, stage 4 very, very quickly. I think the term is turbo cancers. I don't like the term, but very quickly onset. Heart issues, heart disease issues, autoimmune disease, enlarged hearts, sudden deaths, every age, including babies, have increased in frequency. In the womb, it's also increased frequently. She's also said, and she's been talking to other funeral directors as well, that they're having difficulty embalming people. Now, this was made an international issue by a famous interview in the United Kingdom by Dr. John Campbell, I think, of a funeral director, but it's occurring in Australia. She said that these difficulties in embalming people were not seen 4 years ago and prior to 4 years ago, and she said that coroners are telling families that hearts are really suffering and causing deaths. So are you aware of this significant increase in clotting, according to the funeral directors?
I haven't seen any scientific papers on that evidence from funeral directors. Is this an evidence-based paper, or
this is their own personal experience? Their own personal experience. As I said, statistics involves more than just looking at numbers. It involves listening to people.
Yes, but if I haven't got a paper on it with the information and the statistics with that.
You're aware that AstraZeneca was withdrawn and it was associated with increase in blood clotting?
Yes.
Thank you. My questions now go to the document tabled for the Asthma Foundation. You won't have the document, of course, but I will go to, so that people can follow, bottom of page 5, the last quote there. I'm going to read several quotes for the Asthma Foundation, and I'd like your opinion. I think also Dr. Murphy from the Stroke Foundation said, quote, "Do you take advice from the Department of Health?" You then said, "You take our guidance from the Department of Health." Anthony Fauci is an American doctor at the head of the health agencies in America. He's called America's doctor. So I read from the article written by Adam Crichton, who's a very well-respected journalist, economist, who uses facts. Quoting, "This week, British newspaper The Telegraph reported studies suggesting the vaccines in part could be behind the surge in excess deaths in developed nations after the rollout began, something unthinkable only a few years ago." Adam Crichton goes on, "Fauci, the top doctor in America, had assured Americans, indeed around the world, he assured people around the world, the vaccines developed under emergency authorisation stopped transmission and infection, despite clear evidence from the start they did not." I'll go on, Adam Crichton, then quotes from Fauci under testimony before Congress last week. "It's important to point out that something we did not know early on that became evident as the months went by. The durability of protection against infection and hence the transmission was relatively limited," Fauci testified this week. I'll continue with Adam Crichton's comments. Quote, "In fact, in late 2020, the US Food and Drug Administration already had concluded that, quote, data were not available to make a determination about how long the vaccine will provide protection, nor is there evidence that the vaccine prevents transmission of SARS-CoV-2 from person to person." Are you aware of these developments in the United States, Mrs. Whitmore?
I haven't read that article, but I do know that Angela has some information that she could probably share with us.
Yeah, I would just refer back to our submission, which shows that asthma deaths decreased during the pandemic. So we're here to talk about excess mortality during those years, and as we say in our submission, asthma deaths actually decreased. So we don't have any comment on that.
Okay.
Last question, Senator.
Well, I've just referred to, here it is, Asthma Australia's submission. You said there is a significant opportunity to learn from the COVID-19 pandemic. Could you tell me what the most significant are, if they're not listed in broad terms in the submission which I've read. What are the greatest opportunities to learn from the COVID-19 pandemic?
We would refer to listed in our submission.
Sorry?
We would refer back to the opportunities that are mentioned in our submission.
Oh, the broad opportunities?
Yes, so we're talking there about public health measures and reducing air pollution from avoidable sources.
Thank you very much. Thank you, Chair.
Senator Babbitt.
So this question is for Asthma Australia. So your submission states on page 3 that many of the pandemic public health measures are not acceptable or practical today. What do you mean by that? Were there some measures that were implemented during the pandemic that should not be repeated, or should we just do it all again the same way should another pandemic occur?
I think Sorry, Doris, do you want to speak to that?
I'll just make one comment and then hand over to you, Angela. The not acceptable and practical today, we've recognised that there are a lot of learnings and many different states and jurisdictions approached COVID and the management of COVID in different ways, and so there's a pragmatic and practical element, and we support all the evidence around protecting people with asthma, whatever they may be. And what we've done is highlighted those public health measures that will reduce the triggers for asthma for people with asthma, and help them manage and control their condition better. Angela?
I think that was a great answer, Doris. I don't have anything to add. Thanks.
All right, this is to Asthma Australia again. Now, you state in your submission that public health measures, including mandatory vaccination, help protect people with asthma. Now, ignoring the significant human rights issues, for this to be true, you'd want the vaccination to be effective at preventing transmission. Now, we know for a fact that COVID-19s did not stop you from catching or transmitting the virus. They were not even tested for transmission by their sponsor prior to approval. Now, can you explain in detail how mandating a novel vaccination that does not stop transmission protect people with asthma?
I'm not sure that we actually talked about mandating, but Anthony, perhaps you can answer this question.
Sure, thanks for the question, Senator. Look, to the best of our knowledge and understanding of the evidence, there is strong evidence to suggest that COVID vaccinations prevent the transmission of disease between people, as well as the experience of severe disease amongst people who contract COVID-19. So we were confident that this was one of the important public health measures that made a difference and supported people with asthma to avoid the harm that they would have otherwise experienced.
Now, you said that there was evidence there. What evidence are you referring to? Can you provide on notice if you can't provide it now?
Yeah, I'd be happy to provide that evidence on notice, Senator.
Okay.
Thanks.
Next question to Asthma Australia again. Did Asthma Australia mandate its workforce or recommend the mandating of vaccine? If you did mandate your employees, do you still have mandates today?
Anthony, I might ask you to answer that question because I wasn't actually with Asthma Australia at the time, so I would not have those facts. Sure. I would have those facts.
Yeah, sure, Senator. We implemented the policies and I guess the requirements as imposed on us by the governments in the states that we operate. So where we were required to ask our employees to obtain a vaccination to abide by that legislation, then we did so. We don't continue to mandate our employees to obtain COVID vaccination, okay, to the best of my knowledge now.
All right, great. So there are quite a few industries where vaccine mandates still exist. In your opinion, should they still exist or should we get rid of them?
This is outside my level of experience and...
In your personal opinion?
Sorry, Senator, I can't provide my personal opinion on this.
Okay, all right. We'll move on. So my office
1
is...
minute, Mr.
Yep. My office is contacted every single day by victims of vaccine mandates. Some have been injured, some have experienced the death of a loved one. Given what we know about COVID-19 vaccines today, mRNA vaccines today, how can we in good conscience ever mandate a vaccine again? How can we do that?
I can jump in there and just say that's it's really sad to hear that people are having that experience, and we genuinely feel sorry that people have lost loved ones, and that's always a tragedy. I think we will always follow the best evidence from our respected health authorities, and that will guide our actions in any future events, and we do absolutely continue to recommend other vaccines in accordance with the guidance from our health authorities.
All right, I've just got one last question because I'm out of time, but this question is for the Stroke Foundation. In your opinion, have the authorities taken adequate steps to get to the bottom of long COVID or long vax, as some are calling it, or is it being not looked into as much as what it should be?
I think there's always more research that can be done, and we're still early days post-pandemic. There's still COVID in our communities, so there's more research that needs to be done. In terms of stroke and COVID, we do know that it's, and long COVID, we do know that it has an added impact. It causes fatigue, and stroke causes fatigue. And then we do have concerns regarding prevention of stroke, because somebody with long COVID cannot exercise as much as they should do and things like that. But always more research is welcome.
That's it. Thank you.
All right, thank you very much, and really appreciate you giving your evidence today. The committee will report to the Senate on the 31st of August 2024 and request that answers to questions taken on notice are provided to the committee secretariat by close of business on Friday, 21 June 2024. The committee will now suspend for lunch and will recommence at 2:10 p.m. Thanks very much, everyone.
Thank you for your time.
Thank you.
Thank you for appearing before the committee today. I understand that information on parliamentary privilege and the protection of witnesses giving evidence to Senate committees has been provided to you. For the Hansard record, could you each please state your full names and the capacities in which you appear today? And we might go from left to right.
Mrs. Cara Potter, I'm from COVINSURE, and here is a volunteer from COVINSURE.
Rado Filetic, Director and Co-founder of COVINSURE.
Andrew Madry, affiliate of Australian Medical Professionals Society.
Dr. Jayanti Kunnadasan, Treasurer of the Australian Medical Professionals Society.
Dr. Christopher Neal, Cardiologist and President of the Australian Medical Professionals Society.
I now invite you to make a short opening statement, and at the conclusion of any remarks I'll invite members of the committee to ask questions. So I might start with COVINSURE.
Thank you, Chair, and thank you to the whole committee for inviting us here today. We're the national patient-led and science-informed charity representing COVID vaccine-injured Australians. Unlike pharmaceutical companies and government bodies, COVINSURE has zero financial, political or other conflicts of interest at stake. We appreciate that our submission to this inquiry has been published by the committee, yet are simultaneously concerned that many other detailed submissions that address the health risks of the COVID vaccines have not. The main point we wish to emphasise from our submission is that our community of newly disabled and chronically ill Australians are not being investigated by authorities, medically, politically and scientifically. There is zero follow-up on our initial adverse reaction reports. This affects the integrity of official data collection, leading to a major shortfall in the acknowledgement and statistical appreciation of harms caused by these vaccines. Despite this, our numerous submissions to parliamentary and government inquiries detail the range of vaccine-caused medical conditions and some of the scientific understanding behind them. Where are these patients in government data? How is their chronic decline being tracked? How many have died? We note the rise in cardiac issues, one of the contributors to current excess mortality trends. It is problematic that those of us with vaccine-caused cardiac complications were often sent home from initial hospital presentations without appropriate investigations or treatment. People required multiple trips to hospital over many months before they were given investigative scans and properly treated. These instances are not rare, and women make up the majority. We also note Natalie Boyce and Katie Lees, whose deaths have been acknowledged by the TGA as vaccine-caused. Both cases were initially not acknowledged as potential vaccine reactions when they sought medical help. How many others have died or become chronically ill without appropriate investigations into the role of COVID vaccinations? We all know that official data can sometimes obscure worrying truths. We need only look at the Robodebt catastrophe as a recent reminder, which took multiple public inquiries and a Royal Commission to finally acknowledge the failures and harms. Today, it is time for our public health authorities to stop quoting from their own statistics on vaccine safety and on excess mortality and start addressing the fact that not a single one of these organisations is checking their data with the individuals who are represented by these numbers. We call for the government to establish independent research undertakings to review the public health failures we have described in our submission, and we once again call for a COVID Royal Commission that will examine these and many other critical issues that inevitably affect public health protections for all Australians. Thank you.
My name is Andrew Madry. I have an honours degree in physics and PhD. I'm a small business owner and work as a data analyst providing technical services to a range of industries, including medical technologies. I've been collaborating with the good doctors and nurses of the Australian Medical Professional Society for over 2 years now. This is typical of the work that I do in collaborating in multidisciplinary teams, pulling together a systems response to solve complex problems. I became concerned with the reporting of data early on in the pandemic and took it upon myself to look further into it. I found very often what was being reported was at odds with what the data tell us. I contributed a chapter to the AMP's Too Many Dead publication where I took an in-depth look at mortality in the state of Queensland, where there was no COVID in the community right up until the end of 2021. This showed the upturn in mortality trend occurring in older populations from mid-21, unconfounded by COVID. I coordinated the response from AMPS to this inquiry. It includes 6 chapter contributions from doctors like my colleagues here, nurses, journalists and analysts like myself. There's a substantial non-COVID excess that is continually accumulating. You can review this in our submission. It has not turned downwards as of the end of 2023. One of the possible causes of adverse health events and deaths are new medicines introduced and mandated to the public, promised to prevent serious illness and death. Here we are investigating unknown causes of excess deaths. We provide what may be the most comprehensive analysis available of the database of adverse event notifications showing COVID medicines account for 23% of all adverse events reported in the whole 53-year history of the DANE, and that's for all medicines. It takes up 38% of all cardiac disorders in the 53-year history. There are now 1,024 reported deaths. I'm grateful, Senators, for this inquiry to allow public and the specialists with the skills necessary to understand data to provide input for your consideration. Without understanding the causes, there's no chance of bringing this non-COVID excess back to zero in Australia, which has the envy position of one of the highest life expectancies in the world. Thank you.
I am an anaesthetist and perioperative physician and treasurer of AMPS. I'm also part of a group of volunteer researchers under the aegis of Daily Cloud IO who have investigated the publicly available documents that formed the basis of the Pfizer-BioNTech COVID-19 vaccine approval in December 2020. I'm one of the authors of the first peer-reviewed paper in the medical literature unaffiliated with the trial sponsor, which examined the original Pfizer COVID-19 vaccine trial data. To fully understand the issue of excess deaths, there needs to be proper scrutiny of the intervention that was implemented on more than 90% of the Australian population. That's COVID-19 vaccination. More than 50% of the Australian population took Pfizer's mRNA vaccine. At the pivotal point of Pfizer's vaccine approval in December 2020, there was a gross misrepresentation in what was presented publicly. Instead of the 6 deaths publicly disclosed, 4 placebo, 2 vaccinated, suggesting a benefit of vaccination, there were in fact 11 deaths, with more deaths in the vaccinated arm, 6. We found undisclosed deaths, especially in the vaccinated arm of this clinical trial, in contravention to legal and ethical obligations of trial sponsors. As a healthcare professional registered in Australia, I felt it was my ethical obligation to inform the TGA for possible breaches of good clinical practice. The exchange of letters with Professor Lawler is in the AMS submission, which I hope this inquiry makes public shortly, as well as an additional letter to be tabled. In 2022, I was investigated for more than 6 months by APRA when I said it was not honourable for the medical profession not to be able to tell their patients what, in their medical opinion, harms them. Despite the immense stress of the investigation, I stand by my words. Have doctors in Australia been able to give valid, informed consent for COVID-19 vaccination in the background of unprecedented government enforced coercion and incompletely scrutinised trial data by the regulator? If the clinical sponsor can hide deaths and autopsy results, ignore a sudden adult death and cardiac event signal in the clinical trial, with the regulator waving this along, what else can they hide? I hope this committee seeks these answers. Thank you.
I'm a cardiologist and the current president of the Australian Medical Professionals Society. Last year, on the 18th of October, we were in this building launching our 472-page book on the very subject of this inquiry. From a vaccine safety perspective, we believe that the pre-market phase of COVID-19 vaccination evaluation in Australia was deficient. Perhaps because of this deficiency, post-marketing surveillance with, quote, rigorous analysis of safety signals was to be the promised cornerstone of safeguarding the public. However, much about this process was non-transparent and against convention, most particularly the attribution of causality in the many suspected adverse reactions resulting in death. Given the access to data and independent analysis that we have, we can say that the signals were so impressive that one would have expected urgent intervention. If not product withdrawals, then at least new investigations or multiple public warnings. Consequently, when official mortality data became available for the rollout period, we and others were not surprised to see an abrupt and sustained mortality excess. Having access to this data allowed us to independently find the take-off point of excess mortality in Australia, which was mid-2021. But trends in particular states and age groups are highly instructive. In short, mortality take-off points fit with the vaccine rollout age group by age group, but do not fit with COVID-19 incidence region by region. No other postulated causal factor exhibits these key, consistent temporal relationships, and there are known biologically plausible mechanisms to support this contention. The literature now reveals the pathogenicity of the spike protein used in these vaccines, with concerns ranging from cytotoxicity to cardiotoxicity, from thrombogenicity to oncogenicity, and I could go on. 3 consecutive years into this trend, we put it to you that excess mortality has tragically become the most important signal in pharmacovigilance. Unexplained excess mortality continues globally and cannot now be hidden, receiving attention in peer-reviewed articles, in mainstream press and in public awareness. AMP strongly believes that the inquiry the people of Australia deserve must be full and exacting.
Thank you. I just have one question and then I'll move it round the committee. Just a question for COVINSURE. Could you tell us about how COVINSURE was founded and how many people your organisation represents?
Thanks for the question. Leading up to mid-2022, there were a number of us who had been discussing our injuries and the political situation we found ourselves in. And I had an opportunity to speak to a journalist who published some of my story, which caused a flood of people to contact me personally. And it was very clear at that point that this was far bigger than the number of people who had connected already online. And a group of us got together and said, we need to actually do something. We need to form some sort of organisation to be a representative voice. So that happened in mid-2022. So there's myself, there's 6 other people. And excuse me, the brain fog's got me a bit today. What was the second part of your question?
Just how many people now are members of your organisation, or would you be?
So we have some 750-odd people who have registered on our website. That's a fraction of the number of people we represent. We aim to represent all people who've been affected by these vaccines. The number is somewhat difficult to get a handle on because we have trouble getting accurate data out of the TGA, but we know, for example, the Australian Government's vaccine claim scheme, when that was launched, there were 10,000 people who signed up to receive information. So that's 10,000 Australians who had an adverse reaction serious enough to think they needed compensation. So from our perspective and from all the other bits of information that we've collected, we think that's a lower bound. The true number of people in this country could be 10 times as many as that.
Thank you. I'm going to go to Senator Pratt. Senator Pratt's online.
Thank you, Chair.
There we go.
And thank you to the witnesses today. Adverse reactions to vaccines are not uncommon. I recall a particular case in Western Australia where a flu vaccine was withdrawn because of adverse reactions in a child that meant the child ended up with a significant disability. Nevertheless, I'm a supporter of vaccination within robust systems to make sure that the quality of the vaccine and its public benefit is demonstrable. Can I ask in that context, do you have concerns about other vaccines or just COVID vaccination specifically? That's my first question. And how do you think we weigh up the relative benefits and costs, noting that we have a system that acknowledges that there have been adverse impacts on some people from COVID vaccinations versus the overall public benefit from getting vaccinated? Thank you.
So who was that question directed towards, sorry?
Any of you that would like to take it. I guess it's particularly relevant also to medical practitioners and your use of vaccination more broadly.
I'm happy to take that, Senator Pratt. Thank you for the question. The case you referred to with regard to the influenza vaccine was the rollout of paediatric influenza vaccine in 2010 in Western Australia, and that resulted in the Stokes report, a well-known report out of that state, which included, among other things, a recommendation for very robust and very independent pharmacovigilance. Of course, pharmacovigilance is the system I think you're referring to, which is to say the system by which we track reports notified mostly by clinicians to the TGA, and which is therefore a means of detecting signals. You're a supporter of vaccination. I also would say we are supporters of vaccination within informed consent, of course, and of course with correct risk versus benefit appraisal. In regards to the COVID vaccine, we are of the opinion, and we've been on the record of saying this, that the signals from Australia's pharmacovigilance database, which is the DAEN, the Database of Adverse Event Notifications, are very sizable. The TGA in an FOI explained the way they would handle signals. And as we look at the reports, 2 monthly reports of pharmacovigilance, according to the way in which the TGA pre-specified it would be looking at signals, we find between 642 and 848 highly significant signals. Now, these obviously we can't go through these, but these include diagnoses which are not publicly appended to vaccine injuries. We know about, for instance, myocarditis, we know about certain blood clots with the AstraZeneca vaccine, but these included acute myocardial infarction, stroke, deep venous thrombosis and pulmonary embolus, to name a few, but important examples because they have a high mortality. We believe those signals should have been acted upon, but in fact very few in the medical community know about those signals.
Thank you. Can I ask, in that context, how, you know, it's a quickly moving feast where you've got, in a response to a pandemic where we're trying to weigh up the public benefit of the vaccine, and I support the public benefit that's been acquired in this case from getting vaccinated, according to the evidence that I've seen. Nevertheless, I do believe it needs to be tested robustly in terms of how our health agencies engage with pharma companies. What can we do quickly in a pandemic context to make sure that's robust? Like, it is, you know, we do have to weigh up relative risks, weighing up whether we think something's going to be effective, and that the cost-benefit analysis means that we should rely on the evidence provided versus versus making greater inquiry about it before something goes ahead. You know, we didn't have 10 years, if you like, to develop a vaccine in this case, and Australia had much lower mortality in many cases than lower vaccinated countries from COVID.
Senator, perhaps I could answer that question from a data perspective. You know, what do we need? We need real-time monitoring systems to, you know, in this critical situation, the money needs to be put in to enable those systems. As Dr. Neil just mentioned, you know, in terms of pharmacovigilance, we're looking in the COVID context at excess mortality numbers as being the signal. And the problem with that is that the Australian Bureau of Statistics has become the source of that information. Now, that's not their job, as I understand it. And if, you know, when analysts look at the ABS data, it takes, you know, the death happens, it gets reported to births and deaths. Then it takes, there's an administrative process of at least 3 months for that to come through. When we look at the ABS data, it takes another further 3 months for the data to stabilise as, you know, coroner's reports come in. So clearly, you know, a lag of something like 6 months is not enough to, you know, to detect these changes. So, you know, and it should be possible to have real-time reporting systems put in place in a context like this.
Well, I would think in hindsight, and this is probably something we can look at how we recommend, that ABS and the Australian Institute of Health and Welfare have said that they're now going back to look at immunisation status overlaid with health outcomes and COVID deaths, and in relation to that data as to, you know, how did they demonstrate that there was a public benefit to being vaccinated versus the unvaccinated in the level of death, and there wasn't, those data connections aren't there, but they are now being made. Is that the kind of real-time data that you're talking about?
Yes, Senator. I think that's exactly the point. I think that's excellent suggestion, and we would hope that independent groups like ours could have access to that data, and it's even more complicated than that because the joins, we're joining data between different departments, and there can be issues and mismatches, and then and analysts know how to handle that sort of thing and understand the uncertainty. So I would welcome that, and I'd like to.
So there is access to data. Sorry, I'll let other witnesses answer as well. But there is access to data that researchers can apply for, subject to ethics approval. Is COVINSURE making an application? And do you have any reason to believe you wouldn't be successful in also having access to that data?
Sorry, you mentioned COVINSURE. We don't have the capacity to do that type of work. We're all pretty crook. But I think you meant AMPS.
Yeah. So, Senator, I'd like to just add on to that answer. So, for a doctor, you would support an intervention where there's a need. All right. So very early on in the pandemic, Professor John Ioannidis actually published the infection fatality rate for this illness, and for basically anyone less than 70, the risk of dying is 0.05%. So it would have to be a stratified response according to people's age group, their individual health, and you have to, and as an author in the first peer-reviewed data that actually looked at the Pfizer COVID-19 vaccine data, one thing I want to actually emphasize, at no point during the trial was the intervention life-saving. If you align the deaths along as they occurred along the timeline, at no point in this trial was this intervention life-saving. So we can talk about vaccination as an esoteric, but ultimately every doctor should have been allowed to treat the patient in front of them to the best of their ability, and because it's a pandemic situation, with the best. The data is evolving. All doctors should not have had the unprecedented fear and coercion that was put on the medical profession in COVID. That is unforgivable. It has cost lives and it has damaged the medical profession.
I think there would be other doctors that would refute whether or not your assertion that the vaccinations help save lives, but I'm not a medical practitioner, so I will leave that to others.
I'm only speaking to the original Pfizer trial data. And as I said, on the original Pfizer trial data, on publicly available documentation, if you line up the deaths that occurred in the trial along the 6-month period, at no point was the intervention life-saving.
Okay, well, I will take that statement, and I can only ask others in relation to that. I think also what you were referring to in those answers is the relative, I guess, the moral risks of if we vaccinate a healthy population. So in the case, for example, of Saba Rose's vaccine reaction in Perth that did lead to those findings and that review, that was purportedly to protect infants, but in other cases we have more universal vaccination so we can protect those that are older or more vulnerable. Are you talking here about the relative risks of whether a healthy person who might survive a COVID bout but has an adverse reaction to a vaccination, whether that's not, any adverse reaction from them needs to be weighed up against that moral dilemma of why vaccinate them. If you don't vaccinate them, then more vulnerable people might be at risk. But equally, I would also, I want to ask you about that relativity first. And then secondly, in many instances, yes, it can be demonstrated that there was an adverse reaction to the COVID vaccination, but that they are the same reactions that many healthy people would have also had from a COVID infection. Thank you.
What we see in our patient groups, the people who are suffering the most significant adverse reactions are not the people, generally speaking, who were at risk of COVID. So exactly as you said, there is a stratification there. The people who are not at the most risk of the COVID appear to be at a significantly greater risk of having a very serious adverse reaction. And when we're talking about weighing up risk benefits, it would be fair enough if everybody in the community was equally at risk of this new pandemic virus. Unfortunately, that was not the case. Yet we treated everybody as though they were. And that sacrificed one group of people for the potential or purported benefit for another. But complicating that strategy, in addition, was the fact that these vaccines did barely nothing to prevent transmission anyway. So the younger people who were getting vaccinated to protect more vulnerable people, they weren't actually protecting those more vulnerable people. From our patient perspective, we just see so many people who are living full, active, very vibrant lives, and that's been destroyed now. People who didn't need to have the vaccine but felt compelled to, or they were coerced to, in order to protect their community or protect their family, or even if they thought COVID was a big risk for themselves, but actually wasn't.
And that's a fundamental difference between the vaccines we were talking about, which were paediatric vaccines, which are designed to have sterilising immunity, so you don't catch measles, you don't catch those childhood diseases, whereas that clearly was not the case with the COVID vaccines. They were they weren't sterilising, and the benefit was supposedly intended to stop severe illness and death, and that seems like that's a personal judgment rather than the other case creating a herd immunity.
Senator Pratt, I'm going to move on the call and I can come back to you at the end if you have anything else. Senator Rennick.
Hi guys, how are you going? My question is for you, Dr Neil. So just to confirm, you are a cardiologist?
Yes.
Okay, thank you. Is it true, I know you said in your opening statement, that the spike protein is pathogenic?
Yes, so the way I'd answer this question is that the spike protein is a very, very well-studied protein. It's the main pathogenic protein, the main virulence determinant of SARS-CoV-2 viruses. And as such, it's been known to cause toxicity to blood vessels and cause blood clots in COVID-19 disease. The spike protein is the protein produced by mRNA and DNA vaccines, and it is the protein in the Novavax vaccine. So all Australian vaccines also contain the spike protein. And so whilst we recognise that the spike protein in COVID-19 disease is pathogenic, we are also able to recognise, therefore, once your eyes are open to that, that the mechanisms of vaccine harms are likely due to spike protein. Now, I've written a peer-reviewed paper on this, which I can share with you later if you'd like, but there are unfortunately many different mechanisms of harm associated with spike protein, and I think that's why it's not surprising to me that there are also many pharmacovigilance signals in the Australia's database and in databases of pharmacovigilance right around the world. And as I said before, many of those conditions are high mortality conditions which become relevant for today's discussion of excess mortality.
Okay, thank you. Very good answer. Are you familiar with have you read the TGA non-clinical evaluation report?
Yes, I have.
You have? Oh, that's nice to know, because a lot of the government officials haven't. But you'll be familiar on page 19 that they optimised the codon sequence in the mRNA strand to increase the expression of the spike protein. Now, I was always told that vaccines were attenuated to give you, i.e. weakened, to give you a smaller dose or a lesser, toxic dose of the virus, not a strengthened dose. Why, if you're trying to develop a vaccine, would you make the vaccine, the concentration and the expression of the pathogenic part, i.e. the spike protein, stronger, not weaker? Does that make sense to you from the point of view, knowing, and I'll just add in the point that there's also this vaccine used two lipids, ALC 0159 and 0315, which was designed to increase the transfection potency of the vaccine. So there's two questions here. Why would you, A, make a vaccine that's stronger? And then why would you make a vaccine that can enter any organ of the body, not just an organ with an ACE receptor, which is what the virus could do? So this is more pathogenic, more infectious, including the heart, which I presume myocarditis is caused by the spike protein entering heart muscle. So two questions there, if you don't mind.
Thank you. So I would emphasise that at the time of the introduction of mRNA vaccines into the market, there was very little in print really delving deeply into the multiple new aspects of the vaccine, and some of that which was published was misleading. For instance, that the vaccine would simply stay as an intramuscular injection and operate from that site, or perhaps moving into the lymph nodes, etc. We now know, as you said, that the lipid nanoparticle disseminates and therefore carries the mRNA and other nucleotide contaminants into cells all around the body. So it has the capacity to be introduced to organs which one would not expect to be exposed to a protein such as the spike protein. You mentioned pseudomethyluridine, the way in which the synthetic mRNA was modified to prolong its duration. That led to an unknown of how long would this spike protein be produced. We know there were many assurances that it would only be produced for a few days, but in many independent peer-reviewed articles we find examples of spike protein which is vaccinal and not viral, persisting months, and in one case 200 days. So these are things which I feel were not really represented to the medical public well. You mentioned myocarditis in your question, and it's a complex pathogenesis, but it does appear that it is the result of spike protein being expressed in the tissue of the heart and then provoking both an injury and a secondary autoimmune injury. But that raises a point that all organs that might be affected by presumed or suspected vaccine injuries can actually be studied with simple techniques to see whether in fact the spike protein has been produced as a result of vaccination. And by the same token, there are protocols for ensuring that that's not the virus. And so that's something which could have, I think, brought more clarity to what we've seen.
Yeah, thank you very much for that, which leads me to the next question. I'm not sure. Do you think it was reckless for Pfizer to roll out this vaccine, noting that on page 4 it is noted, and for TGA to approve it, when they say there was no distribution or degradation data on the S antigen encoding mRNA, so this was a novel spike protein using synthesis, step 1, and that they also did limited pharmacokinetic studies on the two new lipids as well. So they've effectively got a new novel spike protein, new lipids, and they changed the manufacturing process from phase 1 to phase 2 that involved the use of DNA, and that itself wasn't tested either. Do you think it was reckless for Pfizer to roll it out and TGA to approve it, given that there was no studies done on these important pathogenic risks?
So the lack of pharmacokinetic and pharmacodynamic data which was available at the time of the rollout of these vaccines is very unique. It's very much the exception in registration of pharmaceuticals, and it is acknowledged, perhaps because of those and other reasons, by the TGA at the time of the provisional registration that long-term safety data wasn't known. And I think it's because of that that they committed to quote, very rigorously look at safety signals. Our contention is that the safety signals were there, but there was no response. So yes, they collected the data, but there was no appropriate response in our opinion.
Okay, thank you. And last question, Chair, to Mrs Potter. Are you vaccine injured, Mrs Potter? And if so, could you please describe your injury and how you've had to deal with it, please?
Yes. I received my vaccine injury from my third Pfizer shot, which was my booster shot on the 8th of January 2022. I started with pericarditis, but the inflammation was much further spread than just in my heart. It went through to my lungs and further to other parts of my body, including my brain. Over a period of about 5 months, I was quite acutely unwell. Spent multiple trips into hospital. Spent about six weeks in hospital overall, trying to recover from just that initial acute injury. But since then I am now chronically ill, disabled from the vaccine. I am no longer able to work or drive or do many things at all. Really, it affects my whole body, my capacity to think and speak, my ability to walk, my regulatory system is completely disorganised. So it has had a major catastrophic impact on myself and my family.
And has the federal government recognised your vaccine injury and compensated you appropriately for your injury? Along with, have you received adequate medical support from the medical community, including respect as to your injury?
I have not received compensation from the federal government. I am one of the very fortunate people who fit within the very small category who could qualify for the vaccination compensation scheme because I fit into one of the 11 categories of adverse reactions that qualifies for the compensation scheme, and I was hospitalised for that adverse reaction. But I had to wait till you have to wait for things to finish before you can do that. For me, I have to wait for all your other forms of insurance to be able to come through, and I am still waiting for my TPD insurance to be finalised. So that is taking a long time because, like for many vaccine injured, we find it very difficult to have all of our medical things confirmed and agreed upon. All of these things take a very, very long time because our injuries are so new and so poorly understood. Cannot remember what else you asked. I'm sorry.
Have you received adequate support from the medical community in terms of your injuries?
I have had varied levels of support. I was very fortunate. Unlike many people, my GP recognised my injury to begin with, and I am actually grateful to my GP that I am alive because she recognised I had a vaccine injury. But I have had interactions across multiple hospitals and with many specialists, and not all of those have been as positive. I have only just received some of my medical records back, and in some of those records I've seen that some of the gaslighting of me, that has been done to many of the vaccine injured was also done to me, where the doctors who were saying one thing to me about what they were being quite supportive to me face to face, but in my medical record they were writing things about me suggesting that I was having some kind of psychological event, whereas I have got a long list of experts that have looked at my case and have attributed it to the vaccine. So that is very typical for the vaccine injured, particularly women my age, and we make up a large number of the vaccine injured, that it is very easy to gaslight us with that kind of statement. Yeah.
Thanks very much, Mrs Potter. I appreciate your bravery.
I'm going to go to Senator Roberts.
Thank you, Chair. Mrs Potter, I feel very ashamed of our country. You have been, as a result of lies, you've had your life altered completely, and what we've given you instead of care is gaslighting. But thank you so much for your courage in being here. And I also want to put on the record my appreciation to Senator Rennick for his previous two questions that Dr Neil answered, and answered so capably. Fine questions and excellent responses. Mr Falachuk, you've come before us at the Terms of Reference inquiry. I want to thank everyone for being here in person. Thank you for your commitment. You said in your opening statement, Mr Falachuk, newly disabled and chronically injured, and there are thousands of them. You also mentioned in the Terms of Reference inquiry that doctors were coerced. So I don't need to put questions to you. I would love to, but I've got some other questions. Dr Kunadson, you mentioned, quote, peer-reviewed paper unaffiliated by trial sponsors Pfizer. Could we get that paper, please?
Yes.
On notice?
Yep.
You also told us that more than 50% of Australians took Pfizer, and I'd like to learn more separately on notice. I'll think of some questions for you with regard to your correspondence with Dr Lawler, because I've read it in your submission and I'm stunned. I want to also acknowledge the courage of your stance. And Dr Neil, pharmacovigilance, if I could just have a one-word answer at the moment, because I want to get on to Dr Madry. Pharmacovigilance is not independent, is it, in this country?
One-word answer. I don't believe it is sufficiently independent, and the access is very difficult for the average doctor.
Thank you. And could you send us the paper that you've published, peer-reviewed paper? Send it to us on notice, please.
Yes.
Thank you. Dr Madry, can you comment on the use of models used for predicting excess mortality, please?
Senator, I just want to thank Mrs Potter for you've moved me, and it's part of the reason we do some of this work. There's been an epidemic of bad modelling during this pandemic, Senator. Stanford professor John Ioannidis, published a paper about how bad modelling was. When we do modelling, we need to apply a range of models to look at best case and worst case scenarios. Models rely on assumptions. Those assumptions can be wrong. If I could just, I know the time is short, but a quick comment on the models that the government's relying on at the moment for predicting the numbers of excess. That model changed last year and predicted lower numbers. There's a number of fundamental issues with that model. It uses a time series modelling that one wouldn't use in a modern analysis, fitting a sine wave, which doesn't actually fit the sort of seasonal trends. There was a strange thing that happened from, the standard years were 2015 to 2019, and then, there was a decision to reach back to 2013, and it turned out 2013 is a low year for mortality, 2019 is a high year. So if you wanted to tip up, the baseline and make the excess less, that's what one would do. And in our submission, we've sort of provided a range of what it should be, because the estimates that are there at the moment are very much at the low end of the estimates, and we need to look at the low end, the high end, and the real result should be somewhere in between. There's another issue about subtracting all COVID deaths from and with. We know the convention shouldn't be to count the deaths that are with someone who dies from cancer, for example, who tests positive with a PCR test. They shouldn't be subtracted. We know influenza was down, and during those years. So should we be subtracting all those deaths? Because clearly some of the COVID deaths were deaths of frail elderly people who sadly would have died anyway. So if we're trying to come to what's the clear non-COVID excess, there's more professional ways to look at that. So all I can say, modelling is has been done poorly. That's well established, and I think independent groups like ours that can talk with what's really happening, have a better understanding, and can try and fit ranges to those models. Especially when it's a high risk situation where people are dying, getting injured, we need to understand what's the best case and worst case scenarios.
Thank you, Dr. Madry. What other data is needed to clarify what could be causing the non-COVID excess mortality? Okay,
so if we wanted to rule out COVID vaccinations as a possible cause of this excess, these data sets that Senator Pratt was talking about, where there's a linkage between immunisation registers and mortality registers. We understand that such joining of tables linking of tables has been done by the Institute of Health and Welfare and the ABS. Basically the data that's needed is the date of death, the date of last vaccination and date of death on an individual record basis, and we can go through that and find, if there's trends that shouldn't be there. They should be independent, but there could be trends that look in there, and if we can get access to that, we can provide some insight.
Do you intend to apply for access to that data?
Yes, we've had discussion. Since we've heard more about this, we do intend to apply for it.
Thank you. You said you did an analysis of mortality in Queensland. What did you find?
Okay, so Senator, as you would be interested, Queensland kept out COVID right up until the end of 2021. So with Queensland, we had a 10-month window where we could look at mortality without the effects of COVID. Any deaths from COVID in Queensland were from cruise ships or out of the state. So we purchased data from the ABS with sort of narrow age ranges. And what became clear was that in the older ranges, which is where we saw in the database of adverse event notifications, a lot of the deaths occurring, ages above 60, we saw the trend of mortality start going up in the second quarter of 2021, and that went up right up until the end of the year. So that was, clearly a warning signal.
Thank you, Senator Canavan has a question.
Follow-up here. Have you looked at Western Australia, which had a similar experience? When I look at the ABS data, again, the deaths seem to start ticking up in sort of late 2021, even before the WA border was open.
Yeah, Western Australia has a few more months because they opened up in March, I understand. Yes. We'd have a full 1 year window with Western Australia. So the reason I picked Queensland was partly financial, because there you have the largest state with the longest time. South Australia and Western Australia would be other ones that would be worth looking at.
Okay, thanks.
Can I have one more question? Okay. Dr. Neil, there are many ways excess mortality can be hidden. Classification of causes of death. Can you answer yes or no to each one, whether or not it's possible to hide a death?
So excess mortality typically just considers all-cause mortality. then there's a secondary sort of inquiry as to what the sub-causes might be.
So with doctors placed under coercion, we could hide a death due to a COVID injection by classifying it as not due to an injection.
So I guess there's two avenues to highlight a death as a doctor, which might be, which as a doctor you might have the opinion that it's a vaccine death. One would be by registering the death on the pharmacovigilance database, and 75% of the deaths were registered by doctors. The other would be to write a death certificate. I believe that's rarely done in a way which would note a vaccine injury as a cause of death, but it is possible.
Thank you. Dr. Madre, they can be statistically hidden or misclassified, correct?
Correct. Misclassification is one of the biggest problems we have as analysts.
A barrister that I talked to said that you can hide evidence and the best place to hide it is in plain sight.
That's a very wise statement.
Thank you. Are these things being done?
Is it being hidden? There's certainly strange things happening where, the ICD codes, there's, categorisation going into these vague categorisations from where, it might have been very specific, cardiac, respiratory. There are strange things going on. What we can do is we can detect those things happening. So that's, as you said, from a legal, from a, forensic point of view, being able to see those sorts of things is insightful in itself, even though it may make it harder to find the actual result we're looking for. But, that's important.
So keeping on the theme of hiding data, we can also have alternative narratives such as long COVID instead of vaccine injuries. We can also have the use of labels to denigrate people, shut them up, condition an audience that it could be something else, propaganda to sway people's perceptions. Any of these things tie in with you, Dr. Neil?
Well, we, as a society, we've been concerned about the culture in medicine that tends towards censoring doctors from speaking about some of the key issues of pandemic management, including the vaccine. We believe that's real. We believe we can document it, and it could well have had an effect on the information that's able to come to light.
Thank you. Thank you, Chair.
Senator Babbitt.
Thank you, Chair, and thank you to Mrs Potter for being here. I know it wasn't easy for you to get here, and I noticed Ro as well in the crowd there, so thank you for being here. And Ro's also vaccine injured, and I hope that in time you will get the justice that you deserved. And the wheels of justice turn very slowly, but I think there's a lot of people that have a lot to answer for in this country for what they've done. Yeah. So I'd like to say thank you, of course, to AMPS, the Australian Medical Professionals Society, for attending today. You've put in, obviously, an enormous body of work. You've even published an entire book on the topic of excess deaths. Now, your submission to this inquiry here is not up on the website yet, but I hope that it will be up soon. But thank you for emailing it to me ahead of time to review. I've got a question here for Dr. Kunad Hassan. Now, I've been struck by your communication with Professor Tony Lawler, who is the Deputy Secretary of the Health Products Regulation Group at the Department of Health. Now, as I understand it, Australia relied on pharmaceutical companies' own data when deciding if to inject almost the entire population with a novel product. In your letter to Mr Lawler, you talk about the undisclosed deaths in the vaccinated arm of the Pfizer COVID-19 vaccine trial that had a probable autopsy result at the point of the provisional or emergency use approval. Can you elaborate on this, and why is it significant?
Thank you for that question. So to understand this, the Pfizer COVID-19 vaccine was approved in the US on December 10th, 2020. The data cutoff date for that was November 14th, 2020. Pfizer looked at it for 6 days and then submitted it on November 20th. So publicly what was disclosed was at that point in the trial, there were only 6 deaths, 4 in the placebo group, 2 in the vaccinated group. But actually, if you line the deaths as they occurred along the timeline, it was 11 deaths. So now we have deaths occurring in the clinical trial that are not reported in a proper time frame. Death is a very serious adverse event, And you support, once the clinical site has been notified of a death, they're supposed to tell the sponsor no later than 24 hours, immediately. So we have documentation for one subject, subject 11141050. This subject died on October 19th, and this death was not publicly disclosed. This is a 63-year-old lady with a bit of hypertension, she's a bit overweight. So the clinical site was informed on October 19th. The death only made it into the patient's notes on November 25th. So that's a 37-day delay where it should have been immediate. And I've provided all this documentation, the page stamps and everything, to Professor Tony Lawler. And now November 25th is still before December 10th. So they still chose not to admit this extra additional death. And why I contend that there's an autopsy report, if you read the patient's notes, they say that the cause of death for this patient is sudden cardiac death, but the autopsy determined that the cause of death was sudden cardiac death. So on December 9th, there's a communication in the patient's notes saying sudden cardiac death. Should we change the cause of death from unknown to sudden cardiac death? So they had an autopsy report, at least on December 9th, because there's a specific diagnosis in the patient's notes, and this was not disclosed publicly. That's what I meant. And I have asked repeatedly that if the TGA has this autopsy, I think it's in the public interest that this be available for independent scrutiny. What the Pfizer said that this patient could not have died from the vaccine. So this patient's from the vaccinated arm, and that this patient died because of obesity and hypertension. So this patient's weight is 74 kilos. The patient is not obese. The patient's just overweight. And there's no documented blood pressure reading in the patient's note. So I don't find it credible that the TGA would have accepted that someone with a weight of 74 kilos and a height and a BMI of 27 is at risk of sudden death. So that was part of my correspondence with Professor Lawler.
Thank you. Now, Professor Lawler, he replied to your first letter on the 27th of March denying any breaches to good clinical practice, and he denied that there were any hidden deaths. He also said that it is reassuring to note that in this case, none of the deaths in the trial have been attributed to the vaccine and the initial conclusions remain valid. What are your comments on these remarks from Professor Lawler?
Yes, so I have not received any reply from Professor Lawler other than the first one where he said there were no breaches of good clinical conduct. And as I said, I provided date stamps again to him of the documentation for the relevant patients where there were hidden deaths. So with his statement that none of the deaths in the Pfizer trial were due to the vaccine, I went back and reanalyzed the data. So for this trial, there were actually more deaths in the vaccinated arm, 21, compared to the placebo, 17. Of the deaths in the vaccinated arm, only 3 of them had autopsies. But in the vaccinated arm, 10 of those deaths, 10 of the 21 deaths, were people who were sudden adult death found dead. They were people who died whilst they were in the laundry, people who had a cardiac arrest when they were walking, people who never woke up from their sleep, people who their neighbors called and said, there's a smell in this apartment next door. I think we need to, you need to go and check this. So there was a sudden adult death signal, found death signal, in the vaccinated deaths. Of that 10 sudden adult death found dead, there were only 2 autopsies, only 1 results available. That's the sudden cardiac death. The other autopsy report was the gentleman who was found in the laundry by his mother. That result is still not available. So in the first place, how do you say something can't be due to the vaccine if the autopsy result is pending? And for the other 8 sudden adult deaths, there were no autopsies. And I think it's really critical that people understand this. I can understand if there's a period of illness that's documented in hospital, there's no autopsy. But for people who die suddenly, people who were well enough to sign up for a clinical trial, and they die suddenly, and there's no autopsy, I have repeatedly asked the TGA for their evidentiary basis for the statement that none of the deaths were due to the vaccine.
What's your reply?
I haven't had a reply.
Right, okay. In your investigation of the original trial data for the Pfizer COVID-19 vaccine trial, you found delayed reporting of deaths in contravention to legal and ethical responsibilities of the trial sponsor. Other than the 2 deaths in the vaccinated arm not disclosed that you have outlined in your correspondence with Professor Lawler, what other significant findings did you and your co-authors find in your peer-reviewed article?
Thank you for that. So, as I explained to Senator Pratt earlier, at no point during the clinical trial was the intervention life-saving. At no point were there less deaths in the vaccinated arm. That's a very important finding. The other one is that only of the expected deaths, life happens. This was a very big trial. You'd expect a certain number of deaths. But what we found of the deaths reported were only about 18% of what's expected. And in fact, the number lost to follow-up at that point in the trial was actually more than the primary endpoint population of 170. So there were a lot of missing patients. There was a cardiac adverse event signal as well, 3.7 times higher in the vaccinated group compared to the placebo. So those were the main findings in our. It was a forensic analysis of the Pfizer COVID-19 trial. So this was the one trial that the TGA relied upon to actually approve the Pfizer COVID-19 vaccine and approve the emergency use authorization. So as I said, we are independent researchers, and it was a forensic analysis of the deaths.
May I jump in there, please?
Go for it.
Thank you. So you're saying TGA, you're confirming what the TGA told me in Senate estimates in March 2021. The TGA did no testing, relied on the FDA, which did no testing, and the FDA relied on Pfizer. That's all the basis of the COVID injections in this country.
That was the basis. I'm looking at the clinical data. You're talking about the pharmacodynamic, pharmacokinetics. So I'm looking at the clinical data in which, there are deaths and adverse events that happen, but deaths that happen that are in the clinical data and not actually transmitted. So at some point, deaths were informed by subjects' loved ones to the clinical site, but this was not disclosed publicly either in the EUA approval or in the New England Journal of Medicine publication. So it was not disclosed publicly.
And so you're saying that, are you saying that if the public had known there were more deaths in the vaccinated cohort than in the unvaccinated cohort, whether it's statistically significant or not, there would have been a whole lot of different perspective on these things?
I think it's harder to persuade the public to sign up for an intervention where more people died in the supposedly life-saving arm.
Thank you.
One last question to Dr. Neil. Now, Dr. Neil, are there problems with classification of COVID deaths in Australia, and how does this relate to excess mortality figures? Do you think COVID is the explanation for excess mortality in Australia?
Thank you. Dr. Madry's answered some of these issues. There are well-known problems with the diagnosis of COVID-19. There are well-known coding issues with the diagnosis. And in the context of metadata such as all-cause mortality, there can be other problems of classification. I think in regards to whether the phenomenon of excess death relates primarily to incidence of COVID-19 in the community, I think that's a very important question for this committee. Dr. Madry has alluded to the way in which the take-off point of mortality in Queensland goes up very clearly and very strangely in the second quarter of 2021, 8 to 10 months before COVID hits the state. So we have sort of temporal relationships which are very important in any causality assessment. When we look at the way in which deaths are classified with COVID or from COVID, the advice of the World Health Organization in looking at mortality is only to really factor in the from COVID, the infection type classification of death. And in the latest iteration of the Australian Bureau of Statistics model, unfortunately, both with and from COVID is included in that model, so we don't agree. I'd finish on the point that the average mortality, the average age of mortality in COVID-19 in Australia is about 86. That is the median, which is to say that half of the people who have unfortunately died from COVID-19 were over 86. And nevertheless, in the setting of excess death, not surprisingly, as documented in some of the other submissions to this committee, the life expectancy has had a downturn in Australia. And it's important to note that for the life expectancy to turn down, you would have to have deaths under life expectancy. And so clearly, in our opinion, COVID-19 deaths do not explain the phenomenology.
Thank you, Doctor.
Senator Canavan.
Thank you, Chair. Thank you again for your courage here today to tell this story. It's very important we have free and open debate in our democracy. I want to start with a statistical question here that's dogged me today as I've heard the alternative view. It would seem to me that the government agencies we've heard from, I suspect the department later this afternoon, are establishing a default hypothesis, a null hypothesis in a statistical sense, that the vaccine is safe and effective. And then it's up to everybody else to prove that the null hypothesis is wrong. And so when you push them, they say, oh, there's just no evidence that it's not safe and effective. But that to me seems to put things around the wrong way. I would have thought normally in a statistical test you would have the null hypothesis, sort of the default situation, that this thing doesn't help save lives, that the vaccine is not safe and effective, and the onus of proof, the burden of proof, should be on the drug manufacturer and the government mandating this to prove that it is safe and effective. Have I got that wrong? Is that a fair characterisation of how government agencies are approaching this debate?
Yeah, maybe that's a good analogy. It's, like the legal analogy of innocent between before proven guilty, whereas, if you're introducing something that is potentially dangerous, it should be guilty until proven innocent. And it does seem that the default, the null hypothesis, as you say, is that there's nothing to see, and therefore, if that were true, then you could use those assumptions to try and say, well, this must have been the baseline and all these sorts of things. But that's clearly not the case. There are, the issue is causality, and there's, I see other groups have put submissions in. There's a number of criteria to establish causality. It's called the Bradford-Hill criteria, and we've talked today from Senator Rennick's questions. There's biological mechanisms that could explain some of these things. With the Queensland data, we see temporal correlations. We see the introduction of medicines, then followed by changes in mortality, and there are a number of other criteria. So there's ways to do this properly, and I think it's been left up to independent people to start probing and looking for these relationships. We should be looking at all data, like hospitalisation data. These complex systems aren't just the sum of the parts, they're the product of all the interactions. For example, when we looked at Queensland, 2% of the health workers were put off, and we understand now 75,000 people have left the healthcare system. Yeah. You can't expect that not to have impacts. There's so many variables we need to look at to establish what's going on.
And I know it might be a little bit depressing today, hearing, as Mrs Potter has rightly said, being gaslit all day, but you should take solace in the fact that the Australian people are with you. And I just checked the stats, only 4% of Australians have had a booster in the last 6 months. So hardly anyone is actually listening to these government agencies that continue to parrot these clearly incorrect lines now. That raises a question to me about going forward. Dr Neil, you... I think it was yourself, or I think on the Queensland data, whoever did answer that question made an interesting observation about past data. Just going forward here and making a prediction, people are still getting COVID. And so if the government's hypothesis is right, we would still see excess deaths from COVID, because they're still getting COVID and they're not getting vaccinated now as well. However, if we see excess deaths start to come back to average, would you suppose that, in fact, the rise we saw over this period was more due to the vaccine while people were taking it, and now they're not taking it? We've had deaths come back to normal, which seems to be happening right now. Is that a fair? Would that be your prediction?
Well, I certainly hope that what we're seeing as excess deaths will come back. You say back to normal. There should actually be a compensatory downturn once the exposure, whatever that is, or series of exposures, is removed. And by compensatory downturn, we should mean we should get less than expected deaths for a few years, and unfortunately we're yet to see that. So I think that, I can't predict what will happen, but I think that the nature of that sustained trend has to be taken into account, and if this relates to vaccines, then in fact there have been quite a sustained pressure on the Australian population because of the booster programs.
I suppose this also the validity of my point. Sorry, Chair, just one quick thing. The validity of that point that I've just made depends on how long after a vaccination there is a risk of injury. Is there any evidence on that yet around the world about how long it might persist for?
If I can just...
I think that's a complicated biological mechanisms question, and I would say we need to do a whole lot more. It's inherently the case that some mechanisms are rapid acting and some are long acting, and I think we would see different manifestations at different times.
And this is what's terrifying, because we're trying to look in a period of 3 years, trying to detect what's happening, and it may take 10 years. For the true impact of what's happened to become apparent, and then it's too late. And as Dr. Neil said, we should be seeing deficits. People who are dying of COVID are sadly, over 86. There may be deaths just brought forward slightly. So they're people who don't die a bit later. We should be seeing negative, less people dying at the moment. And if we need to wait 10 years and then we see these trends and go, oh my gosh, what have we done? This is the thing. That's why everything needs to be put into understanding now, while we're still in this proximal period too.
And if I may, I think the bigger point is that we don't know, and that's the problem. That this intervention was rolled out, and we don't know, and that's actually a really big problem.
And Dr. Madre, rather than seeing questions from the health agencies, we're seeing stonewalling from the health agencies. If they really cared, they'd be asking questions themselves and getting into the data.
So that's exactly right. Yeah, we can only just, a lot of what we've had to do to get the information is, purchase data ourselves. Groups have done freedom of information requests at their own expense to the TGA to find out a lot of data. A group has created a website called opendane.info where you can really try to see investigate for yourself for someone who thinks, oh, this strange a reaction I'm having, have other people found this, or is it, it could be just one of those random events. So volunteers are doing work, applying for freedom of information requests to get this data, and it's not really good enough. We need to have access. The public needs to have access, given, particularly in the context of mandates where people are being forced. We need to have open knowledge of the data.
Thank you, Chair.
Thank you very much for your evidence today. The committee will report to the Senate on the 31st of August 2024 and request that answers to questions taken on notice are provided to the committee secretariat by close of business on Friday the 21st of June 2024. The committee will now suspend briefly for 5 minutes and will recommence at 3:30. I now welcome representatives from the National Heart Foundation of Australia and Black Dog Institute, and thank you for your forbearance. We are running behind time. Thank you for appearing before the committee today. I understand that the information on parliamentary privilege and the protection of witnesses giving evidence to Senate committees has been provided to you. For the Hansard record, if you could please each state your full names and the capacity in which you appear today, and I might start at the table and then go online.
I'm Professor Gary Jennings, Chief Medical Advisor with the Heart Foundation and a cardiologist.
I'm Dr. Danny Doherty, Clinical Evidence Manager of the Heart Foundation.
And we'll go online. I think you're on mute.
I am indeed, or I was. So I'm Fiona Shand. I'm Associate Professor and Head of Suicide Prevention Research at the Black Dog Institute, University of New South Wales.
Thank you. Do any of you wish to make an opening statement?
Yes, please.
I'll go to you, Professor Jennings.
I should start by apologising. This will seem quite mundane after the accusations you've been hearing in the last session, but you will have heard the ABS statistics that there was a general trend in deaths downwards, but which spiked upwards in 2021 and 23, and of course COVID was number 3 on that list in 2022 with 10,300 deaths. But from a Heart Foundation's perspective, there's much more to the excess in deaths than COVID itself. 82% of those who died had a pre-existing condition, and a quarter of those had cardiovascular disease. We saw a testing and management of risk factors out in primary care drop significantly, about a 40% drop in pathology testing for things like cholesterol and diabetes. We saw people delaying attendance at health facilities, and as far as severe events like myocardial infarction, we saw much higher acuity and fewer procedures being done to deal with those. And there will be a price, and there is a price that we're paying in the long term for that, because people with more significant damage at the time of their event are going to have long-term chronic illness. So there's plenty to explain as far as we're concerned, the fact that cardiovascular disease is increasing. And indeed, prior to COVID, we were predicting a flattening off of the historical trend, which has been a reduction in cardiovascular deaths because of what was happening in the community in relation to obesity, diabetes, the flattening off of tobacco and other things, all of which suggested that we were going to see that irrespective of whether COVID came along or not. The other thing to talk about is that it's really not easy to count deaths. In 2022, according to the recent AIHW report, 80% of people had more than one condition on their death certificate, and a quarter of them had 5 or more. So people die from things, they die with things, and they die along with things, and that accounts to some extent for arguments that you're hearing about different figures, as well as the fact that a very important point which Dr. Doherty can talk about in our submission is that you really need to look at age-adjusted figures as well. In that 2022 report, the top 5 things that were listed on the death certificates were coronary heart disease on 20%, dementia on 18%, hypertension on 12%, stroke or cerebrovascular disease, including stroke, 11%, and diabetes also 11%. And it's really of interest that all of these are related to cardiovascular disease. They're either heart disease itself, coronary disease, they're risk factors for heart disease like hypertension or diabetes, or stroke, another kind of vascular disease. And indeed, dementia itself, about a third of those are vascular in origin, and the risk factors for dementia are the same as those for cardiovascular disease. So they're all preventable, they're all treatable earlier in life, and of course I don't have to tell you what that involves. It involves addressing nicotine addiction, physical activity, nutrition, hypertension, cholesterol, diabetes, etc. Now there's a similar list for the underlying causes of death. It was of course different for the final event, which was generally cardiac arrest, sepsis, respiratory infections, etc. If we're going to treat 5 conditions in people at the end of their life instead of 1, that's complex and it's expensive, and it would be unnecessary if we had people facing their later years in better health. And so from a Heart Foundation perspective, we would recommend, firstly, we're advocating for a targeted screening program for heart disease, which also, by the way, picks up risks of kidney disease, stroke and diabetes. We hope that the new Centre for Disease Control will address non-communicable diseases as well as infections, because these are linked, as we've been discussing today. That's the only way to address the true burden of disease. And we've seen through tobacco control what assertive government action can achieve, and if we address the food supply, food security, built environment, more active community, we would see some benefits through life right to the very end, and we'd have a more resilient community which would be much better prepared for the next pandemic. And I think it's very like natural disasters, as what we do between events can be more important than what we do in the immediate emergency response, which seems to be what we've been focusing on today. Thank you.
Thank you. Associate Professor Shand, were you wanting to make any remarks before we go to questions?
Yes, I would like to, thank you. So I'll comment first on the suicide deaths comparing 2015 to 2020 with 2021 to 2022. There were no significant changes from the earlier period to the late period, so there were no increases in suicide deaths during the peak of the pandemic. The 2023 national data are not yet available, but we do have preliminary data from New South Wales, Victoria and Queensland, also showing no increase from 2020. So that's one way to look at mortality. The other way is to look at potential years of life lost. So while suicide is not a leading cause of death in the whole population, it certainly is amongst young people, and that is reflected in the potential years of life lost, with suicide being a leading cause of potential years of life lost for both males and females. This is because of the high proportion of suicides that occur within younger age groups. When we look at something like cardiovascular disease, the median age of death, or the average age of death, is much later. That has also not changed from the period preceding COVID to the COVID pandemic period. In terms of the factors that contribute to suicide, mental illness is certainly a risk factor, but so are the social and economic factors. So things like alcohol availability, unemployment and underemployment, income insecurity. And what we saw during the pandemic was a government response which increased job seeker and introduced job seeker. It's likely that that strategy reduced the suicide numbers in Australia, and that's certainly been employed by other countries as well. At the moment, we have a draft National Suicide Prevention Strategy sitting with the Health Minister for consideration. I was part of the working group for that strategy, and the development process has been both rigorous and collaborative. It attempts to address the science and the practical aspects of implementation, and it has really two key aims. The first is to improve care for people at risk of suicide, and then the second is to address those higher order social and economic determinants of suicide. It's likely that addressing things like alcohol use, unemployment and underemployment will result in reductions in suicide, but also in other harms, so other alcohol-related harms, and improvements in physical and mental ill health as well. In terms of what works to reduce suicide, so there's good evidence for restricting access to the means of suicide, so things like gun control, reducing alcohol availability, access to high-quality mental health care, upskilling the primary care workforce, and multi-strategy approaches. So we trialled this multi-strategy approach in 4 New South Wales regions and achieved a 14% reduction in hospital-treated self-harm and a 6% reduction in suicide deaths. And in terms of best investment, we saw that the regions with higher baseline rates also saw larger reductions. Thank you.
Thank you very much. I'm going to go to Senator Pratt first.
Thank you, Chair. Can I ask, please, for the Heart Foundation? There's been a lot of discussion around the impacts on the heart of both COVID and of COVID vaccination. Have you seen, what does the data tell you from the point of view of the Heart Foundation about, in general terms, whether a heart is better off vaccinated or unvaccinated in the context of the COVID pandemic?
Well, obviously, if you suffer from heart complications associated with vaccine, which I'll get on to in a moment, that's significant. But we do see much more devastating effects on the cardiovascular system from COVID itself, and there is, of course, a rate of myocarditis after, particularly the mRNA vaccines, but to 2022, there'd been 9 admissions throughout Australia to ICU from that, 700 admissions overall, and about 1,400 reports. So that's about 3 per 100,000. Over the same period, with over 6,500 deaths from COVID, it was about 130 per 100,000. And that's very similar to what the Centre for Disease Control in the US has reported. That is, COVID itself carries anything from 2 or 3 to 6 to 8 times the risk of myocarditis than the vaccine. Most of the cases that I've seen in my clinical practice and my colleagues have seen, have been fairly mild and self-limiting.
Can I ask in that context, if you are likely, if you've got there's something in your system that means that you might be vulnerable to getting myocarditis. On one hand, you would say, okay, well, I better get vaccinated. On the other hand, you could be one of those minority in which it triggers that reaction. Is there anything that says, well, if you got it from a vaccine, that would correlate with the likelihood that you might have also acquired it had you got a severe bout of COVID? Or are the biological and epidemiological factors in what creates myocarditis either from the vaccines or from catching from a bout of COVID, are they the same or are they different? Is it entirely random, contextual? What can you tell us about that, or is it still an unknown?
Look, that's a very plausible suggestion because a lot of the, nearly all of the adverse consequences of COVID itself are related to the immune response, and we're trying to get an immune response when we vaccinate someone. So as I said, that's plausible. But the true answer is we don't know. We don't know why some people get an upper respiratory tract infection or nothing at all. Some people get invasion of their lower respiratory tract and pneumonitis. Some people get a whole body response with with major organ failure, including the heart. There are genetic studies underway which suggest that there might be some people more predisposed to these complications, and if that was true, then I think what you're proposing would be consistent with that. But I can't say that we really have any sufficient understanding to make a firm conclusion at this point.
Okay, so in that context, as science advances, we might have a clearer idea about autoimmune responses and whether we've got predispositions to reactions. You know, I, for example, get my flu vaccinations because I have arthritis and I suppress my immune system, but equally arthritis and some forms of it are seen to be triggered perhaps from previous viruses. So it's a growing area of science. Do you think in the future we'll be able to give people better advice about who to vaccinate and who not to vaccinate based on, for example, genetic factors?
I'm sure there's research of that kind going on, and I'm sure we'll get some insights into that, but at the moment we don't really know.
And in the context of the general decision that we had to make with the science that we have, did we make the right decision introducing all of the variety of vaccinations into the Australian population? And are there any variations in anything you'd like to see changed in that approvals process, or or are there any variables between vaccination types from your point of view?
Well, I think in the hurly-burly of a pandemic, decisions are made, in more haste than at other times. That's obvious. I think to a large extent we don't see a lot of evidence of malfeasance or gross incompetence as far as the agencies or the developers are concerned. We certainly would have liked to have known that the AstraZeneca vaccine had some particular problems with it a little bit earlier. And as you've suggested, we'd love to know who's going to do well with the vaccine and who might get these rather rare complications that I've talked about.
Thank you. Thank you, Chair.
I'm going to go to Senator Askew.
Thank you. Once I've got the technology under control. Thank you very much for your time today. And Senator Pratt has just covered off most of my question anyway. I was just going to touch on the impacts of COVID-19 and myocarditis, but she's touched on my questions. But just the only other thing I really wanted to touch on was in your summary, in your submission, you were talking about the need to strengthen healthcare systems to handle future crises. I just wondered if you can elaborate on what we could be doing or putting in place now to ensure that for future pandemics, so you say, and need for that.
I think it's about resilience and flexibility. Clearly, we responded as quickly as we could in terms of creating virtual hospitals, in introducing telemedicine things. There are lots of lessons to be learnt from that, and a lot of those things should be kept. I think the other problem associated with any health system, not just ours, is if you're running a hospital at 100% bed capacity during the good times, you're not going to be ready when the bad times come along. And that doesn't mean having more beds than we need, but it does mean having the capacity to use facilities for multiple purposes when things change. And as I said before, to keep people healthier for longer actually would mean that we wouldn't have the vulnerable being knocked off by any new virus that comes along to the same extent.
And I noticed you mentioned the heart health checks and things like that, so there's obviously that need for preventative stuff in the lead-up.
Yes, it's very significant that the people that were most vulnerable to die in the early stages of COVID were the people that had diseases which, at least in theory, are preventable or manageable earlier in life.
Excellent. Thank you, Chair. I'll let Senator Hughes take the rest of my time to talk to the Black Dog Institute. Thanks.
Thanks, Senator Askew. Senator Hughes.
You're right. Thank you, Chair. Professor Shand, you mentioned some of the suicide prevention methods that can be adopted. I just wondered if you could give us an overview of whether or not you found your services being accessed more or whether there was an increase, particularly around the mandates of vaccines and the impacts that may have had on people accessing their workplaces or other opportunities.
Yeah, so Black Dog Institute has a small psychology clinic, so we're probably not representative of the majority of services, but I can comment on an overall increase in help seeking during the pandemic. And certainly there was an analysis of the Lifeline call data, because we were a bit surprised to see there was an increase in calls to Lifeline, but no corresponding increase in suicides. And what that found was that actually most of the calls to Lifeline were to do with anxiety about the virus, but also people perhaps being lonelier because, lockdowns impacted on people's capacity to connect socially. So there was an increase in help seeking, and we saw a government response to that in terms of both increasing the number of sessions that people were eligible for with the Medicare rebate with psychologists, but also with new items being added for telehealth for psychologists, general practitioners and psychiatrists as well.
Mm-hmm. And is that continuing? I mean, are we still seeing a lag of people with mental health conditions that were exacerbated or brought on during those COVID years?
Look, I can't really comment on whether they're necessarily exacerbated, but what I can comment on is that there is still a gap between demand and capacity for all forms of mental health treatment, whether it's the community mental health teams, whether it's the crisis response in the emergency department. They are desperately under-resourced to respond adequately to someone experiencing suicidal crisis. And it's incredibly difficult to get into a psychiatrist and even to a psychologist at the moment. So, yes, there's still a gap.
Mm-hmm. Okay. And, I mean, I guess what I'm trying to understand is, I mean, we're talking about excess mortality here. So, there's obviously the health implications, and, you're here with the Heart Foundation. So, some a little bit different what you or as organisations would be focused on. But I guess what I'm trying to understand is, what were the mental health impacts with the mandating of vaccines, with people being told that they couldn't go into a shop if they weren't vaccinated or they couldn't return to work, and there are still workplaces that have these sort of restrictions in place, and whether or not that in many instances was an unwarranted burden put on the community that actually fed into the problem as opposed to assisting people get through that period.
Right. Yeah. So look, I'm not aware of any research which disentangles the mental health effects of the pandemic. Clearly, there are multiple causes for people experiencing psychological distress. So I can't comment on whether the vaccine mandates had population level implications for mental health, because I'm not aware of any research that's actually looked at that.
That seems to be a bit of a gap. I mean, I would have thought that was something we would have been trying to understand.
Possibly. There's lots of gaps in research. Mental health research is pretty underfunded. Yeah. So yes, it's possibly a gap. Whether it's the first priority is another question. Yeah. So we certainly did see an exacerbation of distress amongst young people, for example, and we've got good records of that. We've seen increases in hospital-treated self-harm amongst young women in particular, and that was occurring before the pandemic, but that trend was exacerbated during the pandemic. And we think that for young people, those are particularly formative years, and not being able to connect with other young people, their schooling being disrupted, there was a lot of anxiety around that for people in terms of their futures. So we certainly saw that pattern playing out amongst young people who were quite badly affected in terms of their mental health during the pandemic.
Yeah, because I see a lot of, in my portfolio work, see a lot of mental health organisations and a lot of the youth organisations that when they come and see me, they're talking to me about the long-term impacts of COVID and what their mental health implications are for them. And I guess, I'm trying to get a sense because we're hearing of lots of catastrophising, for lack of a better word, of broader issues. Whether it's climate change or, all these sorts of anxieties that are being, put in play into the youth mental health space. But COVID is also one of those things that is often cited as a reason why particularly youth mental health is at such crisis levels. So I'm just, I'm trying to understand from a policy perspective, is this going to be an ongoing issue for these people through their lives? Has it had that sort of an impact that it'll be long-standing mental health impact, or is it sort of that blip in time that once people start to get back to a normal existence, those sorts of anxieties will decline?
Yeah, so I think the crisis in youth mental health was there before the pandemic. The pandemic has certainly exacerbated that, but it certainly isn't the only cause of it. Will it continue? I think in terms of what the impact the pandemic had, what we see is that a large proportion of mental illness emerges by about the age of 15. So when you have young people who are already struggling and then you have a pandemic where people are feeling anxious about their future, then of course we're going to see an increase in distress amongst young people, and it's a particularly critical development time for young people. So yes, whether that's going to continue long term, we're only 18 months out, 2 years out of the lockdown, so it's pretty hard to say what that's going to do. But in terms of the presentations to hospital for self-harm, they are certainly not easing off for young people.
Yeah, okay. And I guess just finally, for clarity for the committee, mental illness, mental health, there seems to really be two strands. You've got that clinical side, people with schizophrenia, bipolar, clinical depression that's quite often an imbalance in the brain or, an actual something medical. But then you've also got sort of mental health, which is this anxiety around situations or, particular issues. Where is the focus, or is there enough focus, or is it covering them both, or... They seem to be very different, but, the mental health, anxiety, non-clinical side seems to be getting a lot of funding and a lot of attention versus the medical side.
Yeah, although if you're experiencing psychological distress, it doesn't meet criteria for a diagnosis. You don't get access to the usual range of subsidised services. So, look, there are two ways of looking at it. So there is kind of, most people at some point in their lives will experience some symptoms of depression, some low moods and anxiety and so on. It only meets criteria for a diagnosis when there are a number of criteria met, but also it has to be clinically it has to be distressing, it has to be impairing functioning. So of course that's the end where we tend to focus. But I think what you might be referring to is this idea of mental ill health versus flourishing or mental wellness. And I think if we want to shift the curve so that we've got fewer people under that threshold for mental illness and more people flourishing, then it is about addressing some of those high-level social and economic determinants, like ensuring that people have access to good education. So having high levels of education is protective against suicide, but also against mental illness, like making sure that we've got strong communities, that people are supported in times of economic downturns, etc.
Okay, all right. I'm happy to leave it there, Chair.
Thank you, Senator Hughes. Senator Rennick.
Yeah, hi guys, how you going? Does the Heart Foundation receive any funding from the Australian government or pharmaceutical companies?
The Heart Foundation has received some specific project-based funding from the Australian government for developing, most recently, a risk prediction guideline, and it has received some funding for a walking program which involves several hundred groups around the country that go walking together. So project-specific. There's no base funding, no core funding to the Heart Foundation. Pharmaceutical industry, no. There has been historically some examples of co-funding an independent research project, but nothing. Again, no direct funding to the foundation.
Okay, thank you.
The money is provided by the public.
Okay, thank you. I noticed in your submission you point out, and I tend to agree with you, that the lockdowns would have delayed medical care, and that would have been one of the reasons for the rise in excess deaths, and I think that's a valid point. But the actual data, when you look at it between September 2020, after the Victorian lockdown, in August 2020, where there was a spike in COVID deaths as a result of the lockdown in aged care centres, to April 2021, there was no actual increase in deaths in that 8-month period. So that's quite significant, because I would have thought you'd expect to start to see a rise, albeit a small one, but like some sort of rise, and that never occurred. And then in the next 8-month period, you saw a spike in the deaths, the actual deaths, all-cause mortality, and then you saw a subsequent increase after that once COVID was in the community as well. I guess, can you explain why there was no evidence of an increase in deaths due to the delayed medical procedures in that 8-month period, where we can actually get a clear look at, where there was no COVID and there was no vaccines?
Firstly, the time domains in which you'd expect to get consequences of inadequate support for people would vary. For example, people not getting their cholesterol, their blood pressure measured, that will have consequences years down the track. People not getting long-term, close monitoring of their heart failure or other things would be, months or years. People that are suffering acute events, I haven't seen the Victorian data, but the New South Wales data was that actually the same number of people were coming with a severe myocardial infarction, and they were getting to hospital and getting managed. It was the people with milder symptoms and milder conditions that were not coming, and the consequence of that was that they wouldn't be getting the normal preventive therapy such as blood thinning treatment and things, and that would have consequences not immediately but sometime down the track, and I wouldn't like to predict exactly when. So I think it's very complicated to assign a direct cause and an immediate effect to these changes.
Okay, thank you. Have you read the non-clinical report, TGA's non-clinical report on the Pfizer vaccine?
I have, but not recently, so don't ask me too many numbers from it.
Okay, no, that's fine, because if you actually looked at the biodistribution table on page 45 for the luciferase, for the lipids containing luciferase, not spike protein, the lipids did go to the heart. Mm-hmm. And they were still in the heart after 48 hours before the trial was stopped, when the trial was stopped, and it was in numerous other body organs as well. But it's worth noting that if they were going to do the trial properly, and I accept it's not hard to do it properly when you're doing it on rats, they would have kept the trial going until the lipids were completely drained from the body, so that you knew the entire timeline of the the length, the stay of the lipids at the very least. But I just want to highlight that, and then I also want to highlight the fact that there was no degradation and distribution data on the actual spike protein itself. So when you made the statement earlier on that COVID itself was 6 times, had a greater impact on the cardiovascular system, 6 to 8 times greater than the vaccine, how can you possibly say that when there was no thorough testing done on the impact on the heart or numerous other body organs?
Well, we know that with COVID itself, the spike protein can hang around for weeks and in some cases months. So, so I'm not sure that comparison really tells you very much. I was talking about the consequences, the actual clinical conditions associated with it. I wasn't talking about the biology because that's beyond my expertise.
Okay, because I'm glad you raised that as well, because the spike protein itself was codon optimised to increase the expression. They had methyl pseudouridine there to increase the length, the duration of the mRNA. They increased the poly-A tail of the mRNA so it would last longer. Yet again, you know, you've come in here today and you've made this statement that and I accept that COVID itself, because of the spike protein, was also got cardiovascular concerns. Don't get me wrong, but you know, as I said to the former cardiologist here, the prior cardiologist that was here, it just beggars belief that you would create a vaccine that produced more of the spike protein, not less, in order to, you know, supposedly save people, and to me you're increasing the risk profile. Do you think that's a fair point?
Well, again, I'm not a virologist and I'm not an immunologist, but the whole purpose of the vaccine is to develop an immune response, and that would presumably relate to how much protein that you're trying to, antigen that you're trying to provide. But it's, as I said, I can't really answer that.
Okay, no worries. On the 22nd of July 2021, you posted a tweet whereby you basically said that the heart inflammation was a short-term issue that could be resolved. Do you accept that myocarditis can scar the heart tissue on a permanent basis?
Yes, what we call, well, what I'll call native myocarditis, that is the thing which is bubbling along in the community all the time, once again is almost always a rather benign, self-limiting condition. But occasionally, for no obvious reason, some people progress and develop poor heart function and heart failure. We don't know who that's going to happen in, and there's no reason to suggest that it wouldn't happen with this particular cause of myocarditis. All I can say is that in the clinical experience to date, we haven't seen it very much.
Okay. In 2021, yeah, thank you, Chair. In 2021, data was obtained from the South Australian Health Department by my colleague, Senator Alex Antic, on cardiac presentations to hospitals for people aged between 15 and 44. And cardiac presentations doubled between August and October 2021, so prior to COVID being in the community, but after the rollout of the vaccine. So we've got this issue now whereby we've got an increase in cardiac presentations amongst younger people, an increase in deaths in 2021. The WA vaccine injury report showed an injury rate 50 times higher for the COVID vaccines. Do you think that is compelling evidence to suggest that the vaccines could be a cause of excess deaths in 2021?
I think I'd need to understand those figures. Have you seen any of those?
No, I haven't.
Well, I mean, I'm happy to table for them, get them for you later on, but effectively, you know, there's significant evidence, real-world evidence, not model data, that show that there were cardiac issues in 2021 prior to COVID being in the community in 2022.
Okay. I can't comment without seeing the figures and the causes for those admissions. Certainly, there was a lot of concern with the publicity that was around myocarditis amongst the public, and there were a lot of people coming along with various symptoms which turned out not to be.
Okay, well, I'll rephrase the question. The TGA belatedly acknowledged myocarditis was a side effect of the vaccine after it had already rolled out and after they'd already said it was safe and effective. Do you acknowledge that the testing for the vaccine may not have picked up the risks of heart disease or damage to the heart that then led to an increase in excess deaths?
I think it's the experience with all new drugs and all new therapies that rare side effects take a while to reveal themselves, and it's quite often well past the period of phase 2 or phase 3 clinical trials. It's when they're exposed to large numbers of people in the population. So I acknowledge that, but I'm not surprised by it because we see it all the time.
Okay, thanks, Chair.
Senator Roberts.
Thank you, Chair, and thank you for appearing today. If I've got time, I'll ask questions of the Heart Foundation, but I want to start with Dr. Shand, or Professor Shand, I'm sorry. Part of understanding something statistically is to ask questions and to listen to people outside the normal data capture. I had a conversation with an insurance broker who's got clients all over the country in many industries, many professions, including medical professionals. And I'll go through these points that I wrote down as a result of that conversation, Professor Shand, and ask you a question. He says that he has been swamped in claims for income protection since mid-2021, which was after the COVID injections were released, before COVID was a big part of the community. Cancer, heart attacks and disease, strokes, long-term musculoskeletal injuries, especially hands and arms, new cancers, recurrence of cancers, eyesight. He believes now, and he's been talking to other brokers, they believe that the industry is unsustainable. Premiums are increasing dramatically because claims are increasing. Cost of living is increasing, and insurance is less of a factor in people's spending of their income. Industry-wide pricing was repriced in 2023. Income protection went up 20%, life insurance went up 10%. More increases are coming in 2025. They've been foreshadowed. The industry knows it is under stress. The claims departments are telling him they're under pressure. He's also talked to some of the professionals, including doctors. The doctors are scared. They did what they were told rather than what they disobeyed their training. They're not very comfortable. It's led to specialists being run off their feet because of the injuries and diseases. Mental health, he said, has now become a really big problem, which would be something you would back up, wouldn't it?
Would I back up that mental health has become a really big problem?
Yeah, there's a delay in getting in. They're overworked now, mental health professionals.
Yeah, but I don't think that's a short-term thing. I think that's been a trend that's perhaps been exacerbated by the pandemic, not necessarily caused only by the pandemic.
Okay, thank you. He says there's been a steep increase in claims, mental health claims, since mid-2021, and especially the last 3 years, which brings us to now. So let's move on to the Heart Foundation. If you go to your submission, page 4, bullet point number 6, you say the Australian population, especially individuals with cardiovascular disease, should be encouraged to stay up to date with their COVID-19 vaccinations. And if you go to page 15, under 6.2, second paragraph, furthermore, based on the risks of a COVID-19 infection on individuals with cardiovascular disease, the Heart Foundation also recommends the Australian population stays up to date with their COVID-19 vaccinations. Could you tell me on what scientific or medical basis that those recommendations are made, please?
I'll start, and Dr. Doherty would. The one thing that's clear from post-vaccination is that the severity of COVID infections is reduced. We're seeing fewer hospitalisations per 1,000 people, or however you want to quote it.
Excuse me, which data are you relying on there?
What data?
If you could get it to us on a question on notice, just tell us the basis of that. Your source of that data?
Of course, I can also justify it on the basis of my own clinical experience.
But I would like the data as well,
okay,
please.
We can do that. Do you want to speak to that?
We can take that on notice to provide you with the data.
That's fine, yep.
In regards to vaccinations, there's a correlation between the severity of COVID-19 and the impacts that it can have on the cardiovascular system. When you have a vaccination, it can reduce that severity. We also follow the guidance.
Could we have the source of that data as well, please?
Yes, I can provide that on
Thank
notice.
you.
We also follow the guidance of the Department of Health. So we believe in that organisation. We trust their word, so we will also follow their guidance.
Okay, thank you.
Just to add also, we would make a similar recommendation about influenza vaccination and other respiratory viruses, because we know that vulnerable people with heart disease don't have the resilience to cope with any kind of respiratory condition that other people of good health do.
Thank you. Do you have any peer-reviewed papers with data backing that up?
Plenty.
Okay, could we have some, please? Thank you. On page 7 of your submission, there's a graph, figure 3, which shows a reduction in the average age standardised mortality decreasing from, in 2021-2023, decreasing from 2015 to 2020. Are you aware of the change in baseline from the ABS, Australian Bureau of Statistics?
So the baseline in the crude data or the age standardised?
Both.
So there is a change from baseline. There is an excess deaths during the COVID times. But with this graph, what we're trying to show is that there's we need to look at age standardised mortality. So that takes into account the ageing population, and it's comparing like with like. So one of the terms of reference was to compare the mortality rates from previous years to during COVID. And this graph, figure 3, shows that there's actually a decline. There was some previous years where there was excess mortality due to the influenza virus. So it's not an isolated event to occur during COVID-19 pandemic that there are increased deaths compared to what is considered baseline.
Have you assessed the impact of changing the baseline?
No, not personally.
Okay, thank you. Okay, on page 8 of your submission, section 4.1, deaths caused by COVID-19 and the pandemic state of emergency, and I emphasise and. You said in your second paragraph below that subheading, additionally, the pandemic's impact extended beyond just respiratory illness. For example, during that statement there, you said these included diabetes went up 96%, heart disease 89%, Alzheimer's disease 64%, cerebrovascular diseases 35%. New York City experienced the largest increases in non-respiratory deaths, notably those due to heart disease 398% and diabetes 356%. Is there any explanation of them?
So that data is looking at United States data.
Yeah.
So in regards to the explanation, did you want...
I just wanted an explanation.
So this particular study was looking at the particular areas with the highest prevalence of COVID-19 and showing the correlation between the increased deaths for these other chronic conditions. So the point we were making with this paragraph was in areas where there is high prevalence of COVID, there's more likely that people will die from preventable chronic conditions.
Thank you. Thanks, Chair.
Senator Babbitt.
Thank you, Chair. Professor Jennings, does it surprise you, given Senator Rennick's comment about the vaccine lipid nanoparticle ending up in the heart, does it surprise you that a vaccine should go to the heart? Is that usual for a vaccine?
I can't give you a clear answer on that. It doesn't surprise me because we're delivering an antigen which is intended to get into cells. It doesn't particularly surprise me, but I can't answer what happens with other vaccines.
Okay.
Clearly, mRNA vaccines are new kids on the block, and therefore things may be different. But I'm not aware of any data that suggests that they're more likely to penetrate cells than other traditional vaccines.
Okay. Now, COVID-19 vaccine obviously have known side effects that impact cardiovascular health. Your submission refers to myocarditis, stating that COVID-19 infection may induce 30 to 32 excess myocarditis deaths, myocarditis cases per million. You also state the reported rate of myocarditis cases per million post-vaccination ranges from 0 to 390 per 1 million doses and 44 to 270 per 1 million doses for pericarditis. Obviously, novel COVID vaccines have a much higher reporting rate for myocarditis and pericarditis than the virus itself. According to your numbers, that's roughly 12 times the risk of myocarditis. Now, to your knowledge, do any other vaccines approved for use in Australia cause heart inflammation at these sort of levels?
I don't believe any other vaccines have been studied to this extent. One point I would make clear is that neither pericarditis nor myocarditis are black and white diagnoses. They're very difficult to confirm. The symptoms are rather non-specific, and the definitive tests are a cardiac biopsy or an MRI, neither of which are particularly available. So once again, it doesn't surprise me if rates that are reported are quite variable. On the other hand, it seems very clear that clinical consequences of myocarditis are more common with COVID than with the vaccine. The other thing that is clear is that not all vaccines, not all mRNA vaccines are the same, that we saw higher rates of myocarditis with one or other brand than others.
A key point that is not often discussed is that the number of cases quoted are per dose. So per dose. Now, some Australians are up to their 7th, 8th dose even of these products by now. I expect that the likelihood of an individual suffering an adverse event compounds with each dose that is received. Is that true or is that not true?
Experience to date is that the highest, from memory, the highest rates are with about the second dose, and that subsequently it's very hard then to follow, because people won't necessarily then line up for another dose of the same vaccine. But there's certainly anecdotally an impression that the second dose seems to be the one which is associated with any complications. But irrespective, they're rare.
Got a question about myocarditis. Specifically, can myocarditis eventually lead to heart failure over years, over decades? I believe this is mentioned in your 2018 guidelines for heart failure prevention and
yes, it certainly can, and as I said before, it's one of the unpredictable and rare consequences of myocarditis. Most myocarditis is short-lived and resolves spontaneously.
AstraZeneca was known to cause venous blood clots in the brain. Is it logical or rational to think that a drug could cause blood clots in only one blood vessel? Are there any other examples that you can think of where a drug causes clotting in just one blood vessel?
We know one of the unexplained features of cardiovascular disease is that certain things seem to pick off different parts of the circulation. For example, smokers get atherosclerosis and clotting in their legs, whereas hypertension, for example, affects the brain blood vessels. So again, that's not that surprising to me that if a drug is associated with thrombosis, that it might be more likely in one part of the body as opposed to another. We see that.
Earlier, in a response to Senator Pratt, you said that AstraZeneca had problems. What are those problems?
What you've just described.
Anything else that you'd like to add?
Well, a number of yes, particularly thrombosis.
Please let the witness answer, Senator Babbitt. You've asked the question. Let them answer.
Sorry?
Would you like to answer the question?
Did you have anything further to add on that question,
Professor? No. I think.
Okay. So I'm from Melbourne, and we endured some of the longest lockdowns in the world. Gyms were closed, exercise was not encouraged, and many individuals suffered both physically and mentally as a result of all the lockdowns, curfews, and other interventions. Do you think it was wrong from a cardiovascular health perspective to impose measures which restrict the ability of individuals to exercise?
I think it was unfortunate that was a consequence of lockdowns. There were a lot of people, of course, that took up exercise for the first time and used the opportunity of not spending time commuting to do that. So it did vary. But on the whole, we would think that changes in nutrition and changes in physical activity might have contributed to any uptick in cardiovascular consequences of the pandemic.
So face-to-face medical practitioner visits were not an option for many Victorians for quite a long period of time. Many were forced to attempt telehealth, or may have chosen to just delay appointments, as we're all aware of. Now, do you believe that this lack of medical care has potentially resulted in excess deaths or potential future excess mortality?
It's reasonable to to propose that, yes. Certainly telemedicine proved to be quite effective and helpful in mitigating that, but there was also, once again anecdotally, considerable fear amongst the community about attending health centres where they might be exposed to people that had COVID. So there was a general reduction in medical attendances, some of which would have been necessary and helpful.
Thank you, Chair. That's it.
Thank you. And one very quick question on notice from Senator Pratt.
Thank you. One of the early vaccine proposals was actually developed in Australia using a spike protein attached to the HIV virus, and HIV patients have a high risk of cardiomyopathy if it's not treated. But I'm wondering if you can tell me from your experience that is triggered by the immune response to HIV, not the spike itself, in those cases that you're aware of?
Yes, my understanding of that, it was more that the way that the vaccine was prepared and the way the antigen was attached tended to increase or spuriously increase positive tests for HIV rather
yes,
than...
it would mean that people who'd had the vaccination could, in the same way you do a COVID test,
yep.
It's triggered by the same kind of thing, so I accept that. But I guess what I'm looking for is if there's anything in the experience of patients with HIV that tell us about cardiomyopathy and viruses and the immune response, and whether that's attributable to the nature of the protein or other parts of the virus.
Yeah, I can't really answer that except to say that HIV-associated heart disease is generally coronary disease. It's a slightly different kind of coronary disease to that we see normally, and it relates to. And of course, people with HIV have suppressed immunity rather than enhanced immunity, as we're seeing with COVID or with vaccinations. So. Without being able to give you a clear answer, I think intuitively I think that's drawing a long bow.
Okay, thank you.
Thank you very much, all three of you, for appearing and giving your evidence today. The committee will report to the Senate on the 31st of August 2024 and request that answers to questions taken on notice are provided to the committee secretariat by close of business Friday 21 June 2024. Thank you very much.
Thank you so much.
And I now call to the table the Department of Health and Aged Care. I now welcome representatives from the Department of Health and Aged Care. Thank you for appearing before the committee today. The Senate has resolved that an officer of a department of the Commonwealth or of a state shall not be asked to give opinions on matters of policy and shall be given reasonable opportunity to refer questions asked of the officer to superior officers or to a minister. This resolution does not preclude questions asking for explanations of policies or factual questions about when and how policies were adopted. If a witness objects to answering a question, they should state the ground upon which the objection is made, and the committee will determine whether it will insist on an answer having regard to the ground which is claimed. If the committee determines to insist on an answer, a witness may request that the answer be given in camera. Commonwealth officers appearing today are also reminded of the Senate order specifying the process by which a claim of public interest immunity should be raised, and a copy of the order is available from the Secretariat. For the Hansard record, could you each please state your full names and the capacity in which you're appearing today?
Thank you. I'm Philip Gould. I'm the First Assistant Secretary for the Health, Economics and Research Division at the Commonwealth Department of Health and Aged Care.
Hi, I'm Kayla Jordan and I'm the Assistant Secretary of the Data and Analytics Branch in the Department of Health and Aged Care. Thank you.
I'm Hannah Harding. I'm one of the Directors in the Data and Analytics Branch, Department of Health and Aged Care.
Thank you. Were you wanting to make an opening statement?
Thank you. Yes, just a short opening statement. Firstly, I'd like to thank the committee for giving us the opportunity to answer questions today. Firstly, I'd like to acknowledge the fact that the department does acknowledge we have experienced a period of excess mortality, and while the discussion is often of quite a statistical or scientific and dry nature, we recognise that excess mortality impacts people. It's a very personal phenomenon, and we always keep that in mind when we are discussing these sorts of technical concepts. We also acknowledge that adverse events can occur post-vaccination, and we've certainly acknowledged that that can be the case with COVID vaccines as well. We would say excess mortality is a really complex concept and phenomenon. There are a number of different factors which can contribute to periods of excess mortality. Over recent periods, clearly COVID itself is a significant contributor to that period of excess mortality that we're seeing. We have had discussions today around delayed care and treatment potentially having a role to play there, so that's certainly something which has been discussed in this context by the department. Also importantly, the impact of other non-COVID but COVID-related factors. There's a huge body of evidence in the peer-reviewed literature which would indicate that COVID infection leads to more serious outcomes, including mortality from a range of different conditions. That's based on a wealth of research. We do agree that excess mortality is something that requires investigation and scrutiny. We have done a lot of work in this space in the department, including a lot of the information that we've discussed today being data sources and reports which the department has commissioned with a view to transparency and offering people both within government but also really importantly outside of government an opportunity to interrogate numbers and ask questions. The ABS reports that we've discussed a lot are detailed and rich reports which provide a really powerful picture, an important picture for understanding the phenomenon of excess mortality. We need to be very careful when we are attributing certain things to excess mortality, particularly when we're making temporal associations. It's not to say that doing that is not a valid thing to do, but it does need to be taken with real care. We've had a lot of conversation today around mortality rates increasing, let's say post-April or post-May 2021. That's actually something that we see just about every year as we move towards a winter seasonal spike in mortality. What we need to do there is look at what the excess mortality movements have been over that period, and that's really important. That sort of nuanced analysis is absolutely critical. With that, I think I'd say we've been actively working with the ABS, the AIHW, as well as external researchers to better understand this phenomenon, and it's something we will continue to do. That's all. Thank you.
Thank you. I might just ask, are you able to tell us how Australia's excess mortality figures for 2021, 22 and 23 compare to other international jurisdictions?
Yes, we can talk to that. It's been something which has been discussed in detail. In short, our experience has been a lot milder than most of our international peers. Our excess mortality across 2020 to 2022 was ranked the 5th lowest of 31 countries studied in an AIHW report. So generally our experience has been of less excess mortality or lower excess mortality than many of our international peers.
Thank you. I'm going to go to Senator Pratt.
Thank you, Chair. Can I ask what work is underway to assess the impacts of government policy in responding to the pandemic, and also in that context, the work that's occurring as part of the vaccine claims scheme, and in that context, there's of course the Australian Journal of General Practice indeed acknowledges that studies do show an increased risk of myocarditis after vaccination, but also that it has an increased risk after COVID as well, and that they're looking at the impact. They've raised the question whether long COVID's purely attributable to COVID-19, or whether in part there might be some immune responses from the vaccine as part of that, and that there's work to be done in that regard. And I note that there's $50 million from the Medical Research Future Fund for long COVID research. So I guess I'm really looking at how future research might inform compensation and what we do in the meantime around people's high levels of distress in getting their symptoms recognised and reimbursed. Thank you.
Thank you, Senator. There's a lot of elements in that question to unpick. I'll try to do my best, and my colleagues might also wish to help. In terms of looking at the broader COVID response, obviously I will focus on a health perspective. There's a range of different ways that the response can be analysed, but in particular we've really done a lot of work and will continue to look at how different health measures have impacted mortality and also quality of life during the pandemic and afterwards as well, recognising that the effects are likely to be ongoing. We've commissioned some research specifically to look at the effectiveness of the vaccines in the Australian setting to protect Australians aged over 65 in particular from mortality from COVID. So that sort of comparison work is really important in us understanding how effective the vaccine strategy, which was obviously an important element of the government's response, to understand how effective that was. We have done a range of pieces of research as well, looking at how different communities might be disproportionately impacted by COVID and what their experiences have been. We have had some discussions in this committee around the experiences of culturally and linguistically diverse Australians and how government policy to encourage vaccination actually helped reduce the relative mortality for those cohorts versus the rest of Australians. So some pleasing results there. So there's a whole range of ways that we examine the effectiveness. We also don't just focus on mortality numbers. We've heard discussion in this committee today around concepts such as years of life lost and age standardised mortality rates. So we do look at those measures as well. Excess mortality, as I said, very useful concept, but it's not the be-all and end-all for measuring the impact of a pandemic in terms of mortality outcomes. There were some questions as well around the relationship between the vaccine and myocarditis. I don't really feel I have a lot to add to what Professor Jennings, I believe, said beforehand. I think he covered that very nicely, and I feel somewhat underqualified to say any more than he has.
No, that's fine. I guess what are the gaps in the data that have been identified in terms of what is now being collected? I know we're going back to look at connecting vaccination status with cause of death, which will be helpful. I guess there's critique in the community saying that government's trying to hide data and causes, etc. But as far as I can tell, there's a lot of evidence to show that you haven't ruled the government hasn't ruled any of these things out. It is assessing all of the data that it has on an ongoing basis and making policy judgments on the basis of best scientific and clinical advice. What can you do to reassure us that, questions like, how myocarditis is triggered and whether it can be triggered by, and the manner in which it's triggered by a vaccine versus COVID itself, we're not hiding any of that information, and we're seeking to understand it and make sure that our public policy responses are still fit for purpose.
Yeah, so the department continues to work within the ABS's person level integrated data asset, where we talked about this. It was talked about this morning that the Australian Immunisation Register data is linked with mortality data, and the department continues to use that data and also work with researchers to analyse that data to look at the impact of COVID-19 on mortality. And there's further work still to be done within that space, looking at the impact of comorbidities and looking at vulnerable population groups such as the impact of COVID-19 on people with disability. We recognise that there is a gap in the data that we have available in that environment, and that's what we heard this morning from AIHW in terms of the COVID-19 data that's available in the National Health Data Hub that also contains hospitalisation data, which will give us a more richer data set where we could look at not just mortality as the outcome, but also the severity of COVID-19 through our hospital system and the ICU admissions.
And what remarks does the department have about excess mortality overall in the context of COVID and COVID vaccination? We know that car accidents were down during lockdowns, people didn't go to the doctor for other diseases, that migration was down, but yet we're still trying to look at mortality rates in the context of COVID and unpick that. Once you account for other factors like lockdowns and migration and driving on the road, etc., what are we able to say at the moment about excess mortality in relation to COVID and COVID vaccination?
Thank you, Senator. I just wanted to quickly as well, as an adjunct to Ms Jordan's response, point out that, as you alluded to, the Medical Research Future Fund has invested a lot in COVID research over the years. We've had over 85 grants in that space, and that really complements the data that we're talking about with research which happens in labs and is performed by clinicians. So I just wanted to point out that that's a really important part of the way we are responding. In terms of our overall position on excess mortality, as we've said, we acknowledge that we have experienced excess mortality during the pandemic. As the ABS reports, COVID is the primary driver of that excess mortality, and that's COVID as listed as a cause of death. So it's a really important driver there. But we do acknowledge that, as we've heard before, mortality for conditions like diabetes and heart conditions, these levels are elevated. We referred to before the fact that there's a strong and growing body of evidence to link those higher mortality rates for those conditions with previous COVID infection. There's new research coming out all the time linking those. Specifically...
I'd be grateful for any references to that on notice. Thank you.
Absolutely, yeah, we'll be very happy to provide an extensive list of references. In terms of COVID vaccines themselves, as the ABS said, over the period of the pandemic, we've had 16 confirmed cases of mortality as a result of COVID vaccine, and I think a further 4 where there's a relationship which has been developed. So these are very serious things. Mrs. Potter, who was here before, we take very seriously any mortality, but in terms of the overall bulk of what's driving excess mortality, this is not a major contributor.
Thank you. And can I ask, in the context of research, yes, it's really important to see if there are relationships between COVID vaccination and death rates and what's written on the death certificates, etc. But at some point, like we've heard from the Stroke Foundation and rural and regional health, there are a lot of people desperate for funds and a commitment to making sure that other really prevalent health conditions are addressed. We have to come to grips with what mRNA vaccines mean and to really properly understand that relationship, particularly when they're under a critique and attack, but so that we've really got to drill down into that data. But we don't want to do that unnecessarily where we've got limited resources that other conditions also need that research and attention. I really just wanted you to comment on how we get that balance right. mRNA is new and we will really need to understand it to use it as a tool, but equally we don't want to have to do that if it's unnecessary.
The two major mechanisms that we have in the Australian government for funding health and medical research come via the Medical Research Future Fund, which is a priority-driven fund. And the idea behind that is that the Australian Medical Research Advisory Board actually works to set priorities, so to help provide that macro view of what's important for us as a nation to invest our research money in. So that's a really important way of making sure that what we do maximises the health benefits. And this has led to significant investments in, like I said, COVID research, but also regional and rural health initiatives, as well as clinical trials initiatives. So it's been provided a really good mechanism for us to ensure that money is spent well. That's also complemented by very significant spend for the Medical Research Endowment account, which is managed by the NHMRC. That's investigator-led research where researchers actually put forward their own ideas and they're assessed according to very strict protocols and rules for their potential to deliver useful outcomes and good scientific evidence. So we have really good processes for managing both a kind of top-down and a bottom-up approach to medical research.
Thank you. Thank you, Chair.
Before I pass the call to Senator Askew, I'm just wondering, can you tell us how many COVID-19 vaccine doses were administered in 2021, 2022 and 2023? And for that same period, how many vaccine injuries and deaths were recorded?
We can certainly provide that on notice. I don't have it in front of me at the moment.
That would be helpful. Thank you. Senator Askew.
Thank you. That was something I was going to put on notice as well. Just in regard, just wanted one quick question really. Can you give some explanation around the National Notifiable Disease Surveillance System and what that does and how it actually relates or differs from the death registrations. And I noticed Senator Pratt mentioned that before, the death certificates, and how those death registrations reported by the registries of birth, deaths and marriages, how they relate to each other, those two things.
Yes, thank you, Senator. The surveillance data set that you're referring to, we call the NINDIS. It's a very ugly acronym for a very useful data set. The idea behind the surveillance data is to provide a rapid signal around evolving mortality. So that's something where we have frequent updates of information that's filled in, at times by clinicians who are operating in a very pressed environment. It does provide us with an early signal, a useful signal, but it is subject to significant revisions over time because it hasn't gone through that detailed process which the ABS talked at length about earlier today, where the death certificate is used as the primary source of evidence, and that certificate has to be filled out by a certified practitioner. Some deaths, as we talked about, and particularly deaths of younger Australians, often go through a lengthier coronial process. So while the surveillance information provides us with very high frequency, up-to-date information, it is subject to revision. So both of those data sets have an important role to play in informing us.
What's the time lag then? So what sort of time frame around the rapid signal one as opposed to a formal death certificate on average?
In terms of cases, there's a daily update that the department receives from state and territory departments, and there's actually, in terms of cases, not deaths, but cases, there's a publicly available dashboard that anyone can look at on the department's website.
So that would be updated each day by the doctors and so on that are reporting them. It would be what happened the day before, or is it within the last week that they would be putting that information in?
We have daily data from them. The lag, I believe, is roughly, and it does actually vary. It's sort of a matter of a day or so. But you do see, again, an interesting phenomenon with these data sets is that deaths are typically higher on a Monday because they haven't been recorded over weekends. And that doesn't mean it's invalid data, but it shows the limitations of this sort of information.
And just as a comparison, then you mentioned the longer coronials and so on. What sort of average is it to get the death certificate formalised? Got a time lag?
We could provide that on notice. The ABS actually provides quite detailed numbers, looking at basically the cumulative percentage of deaths that have been certified and formalised over in the months after the death has occurred.
And you said before there's lots of changes. What does that end up be quite close in the information that's reported, or is it quite different and varied?
It can vary.
So when it comes to doctor-certified deaths as recorded by the jurisdictional registrars of births, deaths and marriages, which the ABS analyse, approximately 95% of those registrations are received within 3 months following the death. The other 5%, sometimes there can be other factors where things take a little bit longer. In terms of coronial inquests, 3-6 months is not unheard of, depending on the complexity of the case. When it comes to some of the revisions in the numbers, like Dr. Gould alluded to, so the example where, for example, Monday seemed to have a much higher figure because it counted people over the weekend, it's not unheard of, again, for our jurisdictional counterparts to come back and say, oh, we've caught up with the paperwork, we've readjusted those numbers so it's more even on the date things actually occurred. So when it comes to the trust in the numbers, this is exactly why the ABS figures based on death certificates and information drawn from the jurisdictional registrars of births, deaths and marriages we treat as the gold standard. It has the most complete information. It's been signed off by the different sources. It's been analysed by experts, and then those summaries come through to us. The NINDIS records are fantastic for those short, sharp turnarounds where if you want to see if a daily trend is starting to emerge, and that's the kind of information that, for example, our Interim Centre for Disease Control are very responsive to.
Thank you for that, and thanks for your evidence. I'll leave it there, Chair, because I'm conscious of time. Thank you.
Thanks, Senator Askew. Senator Rennick.
Thanks, Chair. Hi, guys. How are you going? Mr Gould, we meet again. Okay. I just want to refer to your bio on the website, and it says that with your current role at the Department of Health, you have access to some of the most important data sets in the country, including the increasingly in-demand Australian Immunisation Register. Now, what I find amazing about one of today's outcomes is that, you know, throughout COVID, the Australian Bureau of Statistics Department of Health was able to give vaccination status to the state governments just like that, so they could lock us down, lock us out, lock us up, and yet here we are 3 years later and you haven't been able to put vaccination status or attach vaccination status to deaths. Okay, so do you know why it's so difficult to do that if you were happily able to, you know, you could go into any club across the country and be told you can't come in because you're not vaccinated, and yet you who have a PhD in, you know, time series analysis can't get that organised, that to happen in a speedy way?
Just before you answer, Dr Gould, it's really important that you're referring to the department rather than individuals.
Okay, the department.
Senator Rennick?
Yeah.
Thank you for the question. A few points to go through there. Certainly, it was an absolute priority for us to provide our partners in the states and territories with the information that they needed to understand vaccination uptake. Generally, that was done on an aggregate basis. There was often disaggregated by certain geographies, but certainly not unit-level information. That was not something that was at least public.
How were people locked out though if they didn't have the data? So on their little, you know, what was it, COVID ID app?
Sorry, Senator, are you referring to individual vaccination certificates?
Yeah, those where you're on your phone and you had to scan or wave it to get into things.
So that is a combination of the Australian Immunisation Register as at the point of vaccination for individuals, and then those records are saved with your Medicare. So it's administered by Services Australia.
Okay, but you've just said on your bio, Department of Health, that you can access, Department of Health can access the immunisation register. So why can't you access the immunisation register when it comes to analysing excess deaths? Because that's very important as well, because we've had a jump of 10,000 in 2021 and a jump of 28,000 in 2022. So I would have thought that was pretty critical.
Yes. So to that point, the Department of Health is the custodian of the Australian Immunisation Register, so we do have access to that information. We've heard from the ABS and AIHW today about important data integration work that they've done. Ms Jordan also alluded to the fact that we have, through the person-level integrated data asset, which is managed by the ABS, we have linked vaccination status with cause of death information, ABS cause of death information. We have...
Sorry, did you say that again? You haven't linked vaccination status to cause of death?
That's correct, yes.
Okay, so we can then analyse deaths by vaccination status, is that correct?
That is correct.
Is that information publicly available?
So there's a couple of things to take into account here. The research that I was alluding to before, which analysed the effectiveness of the vaccines in protecting against death for Australians over 65, used that data set. And that was obviously referenced in the paper as the key source of information. As was discussed in a couple of the previous sessions, this data is person level, so the ABS have appropriate protocols in place to make sure that people access that in a secure environment. We wouldn't want that information. We need to protect people's privacy. There are mechanisms which the ABS has in place so that people outside of government researchers can access this data and produce their own research. I believe.
Can I access that? Sorry to interrupt. Could I access that? Can you take that on notice? Can I get access to that data, please?
That's not for me to decide. That's for the ABS to decide.
Could you at least show me how to ask for that data?
So we can certainly send you information which is online, which shows how researchers can go through the process of applying for access to that data.
Okay, so next question. One of the things I've heard constantly over the last 3 years is that there's no evidence to show that the vaccines were responsible for excess deaths. And I have to say I agree with you, or agree with that statement in large part for a number of reasons that we've just outlined, that excess deaths haven't been linked to vaccination status, but they were linked to COVID status. So clearly it's going to be easier to link a death to COVID than vaccines if you haven't got the link there in the first place. And as we go through the non-clinical report here, we find out that they never tested the distribution degradation of the S protein antigen, of the LNP lipids that were novel, of the DNA. They used a different manufacturing process, so there was no testing on the DNA. Do you agree that absence of evidence is not evidence of absence?
Can you say that again?
You haven't heard this term as a statistician?
I have.
Absence
I just
of evidence is not evidence of absence. So if you haven't tested for a lot of these things, of course there is no evidence because you haven't done the testing to establish if there's evidence or the evidence proves that there is no link.
In broad, that statement can be correct. I don't want to link that to anything specific.
Okay, right. So last question. You said earlier on that you can't necessarily take time correlation as a indication of evidence for causation, but reality is that temporal association is a significant indicator of causation, and within that time frame there, you've said that it's not unusual for deaths to jump around May. Generally, I've looked at that data series, they generally jump around July. So winter kicks in June, takes about a month with the secondary bacterial infection, so they generally spike in July, August, September. But the significant thing about the jump in deaths was this jumped in May, the month after the vaccine rollout. Deaths jumped, spiked, will cause mortality, that is, blunt that it is, and then it basically went through for the next 2 years. So there was no seasonal variance. There was just a spike, and it's come off a little bit, but it wasn't like a temporal thing associated to the winter. It was more temporally associated to the rollout of the vaccine.
As you noted, I'm a time series person, so I don't want to disparage the power of time series analysis. I think it's very powerful. In terms of the exact example that you're talking about, let's say the rise in mortality in May of 2021. If you took any given year over the last 10 years, it's very likely that you will see an increase in May compared to April, and you would continue to see an increase into the peak of flu season or season where we have respiratory illnesses. So that's a typical thing that we see. The way I would, as a time series person, one way that I might look at this, and I have actually taken a look at it, would be to say, well, the concept of excess mortality actually takes into account seasonal variation. So I would be looking at, rather than a spike or an increase in mortality during that period, rather than a month-on-month increase in mortality between, let's say, May and April, I would be looking at an increase in excess mortality, because that takes out the seasonal factors that we normally see.
But isn't that agreeing with what I just said, where we've just had a big jump and it hasn't really come off at all? So,
well, to give some numbers which I think are quite useful, these numbers are based on the ABS weekly reports, and the challenge with the ABS weekly mortality numbers is it's hard to align them directly with a month, but doing my best to do that. If you look at excess mortality in 2021, between January and April, that was running at 1.9%. And after May, it was running from May to December, post-vaccine rollout, it was running at 1.2%, so it was actually lower. We have as well talked about potential reasons for higher mortality in 2021, and one of those reasons is the concept of death displacement, which we would expect to see, particularly coming off the back of a relatively low mortality year in 2020, indeed one that had negative excess mortality.
Yeah, except we had lockdowns again in 2021, but I'll leave that as a statement. Thanks, Chair.
Can I just add add one thing to that? Just also in 2021, we did see, according to the National Notifiable Disease Surveillance System, over 500,000 COVID cases. So there was COVID at that point in time.
Senator Roberts.
Thank you, Chair, and thank you for appearing again today. Just on the last question that Senator Rennick asked Dr Gould, could you have a look at graph number... Are you familiar with the Australian Bureau of Statistics submission?
Yes. If you just give me a moment, I will fumble on my iPad to have that. Yes. What page, sorry, Senator?
It's on page 7 of their 14-page submission. Top of the page, graph 1. Yeah, that's... No.
Yes.
Have you done any work on trying to understand and explain the first peak in March 2021 and the next peak in August 22? Can you tell me the causes of those peaks? Take it on notice if you want.
I'm not actually seeing a peak in March 2021.
You're not seeing the actual deaths?
Yes, I'm looking at the same graph as you, I believe, with expected actual.
There's a peak well outside the upper range.
Oh, yes, okay. There is a small...
It's quite marked.
Period. So the graph that you see, the expected mortality is a modelled number. We've talked about this before. And as with any modelled number, it has strengths and weaknesses, so that's acknowledged.
Yep.
There are a number of different
This
ways.
is a startling peak.
Yeah. So
is that all due to the model?
The peak you're referring to is a peak because it goes above the confidence intervals of the model. So it is a function of the model, and it is also a function of
it is
the mortality.
way above.
I'm concerned that we're looking at different information. I'm not seeing a large peak in 2021.
End of February, early March 22.
Okay. Oh, 22.
I'm sorry.
Yes.
I'm sorry. Yeah, you're right.
Yes.
What's
the
explanation for the big peak there?
So you see a very significant peak with the actual number. So that's the dark red number, and that represents total mortality over that period, and it is higher than expected. Importantly, this graph also shows what it looks like without COVID. So that's the sort of, dare I say, salmon-coloured or the pink-coloured line, which is a much less dramatic peak. So that indicates how much COVID itself contributed to that large peak. That said, I would acknowledge without COVID, the light pink line is still outside of normal expectations, so that would be considered a period of excess mortality.
Have you done any work on explaining why that's the case? It's above the mean of the range and it's above the upper limit? Yeah, so
again, the ABS reports look at different causes of death.
Okay.
Complementary analysis from, say, the Actuaries Institute also looks at potential causes there. That includes ischemic heart disease.
So we go to the ABS?
Pardon?
We go to the ABS?
The ABS is a very good place.
Thank you. Now I want to follow up on a question that I didn't hear that you answered from Senator Rennick, and that built in turn on something I asked earlier in the second session. The Australian Bureau of Statistics revealed in estimates last week that it's possible to match ABS death data against COVID vaccine status to see what the respective death rates for vaccinated and unvaccinated Australians are. Have you done that analysis? I didn't hear you respond to Senator Rennick.
Again, it's the same concept where I was talking about the time series analysis. We need to be really careful about producing... I will get to that. Producing raw death counts, mortality counts by vaccination status is a very limited value. Obviously, the counts we would expect to be higher for vaccinated Australians because the vast majority of Australians were vaccinated. So we need an appropriate denominator.
Sure.
So that work needs to be done. We also need to...
Excuse me, Dr Gould, you can still have comparison of people who've had 1 vaccine, 2 vaccines, 3 shots, 4 shots, etc.
Yeah, and what I wanted to get to, so you could do that with raw mortality rates, but as we've discussed, age is a really important factor for mortality, so age standardisation is really important there. But there are other forms of work that we need to do to ensure that we're comparing like populations with each other. So effectively we're comparing statistical apples with each other. And that was the whole purpose of the research that we commissioned by the National Centre for Immunisation Research and Surveillance, that they could do that challenging but really critical work so that they could give a better sense of the mortality outcomes for people. So the answer is very clear that COVID vaccines provided significant protection against mortality from COVID. They also extended that research to all-cause mortality. As we've said, COVID was a large contributor. Can we get a copy of the report, please? Absolutely. It's publicly available. We'd be happy to send you a link for that. I can't quote the exact web address, but it's...
When did you ask them to do that report?
I believe the date is current to 2022. We could take on notice when we started conversations around this report.
Yeah. What is the death rate comparison amongst vaccinated and unvaccinated Australians? I know you said there are many qualifications, but filtering through the qualifications, what's the death rate?
It is lower for vaccinated Australians.
Could we have those
numbers, as per
please?
that research. The way they describe it is actually in terms of the protection or the protection against death from the... Just
one moment, Dr Gould. Senator Roberts, just the last 5 minutes, you've been interrupting quite regularly while they're answering. If you could maybe wait till they finish and then ask your next question.
Thank you. I think that research should answer a lot of your questions.
Last question. It's 5:10.
Has anyone ordered you not to analyse deaths, excess mortality, or to do so in a certain way to hide anything?
Absolutely not.
Okay. Thank you, Chair.
Senator Babbitt.
Thank you, Chair. Now, Dr Gould, you mentioned the need to be cautious about temporal trends when analysing mortality data. For example, with an expected upturn in April, Dr Andrew Madry performed an independent analysis of Queensland data. Have you seen this?
I would appreciate if you were going to refer to it in detail, if it could be tabled.
That's okay. I'll put that in on notice for you. You can get back to us. Now, Dr Madry, he carefully adjusted for seasonal variation, and yet he still found an uptick in excess mortality in the second quarter of 2022 in Queensland. This was after the vaccine rollout commenced, but 8 months before there was COVID in Queensland in a year with very low influenza. Now, I'd like to know if this temporal relationship concerns you, and you can get back to me on that one a bit later on.
Sure. Can I just clarify there that you're saying this was in the second quarter of 2022? And
second quarter of 2022.
Right, and you said that there's no COVID in the Queensland community at that point?
8 months before COVID.
So you're saying that COVID only came into the Queensland community roughly late 2022, early 23?
Yeah.
Okay.
I'll put it in on notice and we can have it out. So when the department reviews the Pfizer data, did you discover undisclosed or hidden deaths, especially in the vaccinated arm of the Pfizer trial? If you did, is this a breach of good clinical practice?
These matters have been discussed before in this committee. I don't have anything to add to answers which have previously been given on this topic.
Okay. Could you provide us on notice pre-market placebo randomised studies of transmission with case tracking and finding? And, we don't want any non-randomised studies in the list, please.
We will do our best to find such studies. I can't confirm how many we will find, but we will have a look at that for you.
Thank you. In your submission, You deny any credible link between COVID-19 vaccination and excess mortality. You say that there is no credible evidence to suggest that COVID-19 vaccines have contributed to excess deaths in Australia or overseas. You refer to a study published in the Lancet medical journal titled Effectiveness of COVID-19 Vaccination Against COVID-19 Specific and All-Cause Mortality in Older Australian, a population-based study. The findings of this study have been publicly rebutted by Australian subject matter expert. The study states that the vaccination is highly effective but wanes over time. Tell me this, can a vaccine be highly effective but only for a limited time? And if so, how limited?
It's not something which is a point of contention at all, that we've been encouraging people to stay up to date with their doses as part of our public health messaging to say you need to be up to date. So the effectiveness, the protection has waned over time. What we have seen, which is really important here though, is with increased what we call hybrid immunity, which has been brought about by the result of a combination of vaccines and previous COVID infection, that the general level of protection, let's say, in the community is naturally higher, even without regular updates to vaccination. So we've got a higher natural level of protection.
Okay. Last question? Okay. I might yield there and we'll call it quits, and I will submit some questions on notice for you.
All right, thank you. Thank you very much for your evidence today. The committee will report to the Senate on the 31st of August 2024 and request that answers to questions taken on notice are provided to the committee secretariat by close of business on Friday, 21 June 2024. Where am I up to here? That concludes today's hearing. Thank you to all witnesses who appeared and to Hansard and Broadcasting for their assistance. Again, the committee has agreed that responses to questions on notice should be provided by Friday, 21 June 2024, and the committee is scheduled to table its report for the inquiry on 31 August 2024. The committee stands adjourned.